Bhubaneswar. Yesterday, we had an extremely insightful first day with a deep discussion spanning the entire diabetes care continuum. From understanding obesity as a disease to navigating nutrition management in diabetes, liver and renal disorders, and finally addressing the evolving challenges of type 2 diabetes with CKD. Day 1 truly set a strong clinical foundation for us. The engaging panel discussions and expert interviews highlighted one clear message: diabetes care today must be integrated and centric and evidence driven. Building on those learnings, day 2 will take us a step further, focusing on optimizing pharmacotherapy, advancing metabolic care, and exploring newer approaches to weight management and insulin therapy in real world. With this context, we now begin session 6 titled Future of Oral Antidiabetic Drugs, organized by USV Pharmaceuticals. To formally commence the session,
Recording in progress.
May I request our esteemed chairpersons to kindly take their places on the dais. I invite Dr. Ashok Kumar Das, Professor Emeritus, Medicine and Endocrinology, Dean Academic, Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapith, Pondicherry, to please join us on the dais.
Dear friends, we will start the session with a recap of what happened yesterday, because I considered yesterday was a very good day, and I'll take only 2 minutes to say what happened yesterday. Dear friend, yesterday's entire deliberations was addressed by many people, thousands in number, and we started with the inaugural oration. And the inauguration was done by no less a person, two of our teachers, Professor K.C. Samal and Niranjan Tripathi, and all the speakers spoke about it. We also had a participation by the multinational giants and their scientific advisors, their MDs. Followed by that, we had the Padam Shri Binod Kanungo Memorial Oration. It was a fabulous oration by Dr. Keshavdev, who is an authority on the technology, and he took us to a new world of insulin pumps and the automated insulin delivery. It was very much appreciated. Then there were 5 sessions. First session, modern therapies, therapeutic approaches. It was centered around very important issues like MASLD, heart failure, on the synergy between a combination of gliptin and sulfonylurea, like vildagliptin and metformin, and the verified trial and what is beyond, and from the durability to the glycemic control. We had the most important duo, the linagliptin and the empagliflozin combination, by the first session. Second session was centered around very important issues about the technological advances in diabetes management. We had contest setting by Manoj Chawla, who from Bombay, and Shishir Babu from our place. It was the balancing of AI in diabetes management. Believe me, friends, it was by the chairperson of the AI in India. He also leading the AI in the IDF, and his talk was fabulous. He took us to newer directions, starting from the big data analysis to the issues related to the AI in the diagnosis, in the management, in the retinopathy, in the glucose control systems, and took it how it is also applied in the various AID and technological advances. And after Amit Dey, the chairperson of the AI for our country, then we had the CGMS data. Then we had the diabetic food technologies, and BJ Vishwanathan from Chennai joined. He told the best technology is to look at the patient and look at the feet. He also spoke about new technologies, that is intra-SOX technology, the new debridement, new negative pumps, single-use negative pumps, and all the things in diabetic foot therapy. And the next session was a complication. It was chaired by Srikanth Dhar from the SOM Medical College. And we had the the proverbial speaker, Sonugobelu from Trichy, speaking about the CKD, the CKM, the diabetes, the heart, kidney, and the metabolic control with the newer drugs, what is the importance of it. We had a full session on the prevention and therapy for the MASLD. And Rakesh Shahai, Sambit going to occupy that position shortly. The previous president of ESI, he addressed us very beautifully, followed by, I had an interview, very interesting interview, and Alok said, we'll broadcast it again and again, with Dr. Deepak Jumani regarding the sexual function, both in males and females in diabetes. It was a fabulous session. Then we had GDM, an update, and by Dr. Sunil Gupta, and we had every session had an interview and panel discussion. The last but one session was on the obesity. I had interviewed Briz Makkar on the BL, the very low calorie diet and the keto diet. You know, Briz Makkar is now entirely obesity focused, followed by talk by Nita Deshpande of Belgaum. We had Dr. Nitin Kapoor, and believe me, Nitin Kapoor gave a beautiful talk. 17 questions I asked him, and all this very practical, clinical. I request, we want to bring out this year a booklet. Sambit, you'll be in time. Absolutely by 11, 15:30 will be all. So Nitin Kapoor gave 17 questions and beautifully answered. What should be done? Why 120 ml? How 121 ml makes 1 ml down the intestine. Therefore, the snack cannot work well. He was a beautiful, fabulous talk. And following Nitin Kapoor, we had the panel discussion. Then he had the last session on the nutritional management, where I interviewed Dr. Briz Makkar, and it was addressed by two people, Pratap Behra, our gastro, and also by Srirang Bichu, was very good. He is from Beach Candy Hospital from Bombay. He spoke about Bombay Hospital, and he spoke beautifully about our Alok's contact, and he spoke beautifully about the renal diet in diabetes. CKD is increasing leaps and bounds. And dear friends, we had a beautiful panel discussion with Rakesh, Pratap, Srirang, and all of us. There's a special session at the end, and that special session was about about the type 2 diabetes and the CKD management. Alok gave a talk in the beginning for about 10 minutes. What is the importance of CKD? Followed by Kalyan Ganguly fame of Calcutta, who spoke about the 2026 vision of managing type 2 diabetes with CKD, optimizing the prevention continuum. Believe me, this guy put one chart, all the CKD trials of the UCAR and EGFR. Remember? And on that, he developed 40 slides, and it was beautiful. He spoke about perinephric fat stranding, and he spoke about everything. I wanted to give a glimpse of it. Thank you very much. Now it's my great pleasure and honor to invite Sambit, to speak on a very important topic, that is diabetes distress. I'll be very brief. To say that Sambit, I had been to his institute. He invited me to see his department. I gave a talk to his DM students. He is the presiding officer of all that happens in the kids, and he is the person who is heading the department of endocrinology and taking to newer heights. The Urdu son of my teacher, and he has kept the flag flying high. I will not take a long time, but I must tell you, it's fabulous. And with God's grace, he will go to the highest heights of the endocrine society. And the topic he's speaking about is very important, and we have we experience it every day. So I present you, dear friends, Professor Dr. Sambit Das, for a talk on diabetes distress stemming from bad glycemic control. Sambit, all is yours.
Thank you, sir, for those kind words. Respected Ashok Das sir, respected Kanungo sir, it is really an opportunity to give a talk in any city. So without wasting much time, I'll go to the topic proper. That's a missing link in diabetes care, addressing distress through the glycemic focus. So it's a USB sponsored talk. So the agenda is like, I'll be discussing about what is diabetes distress. Then, for a short few slides, I'll discuss how the triple drug combination is actually helping in reducing the diabetes distress. So the alarming rise of uncontrolled diabetes is not new to this August gathering. So more than half struggle with control. Around 60% of Indian type 2 diabetes have HbA1c of more than 8%, indicating poor glycemic control despite therapy. Prolonged hyperglycemia raises the risk of micro and macrovascular complications that we all know. And younger patients are especially vulnerable to longer disease duration and cumulative glycemic burden. And we have good publication to suggest that younger type 2 diabetes have got more complication compared to any age of diabetes, type 2 diabetes. So factors contributing to uncontrolled diabetes are, it is the patient level inertia definitely, but therapeutic inertia is very important. And the clinician, many times they don't start the drugs at the proper time, neither they titrate it. Medication non-adherence is another big problem. Inadequate education. So inadequate education by the patients, limited access to specialty cares, and dietary challenges. So these are some of the factors that are very important for not controlling the diabetes in a proper manner. So what is diabetes distress? So this is basically an emotional burden related specifically to living with diabetes. Remember that it's not anxiety or depression per se, it's a separate entity altogether, arises from daily self-care demands and perceived failures. So the patient is concerned about daily managing the diabetes, and also he or she thinks about he or she may fail in due course of time. So distinct from depression and anxiety disorders, it includes emotional burden to the patient, regimen related distress. So if you make the regimen more complex, it will be more distressful for the patient, and interpersonal distress. It affects almost 30 to 45% of people with diabetes, though we think anxiety and depression predominates, but definitely this entity per se is one of the major psychological problem in patients living with diabetes. It is strongly associated with poor glycemic control and reduced self-care behaviors. Now, let us see what is the vicious cycle of how poor control fuels distress. So, whenever the glycemic control is poor or due to many factors, we have not been able to control the diabetes, we'll end up in increased distress. And this increased distress can lead to elevated HbA1c, and there is a poor therapeutic adherence. And that leads to again the vicious cycle. And this vicious cycle needs to be broken. And we must address that diabetes distress is one of the core factor in this vicious cycle. Now, discuss something about young onset diabetes, and we have published a review on young onset diabetes, type 2 diabetes, and they have a real burden because the microvascular, macrovascular complications are more common in people living with diabetes who are less than 40 years of age. So patients diagnosed with type 2 diabetes before the age 40 represent a particularly vulnerable population with psychological distress. Higher complication risk, studies have shown there is increased chances risk factors with people living with diabetes less than 40 years of age, greater diabetes related distress prevalence. Studies indicates 45 to 60% of younger patients experience moderate to severe diabetes related distress and longer disease burden. So the intersection of aggressive disease biology, lifestyle stressors, and prolonged treatment burden makes this population especially susceptible to both metabolic deterioration and psychological distress. So implication of diabetes related diabetes distress impacts glycemic control. There is a reduced motivation and poor adherence, and that finally leads to higher distress. What happens if we control the diabetes distress? There are studies which have shown that if we control the diabetes distress, we improve the self-management, it improves the glycemic control, reduces the risk of complication, and supports the mental health. The ESD has come out with a recent document which I was just talking to sir. That was a 2026 ESD evidence-based clinical practice guideline. discuss the relevant members of the healthcare team. So if one healthcare team has detected, then it should be noted and kept in record. The physician should identify, make a joint plan with the person living with diabetes about the next steps, how they should go. It should have the competency to offer psychological support to those experiencing diabetes distress. But again, as a physician, we are not psychiatrists, so we can use simple questions, open-ended questions to ask what is diabetes distress. But most important, as an endocrinologist, diabetologist, physician, what we can do is we can reduce the complexity of the regimen. We can control the HbA1c properly so that the diabetes distress itself comes down. So the implementation and impact of the guideline, there are barriers because in India, especially, we see 50 to 80 patients and average quite a huge number of patients per day. We do not have time to assess the diabetes distress. Insufficient access to mental health services for reference. Facilitators growing awareness of mental health importance and shift towards person-centered care. So this guideline have facilitated that. And guideline contribution is that provides foundation for professional training. Maybe we can spend some time, or our team member can spend more time on assessing this particular condition. And the conclusion that offers a timely essential framework for addressing the distress, and we have to break that vicious cycle where diabetes distress is actually contributing to poor glycemic control. Indian context, the dual burden of hypoglycemia and distress, high baseline A1C, the distress amplifier. Indian studies, the distress HbA1c correlation has been there, and there is a dose response relationship between how much is your HbA1c and how much is your diabetes distress. And it is 3 times higher distress in patients with A1C of more than 10% versus who have HbA1c between 7 to 8%. It is consistent across age, socioeconomic, and treatment groups. Remember that it is not related to socioeconomic status. Maybe higher strata can also be affected with diabetes distress. Glycemic control is the key modifiable factor, and we should address that. Root causes of DIT in the Indian context, it's the poor glycemic control, cultural stigma, treatment costs, healthcare access barriers, limited patient education, and all these factors lead to diabetes distress. Optimizing glycemic control, as I've stressed from my first slide, it is very important, and we can do it. We may not address the diabetes distress properly with all the other factors, but at least we can target the glycemic control in a nice manner. So early intensification and rationale for high HbA1c patient, we should address. We all know that good glycemic control from the very beginning gives its dividends later on in the life. So rapid glycemic reduction is very much important. We should simplify the regimen. We can combine 2 or 3 drugs in one pill, and fortunately we live in India where it is available. In US you may not get 3 drug combination or 4 drug combination, but we have at least 3 drug combination which are available. So it simplifies the regimen. It reduces the cost also, and psychological benefits are also reaped in that. Diabetes combination therapy, I'll just give 1 or 2 slides on the combination therapy of metformin, sulfonylurea, and DP4 inhibitor. So metformin, we all know it's highly efficacious. It doesn't lead to hypoglycemia. It has got cardiovascular advantages. GI effects are the major problem, but it can be mitigated very nicely. Sulfonylurea, we know it is one of the most potent drug, reduces the HbA1c significantly. If we use it properly, then you may not land in hypoglycemia. DP4 inhibitor is absolutely a fabulous drug. You can give it any person without any contraindication. It maintains the glycemic control in a very nice manner without producing hypoglycemia. So what about this combination? So this is just a slide on triple therapy, glimepiride, metformin, and sitagliptin FDC. And we know the individual component of that, and we also know how they reduces the HbA1c. And in one of the studies that has been conducted in India, they have found that 2 to 2.5% reduction of the HbA1c with this triple combination therapy. In one snapshot, I got a very long slide of this triple drug combination, but I just wanted to be brief and just wanted to show this one slide. This is a study where they've done a triple drug combination of glimepiride, metformin, and sitagliptin, and they've divided into 2 arms. One arm they have given glimepiride 2 mg with metformin 1000 mg twice a day. The other arm they have given sitagliptin 15 milligram, glimepiride 1 milligram, and metformin 1000 milligram twice a day. And the important thing which I wanted to highlight, I don't want to go into the study proper, but see the people where they have divided into people who are less than 40 years or people who are more than 40 years. They found that people in those who are less than 40 years in their age, the HbA1c reduction is to the tune of 2.43%, whereas those people who are more than 40 years, it is around 1.66%. So that shows that probably younger group of type 2 diabetes, which have more diabetes distress, who have more chances of complication, fortunately they respond to this combination with a better HbA1c reduction. So that was just the one slide I wanted to show. I'm not going into this metformin DP4 sulfonylurea. We all know that metformin DP4 advantages. Sulfonylurea, we are always concerned about the hypoglycemia, but again the modern sulfonylurea like glimepiride or glyclazide have got lesser chances of hypoglycemia if properly used. So the triple FDC, a game changer in glycemic and emotional control, because if we initiate with the triple therapy, we rapidly achieve the HbA1c, we improve the adherence, and we reduce the distress. And combinedly, it reduces the diabetes distress. So coming to my last slide, that is unmasking the diabetes-related distress. DRD or the diabetes-related distress is a different entity from depression and anxiety. It is often non-recognized. Poor glycemic control is the primary driver for that. It leads to a vicious cycle where there is a poor glycemic control. Early intensification breaks the vicious cycle. And if we are using some kind of simplified regimen like what I have told, then probably we are going to benefit at least that much we can do. But as for the ESD and the international guideline, they also tell that your team members should assess the diabetes distress with the proper tool. So with that, I'll end. Thank you for the patient.
Thank you.
Thank you.
Beautifully spoken. I just want to make one comment. I mean, it's not a question. That we know about acute glycemic and long before, first year I studied in the year 1985, said that they do not know whether that day they did not know the DPP that had come. They said at least good glycemic control gives you a sense of well-being.
Yes.
So I think you have beautifully highlighted it. And India is a country of it. They make the tablet cheaper. First seat, second seat, the people find it convenient to take. And third, of course, very good compliance. Thank you very much.
Thank you.
Next. No.
Next speaker is none other than Dr. Abhay Sahu. What Chief Consultant Department of Endocrinology Hospital, Organizing Secretary of ASICON 12, 18, 16, Co-Organizing Secretary of 14 and 16, Investigator in 3 ongoing international trials, multiple publication 44, posters 12, and paper presentation 12 with written 5 chapters in different books. He doesn't require much more. He will be speaking on escalating wisely the add-on approach with the SGLT2 inhibitors plus DPP4 inhibitors, fixed dose combination to overcome therapeutic gaps. Professor Sahu, please.
Yeah, thank you, sir. And thank you, sir, for inviting me to give a talk on this topic in Nucd here. And I'm sorry for that, because we have a picnic today, so I'm sorry for that. Thank you. So the add-on approach with SGLT2 and DPP4, in particular, overcoming the therapeutic approach. So we'll discuss about the background. What are the limitations of glucocentric approach? What are the I will discuss about the bridging the therapeutic gap with SGLT2 DPP4, and what are the evidences, and then we will have conclusion. So background, we know there is high burden of diabetes. Also 40% of diabetic patients have high cardiovascular risk, and CV disease is the most common cause of death among the diabetic patients. And shift needed from glucocentric to actually it should be organocentric or should be complication centric. That would be important. That is cardio, renal, metabolic. If we are actually targeting all, then probably we are having a holistic approach for management of diabetes. So If you see the problem statement, there is a persistent CV mortality despite of good glycemic control. And again, the most important thing is therapeutic inertia, because we know from the beginning, we start with a single tablet, still not controlled. We increase the dose, still not controlled. We add some second tablet, not controlled. We add going on and third tablet. So in that way, there is a long time where actually the blood glucose is really not controlled. And that initial high HbA1c actually is a driving force for particular development of complications, as we know, Wikipedia has clearly shown that. And there is limited adoption of combination therapies having proven safety benefits. So again, we as a ASEAN, we know that actually we are a bit different from the Western population, because even if with same body weight, our truncal beta cell dysfunction is much higher. And the reason is there is truncal obesity, there is high insulin resistance, there is strong family history of diabetes. We have actually younger age of onset. We have actually early cardiovascular disease. We usually take very high carbohydrate diet, and also we have a sedentary lifestyle. So all those actually are the driving force for the early development of diabetes, early development of complications, because if we compare with Western population, we developed almost complications 1 decade earlier than the Western population. So that is the reason why actually, despite of same body weight, our fat and everything is particularly different. We have a genetic predisposition, of course, is there. And again, if you see the fetal programming, maternal malnutrition, low birth weight, which actually in later on increases the metabolic risk factors, because this is, we know, this is the Barker's hypothesis, which has clearly shown that. And there is again urbanization with sedentary lifestyle, refined carbohydrate at high stress plays a critical role. And again, there is nutritional transition, because now from low protein to we are actually going to high carb diet, because all those junk foods which is available, everything is high carb and high fat diet, which ultimately leads to a significant increase in obesity. And also there is additional stress on the beta cells, which actually further predisposes development of diabetes. Again, as we have discussed, we have a younger age onset, even if low BMI threshold, and there is a high risk of all those complications, diabetes, dyslipidemia, MSLD, and metabolic syndrome. Everything is significantly high among those things. So we will see the comorbidities. We know among the diabetes, 84% have more than one comorbid conditions, and these are the comorbid already have discussed: obesity, hypertension, dyslipidemia, obesity with hypertension, obesity with hypertension, dyslipidemia, hypertension and CKD, only hypertension and hypertension with dyslipidemia. All those combinations might happen. This is the real-world evidence of glycemic control in the patients of diabetic patients. This is the digit study, which is actually clearly shown that TITE has shown that it's a retrospective study from 2015 to 17, which has taken close to 55,000 people, which has clearly shown poor glycemic observed in close to 77% patients have very good poor glycemic control, and that almost 3/4 of the patients you can see, and the mean HbA1c was 8.5, and there is a significant proportion of patients is either on monotherapy or dual therapies. And you will see the comorbidities like hypertension, dyslipidemia, obesity, that is again found to be significant high among those group of patients. So the limitations of glucocentric already I have discussed. It is focused on only HbA1c. Some glucose-lowering agents lack CV protection, and that is we are missing the opportunities of early comprehensive care if we are using only or targeting only glucocentric approach. So what are the how we are going to bridge these therapeutic gaps with particularly these drugs? Because we know SGLT2 inhibitors, it has multiple effects. It has direct effect, it has metabolic response, it has osmotic diuresis and acidosis. Again, it has direct effect on kidney. All those things actually gives positive benefits from the cardiovascular point of view, positive benefits from the heart failure point of view, and also positive benefits from the renal point of view. So this is actually a slide which has clearly depicted everything. What are the basic postulated mechanisms of SGLT2 inhibitors, how it gives protection. It has actually decreases cardiac hypertrophy, fibrosis, so cardiac efficiency increases. It increases the tissue oxygen delivery. In actually, there is in the direct renal effect, where it's actually multiple glomerular pressure is reduced, albuminuria is reduced, renal growth factors and inflammation is reduced. Everything actually plays a critical role for particularly giving renal protection. So the evolving role of SGLT2, the Indian phenotypes, people see the challenges. We have high abdominal obesity and visceral fat. Again, that is a weight loss of around 3 to 4 kg with particular use of SGLT2 inhibitors. We have higher waist circumference and waist hip ratio. Once there is weight loss, of course, there will be some sort of decrease in the waist circumference will happen. There is low level of adipokine and high plasma leptin, which increases the triglyceride level. Again, directly, SGLT2 inhibitors has pleiotropic benefit, which actually causes decrease in the triglycerides. There is low rate of glucose disposal. Again, there is some glycosuria, so this glucose disposal will improve. And there is impaired insulin secretion and increased insulin resistance. Again, it improves beta cell function and also decreases insulin resistance. So, if you see the particularly Asian phenotype, probably everywhere we are also giving benefits from particularly use of SGLT2 inhibitors. Again, from the DP4, we know this actually acts on the GI tract, DP and inhibits DP4 enzyme. So the endogenous GLP-1 which is secreted, that will be supraphysiological. That means almost 2 to 4 times higher than the normal GLP-1 which is there in the body. And that's the way how actually DP4 increases the GLP, and GLP acts on the beta cells to produce increase in the insulin and decrease in the glucagon in particularly those groups. So once we are combining together from the SGLT2, we are getting benefits from the kidney, there is the glycosuria. In DP from the intestine, there is directly incretin effect. But in pancreas, there is dual. Pancreas in SGLT2, there is increase in the insulin secretion, but there is increase in the glucagon. But if you are using DP4, there is increase in insulin or beta cell function, but glucagon is reduced. So the glucagon increase property of actually SGLT2 is being actually neutralized or nullified once we are adding particularly DP4 inhibitor. So ultimately, there will be good glycemic control. At one side, there will be decrease in weight and decrease in the body weight and also decrease in the blood pressure. There will be decrease in the favorable lipid profile will be there, and also there is weight. DP4, we know there is weight neutrality. So these are the major CBOD trials. We know EMPIRIC, ANVAS, and DECLARE all has actually given positive benefits from the heart failure point of view. And if you see mortality benefits, of course, EMPIRIC has given mortality benefit that has not been got from the particularly this particular DECLARE to me. The reason is the population which has been actually included in the study, because in EMPIRIC, 100% people have already having some sort of cardiovascular disease, whereas in DECLARE to me, 60% is having for the primary prevention. So that is the reason actually one of the reason where mortality benefit not got, but all are invariably got cardiovascular benefits from the heart failure point of view. And again, all three are actually found benefits from the renal point of view. All significantly reduces albuminuria, all significantly reduces the progression of decrease in GFR. So everything point of view also, all three has given positive benefits. And from the secondary outcome, renal outcome, everything point of view actually they have given benefits. And 3-point MACE all has given positive benefits or significant statistical significant improvement from the 3-point MACE point of view. Again, so DP4 and CKD, if you see, probably the drugs we know, except Saxa, there is increased incidence heart failure we know, but from the cardiovascular point of view, probably linagliptin and sitagliptin has dedicated trial which has clearly shown there is cardiovascular neutral, there is no increase in the cardiovascular mortality. And of course, vildagliptin, VVD is a very small trial, but no dedicated trial. But of course, there is post-marketing trials which is showing indirect evidence of cardiovascular benefit, but of course, dedicated cardiovascular trial is not with vildagliptin. And penligliptin, of course, there is also no dedicated trial for that. And because clearly shown, there is no increase in the heart failure, and it is neutral from the cardiovascular point of view. There is no increase in heart failure, and there is no increase in the hospitalization due to heart failure, and it is neutral from the cardiovascular point of view. So again, TICOS is safe or sitagliptin is safe from the cardiovascular point of view. So if you see the cardioprotective action, of course, as I have clearly shown, there is neutral from the trial as clearly shown. But again, there are some anecdotal studies which has given some markers, improvement in the markers, like there is anti-inflammatory, there is decrease in the oxidative stress and improves nitric oxide viability, decrease in the liquid accumulation, and also there is anti-apoptotic. But again, these are some of the small studies, but the dedicated cardiovascular trial has clearly shown that it is neutral from the cardiovascular point of view. Again, if you are combining together, this is actually, of course, there is this is the real world study with particularly this trial, more than 50 centers. And this is population close to 360%. Mean age is 56 years and baseline age is 8.9. and they try to see what is happening to HbA1c, fasting and postprandial, and secondary outcome is change in the body weight and additional parameters. So DAPC has clearly shown that usually all sort of comorbidities there with particularly those group of patients, I think. And in patients with risk factors like smoking, obesity, sedentary lifestyle, family history of diabetes, all has been actually taken. And if you see the fasting PP reduction, that is a good fasting and PP reduction. From fast, you can see there is significant change. Again, HbA1c is also reduced significantly, up to 1.7% reduction is there with HbA1c in particularly this study. So again, from the fasting PP reduction and HbA1c reduction is quite significant. There is no confusion with this combination. And key highlight is if you are combining DAPA-CETA, then in the diabetic patients, then there is a significant HbA1c reduction, body weight reduction, and BP reduction is there. It is giving glucose and weight reduction, potential cardiovascular and renal protection, promotes better cardiometabolic outcomes, and it is very much safe for use in those patients. Then if you are combining cardiovascular and SGLT2 together, this is the Bridge DS study. Again, it is a retrospective study taking close to 170 patients. Average age was 56 years. And there is hypertension, dyslipidemia, and obesity always there, particularly in those group of patients. Again, Bridge has shown that this fixed dose combination enhances good glycemic control with help in actually improvement in the heart failure. And also there is improvement in HbA1c, fasting and PP, all has significant improvement. That is decrease in NT-proBNP is reduced. There is blood pressure and diastolic, both systolic and diastolic blood pressure is significantly improving. So again, this is another study with this fixed dose combination which are given benefits from that point of view. Again, this is DAPA-CETA combination. You will see the modifiable risk factors. All those has clearly shown that there is giving some sort of cardiac protection, and there is improvement in the modifiable risk factors from that DAPA and CETA point of view. Again, renal point of view, you will see. Then this is the DAPA kidney trial, which has clearly shown. We everybody in this August gathering know DAPA CKD trial, which has clearly shown there is significant improvement in the microalbuminuria. The deterioration of GFR is actually stopped, or there is some increase in the GFR, particularly use of dapagliflozin in this trial. Again, this is sitagliptin reduces there is the study which has clearly shown sita and lina are the two drugs which is giving improvement in the microalbuminuria. There is no trial with particularly with vildagliptin and saxagliptin. So again, sita lina has trial, there is numerically reduction in the microalbuminuria is there in particularly use of this drug. So if you are combining together, both, you know that Sir has already told 3C, if you are combining for particularly fixed dose combination, the compliance is one of the important factor. Cost is another factor for Indian population because we know everybody is paying from our own pocket. And another important thing is that it is additive effect. It's not actually like 1 + 1 is 3 like that if you are combining together. So that is way how it is giving benefits to them. Again, if you are approaching the initiate the lifestyle modification among the treatment naive patients, if baseline HbA1c is more than 8, you can directly start this combination therapy. Already with metformin, then if HbA1c is more than 9, you can add this combination directly after metformin. And if someone is uncontrolled or there is actually not tolerating metformin, you can stop. HbA1c is more than 8, you can directly go for this combination, and single tablet can take care the HbA1c, not only HbA1c, it will give cardiovascular and renal benefits. Again, this based on the glycemic control, if uncontrolled with metformin plus second line drugs, again, you can add this. Already second line is, suppose someone is on DP4, you just add SGLT2 or you stop DP4, add this combination, that will take care. Uncontrolled on metformin plus second line therapy, except DP4 and SGLT2 is there. Any other combinations there, you just add a tablet and that will reduce HbA1c. Additional HbA1c reduction will be close to 1.5% with a single tablet. Again, this is safe with use insulin. Any sort of insulin combination is there. This combination can be safe. DP4 and SGLT2 can be safely addressed or can be given to particularly those group of patients. Based on the heart failure point of view, again, as clearly shown, SGLT2 is giving significant benefit from the cardiovascular point of view. I have shown sitagliptin and linagliptin are the two DP4 inhibitors, which are a dedicated trial, which has clearly shown it is safe from the heart failure point of view. So again, this combination can be safely given from particularly this point of view. As HbA1c criteria, SGLT2 promotes weight loss and DP4 is weight neutral. So from the weight point of view, again, we know upon combining the weight loss property of SGLT2 is well preserved even if you are combining this therapy. So from the weight loss point of view, again, there will be 3 to 4 kg weight loss will be there if you are combining together in this group. So take home message, dual action. Again, I am forgetting, if you are combining together, there is another important thing is the complications which is there with particularly SGLT2, that is vulvovaginitis or balanoposthitis, that is also found to be significantly reduced because we have a meta-analysis with dipronjos which has clearly shown it has reduced, because the reason is DP4 gives some sort of protection, or there is inhibits the growth of some of the bacteria and also fungus due to presence of DP4 enzyme in them, and that gives some sort of protection from the complication or reduces the complication balanoposthitis and vulvovaginitis once you're combining together. So that's dual action, complementary glucose lowering, better control of HbA1c. It gives cardiac protection, like decreases heart failure, slow CKD progression. Again, metabolic gain, like reduces weight, reduces blood pressure, improves cardiovascular profile. Again, it is found to very much safe, and it is very much well tolerated with particularly those fixed dose combination. Thank you.
Okay, superb. And even in a very short time, you have given us how this unique combination stands tall in the process of you preventing complication, giving complementary benefit, and giving mortality benefit, and giving cardiac benefit, and must be used because it is safe and simple. However, I strongly believe we say fill up and forget. You prescribe this because they don't produce hypoglycemia.
Absolutely.
So, dear friends, I must tell you that FDC, we have been asked to send people to UK and Colombo because they want to adopt FDC in their pharmacopoeia. So, dear friends, thank you. I'll request Professor Arungo to give some comments.
Thank you, Abhay, for a very nice practical talk. After dapagliflozin was this generic came, real world experience became enormous. The whole country started writing dapagliflozin and combinations thereof. And real world evidence proved that that is the one of the best combination with DAPA. Then EMPA came, and EMPA with Lina, DAPA with Lina, they have come out very successfully at a much lower price, and patients benefit. And that also, because I have a large experience with those molecules, and they are really fantastic, and patient's well-being is very good, and euglycemic effect is also good. And the rest you told the science, how they are protecting heart and kidney. Thank you very much.
Thank you, sir.
Now I invite Dr. P. Ravi Kumar, Professor and Head, Department of Endocrinology, MKCG Medical College, Berhampur, Chief Endocrinologist, RK Diabetes and Endocrine Center, Berhampur, 40 publication in national and international journals, reviewer in various national and international journals, organizing chairman .con 25, written chapters in various textbooks. Dr. Ravi Kumar, please.
Thank you, sir. Thank you, Ashok sir. Thank you, Kananga sir, and dear friends. I have been asked to speak something on sulfonylureas. The context in which this topic has been, I think, has been formulated is because my two previous speakers eloquently spoke about DPP4 inhibitors, SGLT2 inhibitors. So, where is the position of sulfonylureas in the modern times? That is the question. So, if you see the journey of sulfonylureas, it started way back in 1942 when it was first discovered. Then the tolbutamide was introduced in 1956. Then there was a real havoc that was published in 1970 by UGDP that tolbutamide increases cardiovascular mortality. Then it was completely stopped. Then came the modern sulfonylureas, then various trials. We will be seeing shortly about that. So what we are talking about sulfonylureas, mostly we are talking about the modern sulfonylureas, especially the third generation sulfonylureas like glimepiride, glipizide extended release, and glycolazide modified release. These are the things which we are talking, and we are not talking so much about the older sulfonylureas. So when sulfonylureas we are thinking about, the things that comes to mind is that they are very good, efficient glycemic lowering agents. They are very low cost. and long clinical experience from almost 50 to 70 years, we have the experience. That is the reason why we are using sulfonylureas day in and day out, and we are getting very good results. The other important factor about sulfonylureas is the certain risks associated with sulfonylureas. This includes the risk of hypoglycemia, the weight gain, and some controversy regarding the cardiovascular safety. We will be seeing shortly that. So as we know from previous trials that a good glycemic control during the early part of diabetes management will likely to decrease the cardiovascular events. The study has shown that if you control the glycemic control during the first year, then at 5.3 years, there is decreased risk of MI, stroke, heart failure, and CV events. So this clearly shows that aggressive control of glycemia during the first year is very important. So if we see the sulfonylureas in the real world study, how often we are using the sulfonylureas, this is a study which was published in the JED, that is Joint Asia Diabetes Evaluation Register, and it is showing that nearly 50 to 60% of all oral glycemic drugs which we are using is either based on metformin or metformin combined with the sulfonylureas. And among the sulfonylureas, if you see the right lower column, you can find that in India we are using mostly the glimepiride use is almost 50 to 60%, followed by the glycolazide almost 20%. So these two molecules like glycolazide and glimepiride constitutes almost 70% of our sulfonylurea therapy in recent times. So some studies have shown that in some countries, after the introduction of DPP-4 inhibitors and SGLT2 and GLP-1, the use of sulfonylureas is actually coming down. And in this last decade, 2010, you can see that 2020, in Italy itself, it has shown that the sulfonylureas use has come down from 30% to almost 12%, and it is being replaced by DPP-4, SGLT2 inhibitors, and GLP-1. So we are in a transition phase where the cost of various drugs, especially the DPP-4, SGLT2 inhibitors, have come down remarkably well. So now it comes to everybody's mind whether these drugs, which drugs, sulfonylureas or DPP-4 or SGLT2 inhibitors or GLP-1, I think in next 3 months, we are likely to get the semaglutide at a very, very discounted price. So these things are coming. So all sulfonylureas are not the same in their action and hypoglycemic risk. This we must remember, sulfonylureas are not same as a group. If you compare the glycolazide versus a glimepiride or a glibenclamide, whereas glycolazide is a very specific action on the pancreatic beta cells, whereas glimepiride and glibenclamide, not only they have got the action at the pancreatic beta cells, they have also got action at the cardiac and skeletal muscles where the sulfonylurea receptor 2A is present. And these actions of glimepiride is non-specific actions. Moreover, glycolazide is not acting through the EPAC2 receptor, which is one of the factors responsible for hypoglycemia in some of the sulfonylurea uses. So the modern sulfonylureas have also been shown that not only they decrease glycemic control, they are also reducing the lipoprotein A, the PAI-1 levels, homocysteine levels. So not only they have got additional metabolic benefits. Now studies from India have shown that in a GLIMP study, these are very short duration studies combining of combination of a metformin and a sulfonylurea glimepiride, you find that A1C levels are coming down from 8.3 to 7.3%. Similarly, a START study where the combination of glimepiride plus metformin was compared with sita plus metformin for 12 weeks, you find that if you combine glimepiride plus metformin, the A1C reduction is superior 0.42% compared to sita plus metformin, which is 0.3%. So there are other fixed dose combinations in India. We have got glimepiride, metformin, voglidose combinations. I don't have to go into details about this because we are using every day in our clinical practice and we are getting results. We are getting very good glycemic efficacy. So there is no doubt, although the Western worlds initially were hesitant to start any FDC combinations, but in India, even before somebody approves, and some of our pioneer workers in India has shown that the triple combinations or the combination drugs are very, very effective. Now, if you compare the sulfonylureas as a glycemic agents versus all the drugs which we are using now, you find that sulfonylureas usually they decrease A1C by roughly 1%. And if you see the lowest in the ranking is DPP-4 inhibitors, which roughly decreases 0.7%. The highest decrease in A1C levels of a combination drugs is metformin plus GLP-1 receptor agonist, which is almost 1.3%. So if you see the order of sulfonylureas are very, very good glycemic efficacy drugs. And as I told you, all the sulfonylureas are not same. If you compare the glycolazide versus glimepiride in the GUIDE study, you find that A1C reductions are almost same. And the hypoglycemia risk is only 3.7% with the glycolazide, whereas it is 8.9% with the glimepiride. So glycolazide is not only efficacy, but it is also decreasing the hypoglycemia risk. Now, I don't have to go into details about weight gain and the hypoglycemia risk. Overall, sulfonylureas are supposed to, there is increased risk and one must be careful with that. What about the glycemic durability? How far these sulfonylureas will likely to maintain your A1C control if you are giving a sulfonylurea compared to other drugs? So the initial ADOPT trial, which has compared the glibenclamide versus metformin versus rosiglitazone, and it has shown that the glibenclamide is likely to fail the monotherapy by 34 months, whereas the metformin around 20 plus months, and then rosiglitazone is the least failed drug among these two. So one of the concerns is sulfonylureas or the long-term durability. So one recent meta-analysis, which was published in January 2026, which has compared the sulfonylureas, if you are comparing with the SGLT2 inhibitors regarding the durability from 24 to 25 weeks and 48 to 52 weeks to up to 104 weeks. And it has been shown that SGLT2 inhibitors are superior in maintaining the A1C level over a period of time. So this means sulfonylureas are very good efficacious drugs during the early part of therapy. Later on, I think if you combine with other drugs like SGLT2 and these things, probably the durability increases. Even up to 208 weeks also, you find that SGLT2 inhibitors durability is superior compared to the sulfonylureas. So a bit about now with recent introduction of SGLT2 inhibitors and GLP-1, one is tempted to shift to these drugs rather than the previous sulfonylureas. I don't have to go into details because many previous speakers must have spoken since yesterday that combination of sulfonylureas when you compare with SGLT2 inhibitors regarding the nephropathy, one beautiful trial was analysis was done, and it is showing that regarding the renal aspects, the SGLT2 inhibitors definitely they have got edge over the sulfonylurea. So in that case, if you combine a sulfonylurea with SGLT2 inhibitor, it is a good option. And regarding these things, I don't have to go into that. But what the practice has been for the sulfonylureas has been, you start with a monotherapy or a combination therapy. Usually, sulfonylureas are started as a second line drug after the metformin therapy. But with recent guidelines where the A1C levels are more than 7.5, we are not starting with metformin. We are starting with a dual drug or a triple drug. So usually you start the most common drug that has been started is the metformin plus sulfonylureas. Then if it fails, you can add a triple drug. Then if it fails, of course, you can change over to other regimens like insulin or GLP-1. So various guidelines, Ashok sir also has published. I saw that one of the publications, he has very beautifully told about the role of sulfonylureas in the management of diabetes management. And it has been shown that sulfonylureas has a place, especially in a country like India, where the cost is a very important factor and early control of glycemic control is very important. Now, I don't have to go into ADA guidelines of 2026, the recent guidelines, which says that if you see the sulfonylureas part on the right side, they have grouped the sulfonylureas in the high efficacious drugs, along with other GLP-1 analogs and metformin and pioglitazone if you combine. Whereas the highest efficacy, of course, semaglutide and tirzepatide, but in a country because these drugs are not so less costly, they are very costly. So that's why we need to based upon sulfonylureas. So ACE guidelines, again, they told that if somebody is likely to get a overweight or obesity or a hypoglycemia risk, of course, sulfonylureas are less preferred. But even in those conditions also, we are many times compelled to prescribe because of the cost factors, but with recent decrease in the prices, one might think otherwise also. So a bit about CV safety of sulfonylureas. The debate has been gone. In fact, I have given 3 debates about sulfonylureas, about the CV risk. Initial trials by Monami et al. And Bain et al. These are the meta-analysis which were shown that there is increased all-cause mortality and CV mortality with sulfonylureas when you compare with the metformin or DPP-4. Fortunately, later on in 2019, the Carolina trial, which has clearly shown that when you compare the Lina versus glimepiride, there is no increased risk of either all-cause mortality or myocardial infarction. The previous trials like UKPDS and advanced trials, those were actually they are not CVOT trials. They were controlled trials, but they were not dedicated CVOT trials. But Carolina was a dedicated CVOT trial, and which has clearly shown that glimepiride is definitely a cardiovascular safety. When we are saying that everything is stabilized, we are okay with sulfonylurea, somebody or other comes with some other article, then we are actually again drawn into this. So a systematic review was published, that is way back in 2022. And when compared with all other drugs with low hypoglycemic risks, it has been seen that sulfonylureas actually increase the all-cause mortality by 1.32 is the hazard risk, and MACE 1.32, MI 1.67, hypo risk is 5.24. Not only that, the recent trial which has been published in the JAMA network, where they compared glipizide, glimepiride, glibenclamide versus DPP-4 inhibitors when they were added to metformin. This is a comparison of trials from 2014 to 2023, and minimum duration of follow-up was 37 months, and they found that glipizide actually increasing the risk of CV events. So one must, anyway, the good news is that we are not using glipizide so much compared to the glimepiride and gliclazide. So practical utility of sulfonylureas in the real world Indian setting. So the modern sulfonylureas are very, very effective glycemic agents and most commonly prescribed OH in Indian setting, almost accounting for 60% of all our drugs which we are using. And one important factor I must highlight that all sulfonylureas are not the same. So there are various trials which are showing again and again gliclazide and glimepiride are two molecules which are apart from all other sulfonylureas. So the safety of glimepiride and gliclazide has been shown in trials where it has been shown that they are cardiovascular safe. Sulfonylureas are very effective glycemic agent during early part of diabetes management, especially around 5 years or less than 5 years, 6 years, 7 years. They are very good drugs. Beyond that, actually you read additional drugs where the efficacy of sulfonylureas comes down because the beta cell mass obviously comes down. And one must be combined, it should not be combined with glinides, as you know that they are working through the same mechanism. And one must be aware of the durability of sulfonylureas. As I was referring to that, compared with SGLT2 inhibitors or a GLP-1 receptor agonist, the durability of sulfonylureas is less. So in that condition, we must use these drugs in the early part of diabetes management. That will be where the pancreatic beta cell mass is adequate. We are getting very good results. The recent introduction of low-cost SGLT2 inhibitors and GLP-1 receptor agonists might change the future therapeutic strategies as they offer cardio-renal and hepatic protection. So many times now GLP-1, I think in next 5 years or 10 years, we are likely to, not 5 years, in next 1 year, we are likely to use GLP-1 receptor agonist more and more compared to what we have been using. We are using very little or almost not till now, till March or April of 2025. After that, there is increase in tirzepatide and other drugs. Now with semaglutide off patent in the month of March, I think we are likely to change over to the next phase. But still, the role of sulfonylureas is still there, and it is a very good efficient drug, especially during the early part of diabetes management. Thank you all.
Thank you, Ravi, for a nice presentation. And protecting a molecule that is helping millions.
Yes.
Glimepiride.
Sure.
In a context of Southeast Asia, where people economy is at stake, we must give a drug that is efficacious and scientifically proven to be safe. Safety and all other things. Previously, we are telling add X why drop to sulfonylurea? Now we must say add sulfonylurea to X, Z drugs. Those are new because patients using sulfonylurea my for last 30 years. They are euglycemic and no, and they are so my
I think we have given a slogan. Sulfonylurea is effective, cheap, affordable, appropriate, accessible, and we have given the last part of the slogan, the glucose smart. And you rightly said, bring down 2.5 glucose smart, and after their cardio. So glucose smart, cardio safe, effective, economical, affordable.
Sir, thank you. Thank you, sir.
Request our youngest follower.
For his dance yesterday on the
Dr. Sunil Kumar Kota deliver his talk on advancing metabolic care. A fixed-dose combination of SGLT2 inhibitor, and metformin. And the question is, Dr. Kota doesn't require any introduction, but he is a consultant endocrinologist, Bastya Southern Bharam, 105 peer-reviewed publication, 90 abstract, 30 book chapters, highest number of in IGEM, letter to the editor, and selected as 55 candidates across globe to participate in ICEPAD held at both USA April 2000. Welcome.
Thank you so much, sir. Thanks that Ipsita has joined later. I think Swikruti is already here, so probably the tag of youngest has to be taken out. Thanks to Kanungon sir and Ashok Das sir for that wonderful invite. And I think Abhay has already done the job. He was preferably alluding to Vrindavan, where he was talking about the romance between Radha and Krishna, sitagliptin and dapagliflozin. I am going to add metformin to that. So probably I would be representing more of Puri, Jagannath, Balabhadra, and Subhadra. So with that brief preamble, yes, the situation is not that which is to be cheered, just to something to cheer about. Global epidemic with rising complexity, the current care models often overlook metabolic roots. So therefore, there has been a paradigm shift in our approach, where we are not looking at only isolated glycemic control, we are also looking at integrated care. And Ashok Das sir was right in stating that yes, the concept of CKM or the CRM is the one which we all need to look at. And the Indian population is particularly vulnerable to early onset of type 2 diabetes, where multiple pathophysiological defects they come in. And one particular scenario is that is very important in places where we practice in most of the parts. We are not able to screen the subclinical cardiorenal impairment. And most of the times we end up finding people having advanced complications. So the initial focus has been to provide relief from the symptoms and glucose monitoring. Initially, we were focusing on the HbA1c because we actually need to look at the numbers as well. And we have seen a number of slides where we were told that we need to start with the monotherapy, we will let it fail, then the HbA1c would go up. Again, we would re-intervene with a stepwise intensification. But then at that point of time, there was little emphasis upon the CV and renal outcomes. Hypoglycemia, weight gain were the major limiting factors, and weight and metabolic risk as a whole was not being looked at. So the common soil hypothesis we all have been talking about, where insulin resistance is hypothesized to be the causative factor for both diabetes and the cardiovascular disorders. But here you can see obesity giving rise to forming a common denominator, giving rise to all the problems of diabetes, hypertension, and atherogenic dyslipidemia. And by this point of time, we have ample evidence to suggest that diabetes is not only about glycemic control. This again is an editorial in 2023. It says that hyperglycemia is just tip of the iceberg. See, once there is an advent of CKM syndrome, we are looking at a number of other factors like type 2 diabetes, chronic kidney disease, ASCVD, MASLD, and therefore we have witnessing a shift from our traditional approach of only reducing the sugar, but we have rather become miser in our expectation. We want much more. Ye dil mange more. So we want them to reduce the weight, fat. So as my previous speakers have already alluded to, the newer therapies like GLP-1 receptor analogs, gliflozin, surgery, lifestyle, digital tools, all of them have chipped in a big way to improve multiple outcomes. Therefore, holistic metabolic medicine is the one which we are looking at. Yes, it is not only about the blood sugars, it's links with NFLD, PCOS, hypertension, dyslipidemia. With the increased cardiovascular and renal burden makes us look beyond the traditional approach of HbA1c. Therefore, multi-dimensional approach is required. So the reduction in diabetes complication is through the glycemic management, the blood pressure management, lipid, and agents with cardiovascular and kidney benefit. That is very important. And this is the tabular form of recommendation where we are taught to look at not only the blood sugar values. Initially, the factors which come to the fore are presence of ASCVD or high risk ASCVD, heart failure, stroke or TIA, chronic kidney disease. If not, then you have to look at the HbA1c, and then also there are other parameters to look at like cost, weight, and hypoglycemia. So the the therapeutic goals have been effective, have been evolving. The ones which not only could reduce the sugars, they should be also reducing the cardiovascular events, should be reducing the renal progression, promote weight loss and insulin sensitivity. They should be lowering the blood pressure and lipids, and prevent complications through early intervention, improve quality of life, and reduce pill burden. I have listened to many seniors who have been talking about the fact that in places like India, where we cannot screen the baseline or subclinical cardiorenal risk factors, it is always better to go with a drug which would also take care of these risk factors apart from only looking at the hyperglycemia. And apart from that, we know that a large proportion of patients with type 2 diabetes have cardiovascular disease, approximately 1/3 of them, and the presence of patients with type 2 diabetes and CVDs have an increased risk of other complications like MI, stroke, heart failure, and CKD. And to make matters worse, we have been debating a lot, and we have come to a conclusion that CV disease occurs early, especially in the Asian context. And heart failure is an early, highly prevalent and often undiagnosed complication in patients with type 2 diabetes. Between 25 to 40, which is a staggering number, we must admit, of patients with diabetes having heart failure, and 68% of patients who had type 2 diabetes for 5 years showed signs and symptoms of asymptomatic LV dysfunction. And it is stated that predominant chunk of these are around 23% of them are HFpEF, and 5% of them are HFrEF, totaling them to 28% of them. And CKD and heart failure are the most frequent fast cardiorenal disease manifestation in patients with type 2 diabetes. You can see around 35% of them having CKD, heart failure present in around 24%, followed by stroke, MI, and peripheral arterial disease. So I still recollect during endocrine residency, the three parameters, the hypertension, dyslipidemia, and hyperglycemia. Hyperglycemia predominantly getting linked to peripheral arterial disease, hypertension predominantly getting linked to cardiovascular disease, and dyslipidemia predominantly getting linked to cardiovascular disease. But that is getting changed. And here in the previous slide, you can see the chances of CKD and heart failure taking over other complications. And BMI, yes, it is one parameter which we all need to look at. And it is associated with insulin resistance, loss of motivation to exercise, and loss of muscle. And of late, there has been a lot of deliberation on sarcopenic obesity, especially in the elderly. So that's what that is something which is again making matters worse. So gliptin and gliflozin, however, has taken us through thoroughly how they have changed the landscape. They enable organ protection beyond glycemia, dual and triple combinations reduce treatment inertia, that is for sure, and shift towards earlier combination therapy supported by trials. So we need to choose the right agents and in the right patients. And yes, we all have been willing to control the sugar set in an aggressive manner, but with the previous kind of drugs, we used to have the more risk of hypoglycemia and weight gain, which is basically negated by this combination. And triple FDC address the 7 out of the 8 pathophysiological pathways in ominous octet. So we are acting early, acting aggressively, and we are also trying to act at multiple pathophysiologic defects. So the combination of metformin, gliptin, and gliflozin has the potential to correct 7 defects of well-defined ominous octet without provoking significant hypoglycemia. And the cardiovascular and renal benefits of the individual component medicines are unaffected by the other molecule in the combination. And AAC guidelines recommend triple drug therapy as a first approach for treating asymptomatic patients with HbA1c level more than 9%. And patients having HbA1c less than equal to 9%, triple therapy can be recommended if the patient has an inadequate response to monotherapy or dual therapy. So these are the global approvals. FDA approval in 2020, Empalina metformin, and the Dapasaxa metformin faded away for obvious reasons. And DCGI, they approved Dapasita and metformin in 2023. And Alok sir has rightly told us, subsequent to that, we have a number of other possible combinations flooding the market and yes, coming in a cheaper way. So the benefits are simplified once daily dosing regimen, improved patient adherence, better HbA1c control than dual therapy, reduces treatment inertia, convenience improves the quality of life, and available in Indian market. Yes, we have some studies which have been highlighted by Abhay as well. And Indian perspective, yes, we have an early onset of diabetes attributed to central obesity and metabolic syndrome, early onset of type 2 diabetes onset with high CV risk, and cost sensitive population, which is a very common finding in our day-to-day OPD practice, which needs value-based care. And FDCs help reduce the pill burden and improve access. Physicians increasingly receptive to early combinations and need for more awareness and prescription comfort. So the cardiorenal protection of SGLT2 inhibitors, the SGLT2 inhibitors reprogram systemic metabolism to a fasting-like metabolic paradigm. This again, we have been seeing there has been a ketogenic environment from the protein catabolism and the free fatty acid oxidation, which they take over as the additional energy substrate, thereby reducing the glucose utilization and increasing the free fatty acid utilization and increasing the branch chain amino acid utilization, therefore improving the cardiac and renal health. This slide again is a repetition of what Abhay has already told. The mechanisms by which the gliflozins are affording protection to the both heart and the kidney by means of acting upon the diuresis, the sympathetic nervous system, metabolism, iron homeostasis, kidney, the thrifty substrate hypothesis, and the antioxidant status. And yes, the NFLD or the MAS-LD, which has been labeled MAS-LD of late, here is a systematic review and meta-analysis. The 11 studies involving 839 patients were included in the meta-analysis, and there were positive impact of DAPA on liver function by decreasing the enzymes, the TG, body weight, BMI, HbA1c, and fasting plasma glucose. And we have seen the studies with the DAPA and SITA, but this is a fixed dose combination therapy of DAPA, SITA, metformin phase 3 study where the DAPA, SITA, metformin was pitted against SITA, metformin, and DAPA, metformin. And it is not a surprise to understand that the combination has been performing better as far as the HbA1c reduction is concerned vis-a-vis SITA, metformin, and the DAPA, metformin. The second is a MESIDA trial, the randomized double-blind active control trial assessing the FDC of metformin, sitagliptin, and DAPA in Indian adults with type 2 diabetes. The MESIDA trial is a multicentric randomized double-blind active control phase 3 study were conducted in 274 Indian adults patients with type 2 diabetes, and you can see half of them were given the FDC of 2 drug and half of them were given FDC of triple drug. And again, here you also you can see the numerically and the HbA1c reduction wise the triple drug combination is performing better as far as the HbA1c is concerned. This is a systematic review with meta-analysis, the triple drug combination of gliflozin, gliptin, and a metformin in type 2 diabetes India. And you can see that the standard difference in mean and pooled data analysis of HbA1c was 0.5049, which went on to achieve the statistical significance. And the way it addresses the clinical inertia is definitely important because more the number the tablets is prescribed, that then the adherence of the part of the patient definitely comes down. So triple therapy is the one which is the one which can take the role of both as an initiator and also as a one which can be used for intensification. We have a number of real world evidence, as Alok sir was rightly alluding to, and the cost is a major point which is being addressed with this particular combination, and we can monitor the outcomes in personalized titration. And once the barriers, the number of drugs will go up, the complication will go up, the cost will jump up, all these are being effectively addressed, you end up finding a friendly patient, and ultimately that translates into better outcomes. So we need to identify the eligible patients proactively, utilize lab and clinical markers, leverage the FDCs for simplification, which we all have been doing. And the follow-up has to be in accordance with the international guidelines once in every 3 to 6 months. So we can utilize the triple therapy in at the outset itself, and also for the intensification, which can bridge the gap between guidelines and practice. So therefore, to conclude, I would say that it is not just a glycemic problem, it is also a metabolic disorder. The triple therapy is one such option which offers a robust, multi-targeted approach. Early metabolic intervention is very important, and the FDCs help in a big way because they are practical, effective, and increasingly essential. They empower all the level of care with this knowledge. Together, we can actually shift it from control to care. Jai Jagannath, and thank you.
Thank you very much, dear friends. You know, we have prepared painstakingly questions for panel discussion, but in the interest of time, I'll take only half a question for each speaker just to complete it, and you can answer from your place. Now we'll start with Sunil because we're on the dais. Sunil, can I ask you the first question from the, and I'll hand over the questions to all of you. We can come. So the first question I'd like to ask you, Sunil, is that are you moving towards, are we moving towards a very bright future where the early combination therapy becomes the norm rather than exception?
So I would state by quoting Alok sir only, we have been using it since long. Are we not? We are not moving. Probably we have progressed to a great extent in utilizing these FDCs because they target a multiple pathophysiological defects, and Ravi has clearly told us the durability data is there. It affects multiple pathophysiologic aspect whereby the insulin resistance, insulin secretory dysfunction is being addressed, the subclinical cardiorenal impairment is being addressed, the risk factors is being addressed. Yes, we are moving, and we are moving in the right direction.
Absolutely. The question to Sambit, have a question. How should clinician balance tight glycemic control with to reduce the psychological burden?
Yes, sir. I think we have discussed in that the vicious cycle of diabetes distress with poor glycemic control, and that again leads to poor glycemic control and diabetes distress. So that vicious cycle needs to be broken with a good and tighter glycemic control, and we have already discussed about glycemic happiness. So once the blood glucose comes down, one feels better, and glycemic happiness and diabetes distress actually goes down. So only thing we need to avoid hypoglycemia with a stricter glycemic.
Thank you. Away has gone outside. Okay, last question to Ravi. Marvelous, Ravi. You just give a lot of reviews. Beautiful. How can clinician minimize hypoglycemia? You alluded to it. And weight gain. Simple directions to. These are the two things which against the smart glycemic control and cardiac safety. How can you do this?
Sir, it is a real issue with any sulfonylureas, the weight gain and hypoglycemia. So we should be careful in using the sulfonylureas which are got least hypoglycemia and weight gain risk, like either use a glycolazide modified release or a glimepiride, number one. Number two, in certain conditions like chronic kidney disease or patients with where the dietary habits are not regular or irregular dietary habits, elderly people, these are the people who are likely to prone for hypoglycemia, and certain drugs you should not mix with sulfonylureas, especially the glinides. One should not be mixed with the sulfonylureas to decrease the risk of hypoglycemia, and certain other conditions like hypothyroidism, which are and hypocortisolemia. These are the conditions in which they are at increased risk of hypoglycemia.
Thank you.
Regarding the, sir, one.
Yes. No, please.
Sir, regarding the weight gain,
where the speaker controls the.
So regarding the weight gain, of course, we should be careful that while using sulfonylureas, combination with a pioglitazone or other drugs which are likely to increase the weight gain, we should be careful. Thank you, sir.
Yeah, dear friends, while ending this session, please watch what we wrote some time back. When pathophysiology is multifactorial, therapy should be synergistic. Number two, fixed dose combinations don't just simplify the prescription, they simplify the lives of the type 2 diabetes patients. Dear friends, thank you very much. A wonderful session on the FDC. I think it's a great session. Thank you. And my sincere regards, love and greetings to all the speakers. Thank you.
Subhasri, please invite the chairpersons.
Thank you to our chairpersons and panelists for those valuable insights into the future of oral anti-diabetic therapy. As we have seen, optimizing glycemic control is only one part of the larger metabolic picture. We now move forward to an equally important pillar of diabetes care, weight management. With this, we begin session 7, New Age Weight Management, organized by Novo Nordics India. I invite Dr. Lalatendu Mahanti, Associate Dean and Vice Principal Professor, Department of General Medicine, Kalinga Institute of Medical Science, Bhubaneswar, to please join us on the dais. I also request Dr. Ashok Kumar Das to kindly set the context. A warm round of applause as our chairpersons take charge of the session. Thank you.
Good morning. I welcome you all to NUCD, 12th NUCD, and it's my pleasure and privilege to be chair a session on new age weight management. There are a lot of important topics and very important speakers also. I would try to start with the first speaker, Dr. Ipsita Misra, who is Associate Professor and HOD Department of Endocrinology, IMS and SOM Hospital, and SOM 2, Kotak, Director, Soul Balance Diabetes and Endocrine Center of Excellence, professional membership in multiple societies and a lot of 32 publications. And she will be speaking on the gold standard, semaglutide leads the way in weight loss and beyond.
Thank you, sir. At the outset, I would like to thank Ashok sir, Kanungo sir, Team NUCD for giving me the invitation and having me here. So we will be talking about semaglutide. So this is a Novo sponsored sessions. So under 3 subheadings, we will just have a brief overlook, trying to understand the burden of obesity in the current scenario. What is the evolution of the pharmacotherapy? Not much into detail. And we will talk about the drug, the extensive trials that it has been through, and of course, the safety profile of SEMA 2.4. Well, now obesity has been recognized beyond the accumulation of fat tissue in a body as a chronic disease, multifactorial, needing treatment maybe throughout the lifetime. So the definition has evolved. And if you look into the data, probably right now 1 to 2 billion of the world is obese, and equitable distribution among the 3 categories of adults, adolescents, and children. And probably by 2050, we are going, half of the world is going to become overweight and obese. And interestingly, if you look into the numbers epidemiologically, the data says that the lower and the middle income countries, here, these are the one where the prevalence of obesity is on higher side. And the Indian picture per se, more of our population are those one who have obesity predominantly at the abdominal site, where we get the classical pot-bellied appearance, and the generalized obesity prevalence is rather less. We have understood obesity is associated with multiple complications. So if you look into this picture, initially obesity was thought as a risk factor for causing dysglycemia, dyslipidemia, hypertension, but it is associated with multiple conditions. Rather, it's the mother of everything from CADs, CKD, MASH, PCOS, malignancies, OSS, etc., and multiple more. So this is a brief summary of the pathophysiology. So broadly, the complications of obesity are categorized into 3 headings: mechanical, metabolic, and mental. Mental health we don't talk of. So mechanical, if you look, of course, the mechanical stress, mostly OSA and osteoarthritis, more so in our population. And metabolic complications, if you look into the pathophysiology, what happens is when excess of fat mass, especially in the Asian populations, the way it accumulates, it sets into an inflammatory milieu, which ultimately leads to, if you look into the down signaling cascading pathways, there is alteration in the insulin sensitivities, a worsening of insulin resistance, spillover of the lipids, lipotoxicity, which will lead into the spectrum of metabolic health related problems ranging from diabetes, spectrum of cardiovascular disease, CADs, etc., etc. So ultimately, is the life expectancy is decreasing. So as the BMI starts increasing, so you can see the life expectancy starts faltering to as less as fourth and fifth decade of life. And what we have understood from various data trials, 5, 10, 15% of the baseline body weight, if it is lost, what are the benefits? So if you look into this, at 5%, there is improvement of insulin resistance. So somebody who is pre-diabetic may become normal. There is improvement in the beta cell functions, decrease in the inflammation, and improvement in the muscle insulin sensitivity. So these are the pathophysiologies which starts the problem of various spectrum of metabolic health beyond dysglycemia and diabetes. So 10 and 15% of the weight loss, even if somebody is having to the end of established CADs or having a CKD stage 3, can have definite improvement and certain cases remission of those conditions also. So with the evolution of timeline since last 30 years, so initially as an obesity treatment protocol, it was just the lifestyle, take care of your food habits, exercise habits, and then the component of CBTs, cognitive behavioral therapy, was introduced. Certain drugs came up, and ultimately it was bariatric surgery. So there was a wide gap to meet the choice of the patients, because we all know that bariatric surgery, they have their own advantages and disadvantages. So what happened is, with the evolution, so this gap has been met with the evolution of certain drugs, and where we have identified especially the GLP-1 analogs or the incretin mediated effects. So let us introduce semaglutide 2.4 milligrams. So this molecule has been extensively in trial since 2016. So SUSTAIN was the first trial, SUSTAIN group of trials rather, I would say, which was the first CVOT with semaglutide. And then came the STEP trials, which looked into the weight parameters of semaglutide. So step 1 was in the non-diabetic, 2 in the diabetic, 3, 7, and now multiple until 11 step trials are there at various points. So ultimate goal was of all the step trials was to look into the degree of weight loss, because what we wanted to understand is the degree of weight loss, how sustainable it will be. So step 4 and 5 and 1 are some important trials with this molecule, which gave us a lot of idea. And along with that, it has been through some trials looking into the cardiovascular part, the celiac, the renal part, the flow, and of course with MASH, that is the essence trial. So bottom line is, if you look 2.4 milligram of this molecule compared with lifestyle alone, so up to 18 to 19% of weight loss, mean weight loss, can happen with this molecule. And out of 3 patients, at least 1 will have an attainment of 20% weight loss reduction. And interestingly, sustenance of the weight loss for a longer period, as long as 4 years, was there. And step 4 gave us the data that after 20 weeks, even if you are stopping the drug therapy, you will not re-hit the baseline values of BMIs. So this is the extensive trials. So mean loss with almost all of the step trials, 6 and 7 were done in the Asian populations for a little bit lesser duration. Weight loss reduction of around 15 to 17% was there. Step 2 was the one which was done in the diabetic patients, where it was seen that the weight loss efficacy was not as great as step 1. It was until to the tune of 9 to 12%. So weight loss benefits are very good. So at least 5%, most of the patients, 90%, 10 to 15%, at least 75 to 50% you can have. So 5, 10 and 15 for the Indian patients, even if it is 10%, we will be like too much happy. So good amount of weight loss is what we have understood. And out of 3, we saw in the previous data also that at least 1% will hit the value of 20% of weight loss reduction. So now step up has come up, where the weight has been loss has been seen with 7.2 milligram of SEMA, and it is as effective as any bariatric surgery procedures, as great as 20 to 25% of weight loss reduction. And importantly, it's not just the weight loss or the loss of the fat mass. We want to explore whether we'll get added benefits in terms of CV part, renal part, etc., etc. So quite good reduction reduction of the systolic and the diastolic blood pressure, which we know are the CV risk factors, improvement in the lipid profiles, triglyceride reduction as good as 20%. Inflammatory markers has been seen in various studies as secondary outcomes, where there is reduction in the state of inflammation, HbA1c, etc. And SELECT, we know the data, as SELECT has seen that 20 to 22% of 3-point MACE reduction in the CV outcome parameters happens in those of SEMA users versus the placebo users, following which ESC has given that this is probably the only GLP-1 analog that should be considered as a treatment modality in patients with obesity to explore the CV benefits. So, safety profile. Now, this molecule has been with us since probably 9 years. Quite a number of patients have been involved and enrolled in multiple trials, and the safety profile is good. Other than we know that all the incretin-based therapies, they have the commonest side effect is with the gut-related adverse effects, nausea, vomiting. Step 2, which was done in diabetics who were taking other therapies, of course, hypoglycemia was there, and we know that GLP-1 analogs, if they are given along with SUs or insulins, you have to be careful. And related to the occurrence, we know that incretin-based therapies are contraindicated in those who have got pancreatitis or a family history of medullary thyroid malignancies, but no new malignancies were seen with these drug users. And the risk of occurrence of NION came up in 2024, but now again we have got data that probably SEMA is associated with decreased occurrence of NION, which was published last year, November. So per se, the worsening of DR, it's there in our mind. We do not per se start the drug therapy in those who have a background DR, but we'll get the data from FOCUS. So just to sum up, growing burden of overweight and obesity, and having this molecule, which has been through many trials, definitely is the harbinger of the paradigm shift in management of overweight, obesity in individuals without diabetes and with diabetes. And of course, beyond weight loss, you are exploring the cardio, the renal, the metabolic effects with this drug, and safety profile is consistent with the GLP-1 receptor agonist class. So thank you so much.
Thank you, Dr. Ipsita, for an excellent presentation highlighting the extra benefits of semaglutide beyond weight management, the MACE reduction, and also the other advantages. And sir, would you like?
I just want to tell you that Ipsita is the daughter of Pradhanand, and the speaking, the communication has been superb. Silly to that. Now, I must tell you one thing very important about SEMA. As you rightly pointed out, this is the first in class. As you said, 9 + 1, 10 years of experience. It's also the first to say that it can be given, it is from the injection room to the oral room, and that you can achieve the same type of benefit. It has also shown the NION is not only because of the drug. It is also some pre-existing, as you rightly said, there are literature which show the depth of the fundus copia and gives us the directive how we can also preempt. And finally, as you said, when others are looking for Summit 3, whatever, we have established cardiovascular safety. So we say first in class, first in safety, highest number of patient exposure for last 9 years, and protein in a pill. We'll have a last question answer when Sir will lead the panel discussion.
Yes, sir. Yes, sir. I'm there, sir. Thank you, sir.
Okay. 2 questions I'll ask you. No, these questions are by mine. Now, you tell me that you said that the cardiac benefit does continue beyond the drug is stopped. Please justify that. You alluded to it.
Yes. So SELECT was the trial which looked into the CV outcome, and It was seen that the CV benefit was achieved before the weight loss attainment targeted values was there. So this highlighted that this drug per se, it has got an effect on the vasculature, and it somehow kind of modulates the inflammation which plays, and it also takes care of the RAS methodologies. So these were the proposed mechanisms in which SEMA, before achieving the targeted weight loss, probably causes improvement in the CV part.
The last question, yesterday Nitin was with me, Nitin Kapoor fame. Nitin was talking about the step 7, 8 trial. You talk about 9, 10, 11.
Right.
Now, Nitin has shown that with the high dose, 25 and 50, he has shown the weight loss equivalent to bariatric surgery.
Absolutely.
Your comments on that. And also last comment on the flow trial.
Absolutely, sir. So step up is with 7.2 and now 25 and 50 can achievement have the value targeted of as good as Rouen by. But I think we need more data because of the problem of the GI related, gut related side effects. And I believe that Indian gut microbiome is definitely, it is different. And related to flow, of course, SEMA has been shown that again, there is around 18 to 20% reduction in the primary outcomes of the renal parameters with the drug molecule.
Thank you very much. Great talk. But Nitin said yesterday in this 25 and 50 gram trial, 50 milligram trial, there was no blinding. So he knew everybody was taking the drug.
Okay.
Therefore, the GI side effect, it had been noted, it was
Yes,
there,
yes.
but not too much.
Right, sir.
Thank you.
Right, sir.
Great talk.
Thank you. Thank you,
Great
sir.
talk.
Nice presentation. We'll invite the next speaker, Dr. Sukhriti Jena, is a consultant endocrinologist, Kalinga Hospital, Bhubaneswar. She has been a university. Abhay first. Okay. Abhay
Abhay doesn't need an introduction.
Abhay is Abhay.
Abhay is Abhay. Abhay is Nirbhay. And Abhay is going to speak to us. He just spoke to us in the first session about the combination therapy. Now Abhay is going to speak to us very important topic. The power of one, the slogans that they have developed around semaglutide like it. The power of one semaglutide as the ideal first choice for both diabetes and obesity. Power of one as the first choice, number one choice for diabetes and obesity. Abhay, all is yours.
Thank you, sir. Thank you, respected chairpersons, my dear friends and colleagues. So already Ipsita has discussed about semaglutide, and it makes my job very much easy regarding discussing Ozempic, because both are same. Only the strength difference is there. Otherwise, same. I will discuss the power of one. Semaglutide is a first choice medicine for diabetes, because obesity part already Dr. Ipsita has discussed, obesity and diabetes. So this is a Novo sponsored program, and we know that if you see the unrelenting epidemics of diabetes, if you see it's not an isolated disease, because once you are telling diabetes, probably there is a constellation of things which is actually attached to that. It is inflammation, weight gain, hypertension, adiposity, insulin resistance. Everything is associated once someone develops diabetes. So this is a constellation of symptoms and all important risk factors, because we know once there is diabetes, there is renal failure, risk of renal failure, cardiac coronary disease or heart failure, in liver MSLD and peripheral arterial disease. All has been actually the end stage or the complications related to diabetes. We know everything. So management of diabetes requires a holistic, multifactorial and a person-centric approach. So the prevalence of diabetes in India now is close to 100 to 1 million. This is the ICMR data. And probably by this time, because this is already 2 years old, by this time, further it would have been increased significantly. And the percentage of people living diabetes not controlled is close to 75 to 80%. And the most important, another important thing is that what the data we are getting regarding the prevalence of diabetes, almost equal number of people are there who have never tested their blood glucose but they are diabetic, and we are not detecting them. So actual figure is much higher, but actually ICMR has got from that. And this is the every 1 year of poor uncontrolled blood glucose in diabetes, how it is affecting. The risk of microbial infection is increasing by 67%, heart failure 64%, and stroke 51%. Every 1 year of poor glycemic control. So one can imagine if someone is having uncontrolled blood glucose, how significantly percentage exposed to different type of complications. And this is achieving a good glycemic control. This is the legacy effect with the Wikipedia study which has started. Wikipedia started in 1976 and continued up to 1996. 2 arms, one arm is tightly controlled, another is conventional arm. The only difference between both the arms is close to 1 to 1.5%. And when in 1996, 97, when the study closed, what they found that the microvascular complication is far less. Those are having tight glycemic control from the beginning in comparison to the conventional group. In 1997, they stopped intervention. After that, both the groups become uncontrolled, and both the groups average HbA1c become 8.2. So this is uncontrolled. But after 10 years, in 2007, again they reanalyzed. Still, they found that those who are tightly controlled from the beginning, still their microvascular complication is less. And again, they are getting benefits from the macrovascular point of view. So that shows that if you are having a tight glycemic control at the beginning, the body got some signal and that gives some sort of very positive benefit even if in the latter part of life. So a tight glycemic control from the beginning is utmost important. That is the legacy effect. So again, here, once we are using GLP-1 receptor agonist, there is decrease in insulin secretion from the beta cells. What are the effects it has? Decrease, which is there from the beta cell, it is acting on that. Increase, there is an increase in hepatic glucose production. There is increase in the lipolysis, impaired appetite regulation, increased glucagon secretion, decrease in incretin effect, and decrease of death. So from the ominous octet, probably 8 out of 7 out of 8 is actually taken care of once you are using GLP-1 agonist. So all those targets is being targeted in the pathophysiology of diabetes. Again, if you will see the ADA recommendations, early use of semaglutide across the patients, you will see this is the now the current guideline which is showing GLP-1 receptor with proven CV benefit or SGLT2 inhibitors with proven CV benefit should be used as the first line of therapy, particularly in the management of diabetes. Again, if you want weight loss, again it is important. If you want, even if CKD patients, also GLP-1 receptor agonist is actually with proven benefits, means only semaglutide is actually having the proven benefit from the CKD point of view. So this is approved for that. So this is the semaglutide is endorsed as India's first very highly efficacious drug both for glucose lowering and weight lowering properties. Semaglutide provides a clinical benefit across wide spectrum disease because it allows an individualized and timely delivery of clinical benefits aligned with and needs across the indication and formulations. That is, we have now Rivals as oral therapy. We have weekly injections. This is Ozempic, as I am discussing. And now Wegovy is there for weight loss. It is 1.7 and 2.4 additional strength is there with Wegovy, which is actually responsible, or there will be significant weight loss will be there with that. It has a wide range of benefits out of the patients, weight loss up to 21%. And glycemic HbA1c reduction, those are having baseline HbA1c close to 9 or more than that, there will be a HbA1c reduction as high as up to 2.8. So there is a significant HbA1c reduction is also there with particularly Ozempic. And US FDA, if you see for the primary prevention, it's approved SOUL trial as showing the cardiovascular trial, which has showing significant benefit. 3-point MACE, if you see the SUSTAIN 6, that is 26% reduction in the 3-point MACE. And if you see the heart failure, step heart failure, preserved infection, there is 69% improvement is there with from the heart failure point of view. And probably this is the only drug till date which has given benefit from the peripheral arterial disease point of view. Because till date, if we will see the SGLT2 point of view, then there is controversies because we know the CANA trial has shown there is increase, then NAPA has shown there is neutral. But again, this the meta-analysis has shown the SGLT2 has some sort of signal towards actually, if those are starting from the beginning, within first few weeks, there is a signal for peripheral arterial disease, or those are having critical link ischemia, they might precipitate peripheral arterial disease from the beginning, few weeks of starting of SGLT2 inhibitors. But here, this is the only disease drug, not only giving cardiovascular benefit, not only giving renal benefit, among the peripheral arterial disease, probably this is the only drug which is giving benefit, anti-diabetic drug which is giving benefit. Till that, no other drug has been approved or given any sort of benefits from particularly cardiovascular point of view. Yeah. So again, from the liver, Essence trial, 37% reduction in 63% reduction in mass and 37% reduction in fibrosis. So that is the endpoint you will see. Again, if you compare with resmetirom, because it is the approved drug for particularly MSLD, even if in resmetirom trial as they have shown clearly, there is no reversal of fibrosis. Up to inflammation, up to significant inflammation, resmetirom can reverse back to normal. But resmetirom has no effect on fibrosis. Again, this is the only trial which has shown there is reversal of fibrosis. And again, it has been US FDA approved for particularly use of in MSLD. Recently, only 3-4 months back, it has been got the approval. And again, all-cause mortality up to 20% reduction in the all-cause mortality. That is the select and flow both has shown clear-cut benefits. So once weekly injection, it's a human GLP-1 analog. It exhibits 94% structural homology and also half-life is close to 7 days. It is 6.75 days. So it is close to 7 days. Hence, it is suitable for once weekly therapies and has been extensively studied across different RCTs and real-world evidences. So if you see, up to 7.5 billion people worldwide has been exposure to Ozempic, and in 75 countries it's already approved and also is being used. And this is the #1 prescribed GLP-1 across the world, because people ask anybody, even if any patient, sir, actually there is a new drug has come, you can give, sir, Ozempic. Nobody knows Wegovy, nobody knows Mounjaro, anything. They say Ozempic, they know this is, anybody who asks, they know it's Ozempic. So that is the beauty of Ozempic among us. So now approved in India. So that is, people see, even if a lot of the time we ask that, is there any Indian population which has been exposed to that? People see across different trials, close to 1,250 patients are from India. All different trials. People take all those trials. This is because this orange one is the trials where actually Indian population has been actually included, and you will see Sustain 8, Sustain 7, Sustain 4, Sustain 10, Sustain 9. All those actually trials, actually Indian population has been actually there. So again, this is a drug which has been well tested among the Indian population, and this is the drug which is actually showing all results, also has been actually can be extrapolated or can be exported to our own population. Again, the provides a good glycemic control, enables the first line of therapy, powerful glycemic control up to 2.8% reduction, and 4 out of 5. That means 80% people reach a target HbA1c less than 7 with particular use of this, and there is a good HbA1c reduction is there, particularly with this. So compelling weight loss up to 8 kg, and 66% people reach clinical, meaningful, significant weight loss target. That means more than 5% weight loss is found in more than up to 2/3 of the patients. So again, this is called clinical, significant, or meaningful weight loss. That is more than 5% weight loss, and up to 8 kg weight loss is there, particularly Ozempic. So 3-point MACE reduction 26%, composite kidney outcome reduction by 24%, as I have clearly shown. SOUL trial and FLOW trial both has clearly shown that benefits. And there is 60% loss in improvement in the kidney function, and proven to delay the renal failure up to 5 years once you are using Ozempic. So again, that is the renal benefits what we are getting from that. And not only that, we are getting some additional pleiotropic benefit. You will see that there is free fatty acid reduction up to 12%, triglyceride reduced by 14%, VLDL is reduced by 12%, and LDL is reduced by 8%. So from the lipid profile point of view, we are getting an additional pleiotropic benefit, and that is again is extrapolated, and that probably is another factor which giving helps in the cardiovascular and renal outcome point of view. Again, of course, we know that GI side effect is one of the thing which is always the innate thing which attached to any sort of GLP-1 therapies. Here, there is definitely GI side effect is there, but they are mild. Because and another important thing is, if you are starting low dose and just gradually, as the guidelines says, to low dose for 4 weeks, then increase to little bit higher dose 4 weeks, then gradually if you are giving, probably this GI side effects will be actually taken care of. And the most important thing is that usually within few weeks this GI side effect went up. That means there will be significant reduction in GI side effects. You just give some prokinetics initially for a few weeks, and this GI side effect will significantly improve. And small frequent meal and less fat diet is the most important thing, should be given to, or it should be told to the patients, and that will take care. There particularly the GI side effects usually very mild. And there is always a risk, because when the Sustain 6 trial came, that the biggest Sustain 6, even Pioneer 6, both has shown there is increase in the retinopathy, risk of retinopathy. So again, that was a debatable thing, because till that period, not a single trial tried to see what is happening to retinopathy in any set of GLP-1 shift agonist trials. After that, due to this signal, actually they tried to see what is happening. Again, the risk of diabetic retinopathy is associated because there is some people has got, but that has been attributed to a rapid reduction in the blood glucose, because once there is a rapid reduction of blood glucose is there, then probably the risk of retinopathy increases. And but the benefit risk profile of GLP-1 use, including Ozempic, remains favorable, and that shows it can be used. And the most important thing is, even till date, no guideline has suggested that anybody who are starting GLP-1, a prior or baseline retinopathy checkup should be there. No guideline has actually suggested till that. Of course, in future, some guideline might come. But this is one trial focus RCT is actually going on, which will give us clear-cut idea. Really, it's because this we need a RCT to tell really it is a giving increasing retinopathy or not. And this is a dedicated trial for retinopathy which is going on. Regarding neon, we know there is another thing. There is no causal relationship, particularly with Ozempic versus neon because of RCTs. Rather than subsequent meta-analysis shown that those who are on placebo group, there is 8 neon has been found. In the Ozempic group, there is only 7. So probably the relationship is not there. Again, this is the European Association has clearly recently shown that it reduces the risk of neon rather than increase, because there is a initially when they got there is they thought probably there is some association there, but all meta-analysis and RCTs has ultimately of European guideline has come that it reduces the risk of neon instead of increasing. That is another important thing which has come with particular Ozempic. So retinopathy point of view, a trial is going on. Neon point of view, it is reducing the risk of neon, not increasing. So that should be very much clear to all our friends. And it is approved as a first line of therapy in diabetics, can be given in all patients who needs a powerful glycemic control, who needs weight loss and long-term cardiorenal protection. That is the most important thing. And dosing, as I have told, 0.25 4 weeks, then gradually increase to 0.5 4 weeks. Then you go to 1 milligram instead of jumping directly 1, because if you are directly going 1, probably that gives some sort of increase in the GI side effects or any sort of adverse events will increase. So start low dose and go slow. That is the motto of each and every GLP-1 therapy is what we are giving. So that is the way. So concluding that Ozempic has a long legacy of use. It has good glycemic control. It has weight loss up to 8 kgs there. It reduces cardiovascular risk. It reduces CKD. It is beneficial effect on the lipid profile. It reduces fibrosis or improvement in the fibrosis in MSC cases. Convenient once weekly dosing, and more than 7.5 million people has already used throughout the world, and the highest number of prescribed GLP-1 till date is particularly semaglutide. And with this much, I am completing my talk. And any queries, any questions, anything?
Abhay, thank you. I think fabulous talk. You know, I think Alok, it has been great. I have to ask you 2 questions because that is part of panel discussion. It will be repetitive. I just want to ask you that you compared resmetirom, which is approved drug for the NAFLD or whatever you call it, MASLD, and you compared that that takes care of the fat, and you said that this drug takes care of the fat plus fibrosis. I want a little bit of expansion of that.
Actually, resmetirom, it is actually, we know that this is a TSH receptor beta agonist. So that shows the mechanism action has shows it has some property like lipid, it has acts on the lipid cells, it acts directly on the lipids and also causes some sort of lipolysis and reduces triglyceride to free fatty acid and glycerol. That is one part. So in this way, there is some sort of removal of the fat. Also, it directly acts on the hepatocytes and hepatic ballooning, hepatic degeneration and ballooning is significantly reduced. And also portal inflammation is significantly reduced with use of particular resmetirom. But if you see the trial of resmetirom, all has shown once fibrosis is established, it has no effect. Till that period, resmetirom is giving up to 60% benefits, so there is a reversal up to 60%. But once there is fibrosis, resmetirom is not giving benefit. But here, with use of particularly this drug, what I am telling Ozempic, there is, as I am showing lipid profile point of view, we are getting all parameters reduced. And probably that is, once the lipid parameters is reduced, everywhere some lipid will come down. Not like that, only in the circulating cholesterol will come down. So there is removal of the fat from the liver. And as we know, any sort of, not only Ozempic, all GLP-1 has an anti-inflammatory property. So it directly acts on the liver cells. It induces or reduces the inflammation, because we know hepatitis steatosis and hepatitis all are inflammation. So local inflammation is significantly reduced. There is removal of the fat from the liver, and there is reversal of this inflammation is because essence has shown up to 49%, but fibrosis reversal is up to 30%. So
yeah, I think liver and the
Yeah.
next talk is hers.
Please.
I just one small question. Beautifully you said about the PAD, peripheral arterial disease. As you rightly said, we have no drug. We probably give silostazole, which may or may not
sir,
do
these are only improves the
Peripheral
circulation.
circulation.
The circulation.
Ah.
It has no effect on the pathophysiology.
Yeah, but
It
just
is targeting the pathophysiology.
correct.
There is improvement in the peripheral arterial disease, and the
Great.
atherosclerosis which is there,
Yeah.
it is found to be reduced
Yes.
with particularly.
Thank you, Abhay. So, dear friends, this drug should not be at the end of the algorithm. That's what Abhay said. This should be first line. The drug which reduces glucose, severe protection, and weight reduction should be the first line, did not be the last. So that's what you said. Number two, India is the country of diabetes. And if you're going to treat diabetes, as you rightly pointed out, Abhay, we have to take care of a drug which treats both obesity and diabetes beginning, and that was that. And so I'm giving a talk in Epicon on this. So it's a foundational drug, the first on drug for the diabetes. Abhay, it was marvelous. You took it to the highest heights. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir. Now we call on next speaker, Dr. Jayashree Swai. Needs no introduction. Professor, Department of Endocrinology and Metabology, IMS Sam Hospital. ESI President's Award for Appreciation 2025. Women's Physician of the Year Award, ACP India 2025. Oration in Epicon 25 Sanofi Apprentice Lectureship. Outstanding woman contributing in women's health by ACP India. And 50 national and international publications. She'll be talking to us on the topic called Crossroads of Care, the intersection between obesity and liver disease. That is
Awards of Women of the Year. One
Yeah.
is ACP.
And another is API. I think. Yes, yes. ACP India and
So great. Jayashree.
2 years continuously, 24 and 25.
Great. Leading women in endocrinology in our security. Yes.
A very good morning, everybody. Thank you, Alok sir. Thank you, Ashok sir, for giving me this opportunity. Thank you, Dr. Lalatendu, for giving this nice word of introduction. And it's my great privilege to be part of this forum. And I am being a part of this scientific forum. And it is my great pleasure to be work with Ashok sir, who is the son of the soil mentor, and is proud of not only Orissa for all over this India. So now, Professor Sahu has made my job little bit easier. Dr. Ipsita has discussed regarding the semaglutide and obesity. And Dr. Sahu has give more emphasis on the cardiovascular safety with the semaglutides. And I will discuss only one thing, is the one aspect of this semaglutide spectrum, that is obesity and the liver disease. And I'll give more emphasis on a trial, that is Essence trial. So then, as you know, now this term we are moving from the NFLD to the MSLD, and NAS to the MAS. So what is MAS and MSLD spectrums? And this is very beautifully given in the pictorial form. The first is the normal liver architectures, and the second is the steatosis, that is depositions of the fat in the liver cells, and hypertrophy of the adipocyte, followed by the MAS spectrums. That includes this histological classification, that is steatosis, ballooning, and inflammations. All are collectively known as the MAS, and which is lead to the fibrosis. And it is given beautifully in this pictorially here. So what happens in this MAS? There is hepatocellular damage, and which may lead to this fibrosis and cirrhosis. And the background is the chronic inflammations. So these MAS activities, if you look, that is steatosis, ballooning, and inflammations. If it is untreated at this stage, it may lead to this fibrosis. And fibrosis, we can classify it as mild, moderate, severe, according to that of the grading, which is given histologically and by the non-invasive test. That is F1, F2, F3, F4, and followed by the frank, peripetal, and fibrosis of thick cirrhosis, that is cirrhosis. This is this disease progressions of this MSLD and mass. So if you look to the global prevalence of this mass, then it is the pool data which shows that MSLD is prevalent around the 30% in all over the globes. If you look to the beautifully given in the pictures, every country, North America, Latin America, Middle East, South Asia, and that of the East Asia, and the average prevalence of is around 30%. So next is that this prevalent of this mass among these MSLD patients is as high as 16%, but the average is around 4 to 5% all over the, if you look global prevalence. So it is pool data of a large study. So it is around 5%, but it may extend up to this 16%. So then what is this factor that is causing this such prevalence of this mass and this MSLD? That is the obesity. Obesity is the main key driver for this mass. Then what happens? Those people who are living with obesity, they are living with the disease that for the chronic systematic inflammations and this metabolic stress or oxidative stress, and that may lead to the fibrosis of this many organ, chronic low-grade inflammation leading to the fibrosis of many organ. That may be the artery, which causes the which at the end of that scenario may be the CVD, CAD, or that of the PVD, or maybe the heart. It may have these inflammations of the heart leading to the heart failure, maybe preserved heart failure or ejection fraction, or that of the reduced ejection fraction, or it may have this effect on the pancreas. Chronic inflammation causes the diabetes, and also that of the kidney. It may have the CKD, and above all in liver, it causes the MSLD. So as a result of the chronic systemic inflammation, or other word I will tell it would meta inflammations leading to this fibrosis, it has effect on the CVS, liver, and it may have the risks of the cancer. Above all, the morbidity and mortality of this obesity patients are increased. So obesity is associated with more than 55 diseases, with the risks of cancer is increased 4 to 5-fold. Along with that, so also that of it has effect on the liver and the chronic inflammation causing that of this MSLD and increase the morbidity and mortality. I will concentrate on that part. Then what are these metabolic dysfunctions that causing MSLD, and what is the modifiable risk factor, what is non-modifiable risk factor? If you concentrate on the modifiable risk factor, it may be the age, sex, genetic factors, or no, if you that is non-modifiable. If it is a modifiable risk factors, you may consider the blood pressure, the dyslipidemia, or deranged lipid profiles, or inactivity. Physical activity has a great role, and you can modify that portions. So the result of that, all these modifiable and non-modifiable risk factors, they cause the oxidative stress, inflammations, low-grade chronic inflammation or meta-inflammation, and mitochondrial dysfunction, and gut mycobacterial derangement, or this gut microbial derived endotoxins or endotoxemia, and it alters the immune systems. That is the major, and causing type 2 obesity, type 2 diabetes, and also this MSLD and other consequence of this MSLD. So this is the pathophysiological mechanism. So what happens if somebody is having MSLD and followed by this mass and followed by this cirrhosis, then what happens? In this mass cirrhosis, we may have these increased portal pressures. As we all know, there is increased impaired synthetic functions, electrolyte dysfunctions, and malnutrition are the result of the mass associated with the cirrhosis. Simultaneously, there is health related quality of this life disturbs, there is chances of this hepatocellular carcinoma and other cancers apart from that, the liver, there may be these renal complications and these cardiovascular complications and ascites. As you know, this in every cirrhosis of the liver, there is ascites and chances of the G bacterial peritonitis and other things, and hyponatremia, hypervolemic hyponatremia is one of these major complications. So multi-organ involvement in these mass complications are there. In this background, there is a benefit of this semaglutide. Let us coming to this discussion point. So what is the beneficial of these semaglutides in this comorbidity condition? What is associated with the mass atherosclerosis or MSLD? So mass is associated, we know, as I have discussed, obesity, diabetes, hypertension, dyslipidemia, and inflammations. And semaglutide has a favorable effect on weight loss, increased glycemic control, cardiovascular risk reductions in these different trials, and improve lipid parameters, what has been seen previously, and it also reduced this inflammation, decrease CRP shown in the steps trials. So there is potential benefit of this GLP-1 receptor agonist on this all these modifiable and non-modifiable, so also the non-modifiable risk factors of the MSLD. So we have trials, phase 1 trial, phase 2 trial, and phase 3 trials. If you look to this phase 1 trial with the semaglutide and MSLD, there is no apparent effect on the liver stiffness, what we have measured in the elastography, but fewer patients have substantial increase in this marker of this fibrosis. But 50% of these patients decrease this liver fat, that is seen in this phase 1 trial, and there is improvement of this metabolic parameter, what I have discussed, the reductions of the total fat, reductions of the visceral fat, reduction of the inflammatory marker like the triglyceride fasting and the CRP. But if you look to the semaglutide phase 2 trials, semaglutide, there is significant benefit, higher percentage of the patients, they have the NAS resolutions without worsening of the fibrosis, and numerically high percentage of the patients, they have the improvement in the fibrosis without worsening of the mass, fewer patients of the worsening fibrosis, and improvement of the fibrosis biomarkers seen in the phase 2 trials. So because all these factors in the phase 2 trial, it has been seen that reductions of the body weight, reductions of the A1C, and the lipid parameters are there. So as I have discussed, these modifiable risk factors, so by modifying these, there is a benefit that is seen in these phase 2 trials. Let us look for these phase 3 trials. Phase 3 trials, that is a randomized, and it is known as the essence trials. Step trials are regarding the weight reductions, and other trials are the sustained soul, other trials are regarding these cardiovascular reductions, risk reductions, but essence trial here is for the MSLD patients. So here I'll go to detail bit a little bit detail regarding the inclusion and exclusion criteria. Those patients who are liver biopsy are performed within 180 days are included in these patients. So age, adult, and biopsy confirmed steatohepatitis, and stage 2 to 3, F2 to F3, not F4 or frank cirrhosis patients, they reversed with that of the semaglutide, what we have discussed in the previously. Staging is more important, and it is biopsy confirmed, that is. So next point is that key in exclusion criteria, other form of the cirrhosis of the liver, or other, if the patient is taking alcoholic, or that of the other like hepatitis A, B, C, all are causing the cirrhosis of the liver, they are included. Viral component is there, they have included from the study, or previously patient is taking the GLP-1 receptors or other medications, that is also excluded from the study. So histological getting the biopsy proven F2 and F3 are included in this study for this essence inclusion criteria. So what happened? How that what is this study design? Here they have given. Here they have taken 100 around 1200 patient participants. All are histologically proved steatohepatitis and stage 2, stage 3, F2, F3 disease, and they have given semaglutide 2.4 milligrams once daily along with the standard care versus that placebo. First is the titration phase, followed by this maintenance phase. And they have divided this study into two parts. First is stage 1, phase 1, that is up to 72 weeks, and next is this stage 2, that is up to 240 weeks. So the trial, it is multicentric, 37 countries are included in this study, and 250 sites are included. And as I have described, randomized, double blind. This is the beauty of this study. So what are the objective of the study? Primary objective and secondary objective is that improve this liver histology part. That is first part of the studies within 72 weeks. Second part of the study, it's lower the risks of this liver related clinical parameter. That is at the end of 240 weeks of this study. So coming to that part 1, what is the key result? The steatohepatitis resolutions with no worsening of the fibrosis at the week of 72. So that is the resolution of the steatohepatitis, which was histologically proven. There is improvement of this liver fibrosis without worsening of this steatohepatitis. That is the second part of this primary endpoint of this phase 1 study. If you look to the secondary endpoint of this phase 1 study, there is change in body weight and resolution of the steatohepatitis and improvement of the fibrosis. Fibrosis was not included in the primary endpoint. If it is there, it is better. So it is a secondary endpoint. So if you look to the part 2 of the study, that is up to 240 weeks. So what is the primary endpoint? Cirrhosis-free survival corresponding to not experiencing one of the following liver-related clinical event. That means histologically progression to the cirrhosis, all cause of the mortality, liver-induced MSL score, that is score is more than 55, liver transplant, and hepatic decompensation event is there. That is this endpoint, primary endpoint. And the secondary endpoint of that study was time to first major adverse cardiovascular event. So what is the result of that study? This is the demographic key parameters. 99% of the participants are more than 1 MSLE cardiometabolic criteria is there. 43% of these patients, they met the all 5 cardiometabolic criteria, and this cardiometabolic criteria ranges from that of the 41% to that of the 45%. As I have discussed, this cardiometabolic criteria ranging from that waist circumference, increased blood glucose, hypertension, to that of the dyslipidemia and other things, other inflammatory markers. And type 2 diabetes and normoglycemic patients are included in this study, and the BMI ranges from that 36.4 to that plus minus 7, and more number of the patients are the BMI range of the 35. So if you look to this inclusion non-invasive criteria, which we are taking by this elastography and other by other calculated score, 31% of the patients, they have this fibrosis stage 2, and 68% participants, they have this fibrosis stage 3. So these are the elastographic and the other non-invasive test criteria like FIB4, like PRO-C3, and that of the CAP and LSM. So what is the result? If you look at the primary endpoint, which is the steatosis resolution and improvement of the liver fibrosis, see at the end of the 72 weeks, there is 60% of these patients, 62.9% of the patients, they have the resolution as comparison to the placebo, where it is 34% and it is statistically significant. Similarly, that is improvement of the fibrosis seen in the tune of this 36%, which is statistically significant when compared with the placebo. So the next point is that steatohepatitis resolutions and improvement in the fibrosis. It is at the end of this first part study. Here 32% versus that of the 16% resolution of the steatosis with the improvement of the liver fibrosis seen in the semaglutide group as compared to the placebo. But standards of the care is given in the both these group. So next coming to this, what are these improvement in these non-invasive parameters like what we have seen in these fibroscans or other calculated parameters. If you look to this graph, that is significantly decreased downward trends at this from this beginning actually as of the 48 weeks, and it is sustained up to that of the 72 week. At the end of the study, statistically significant difference between the two groups. Similarly, the enhanced liver fibrosis scoring is also improvement at 24 weeks, and it is sustained up to that of the 72 weeks in this study, where they have given semaglutide 2.4 milligrams versus placebo along with the standard of care. So semaglutide improves hepatic and cardiometabolic parameters in these patients. How? It decreases by decreasing this body weight, NAS resolutions. It causes by decrease the body weight, decreasing these lipid parameters, improve these glycemic controls, cardiovascular parameters improvement by decreasing the inflammations, show NAS resolutions, disease activity, slowing of the disease activities, halting of the fibrosis progression, and improvement of the fibrosis will be there. So it will improve this long-term survival in these people, those who have this mass, MSLD, or fibrosis with steatohepatitis and steatohepatitis with fibrosis up to this stage 2 or stage 3. So, and coming to this safety effect, what has been discussed by this my previous speaker. So safety is at par with that of the other GLP-1 receptor agonist. No significant adverse effect is noticed in this study. Only GI effect, that is at par GI effect, vomiting, nausea, dyspepsia, and other GI parameters, GI side effects are there, and which is at par to that of the other GLP-1 receptor agonist and other study. So nothing to be specified here. So to summarize my presentation, significantly more patients achieving both histologically MS resolutions and improvement in the liver fibrosis, and significant change in the confirmatory secondary endpoint mass resolutions and fibrosis improvement, and it has a great effect in the reductions of the body weight, glycemic parameters, lipid parameters, blood pressure reductions, inflammatory reductions, so also reductions on the inflammations and improvement on the steatosis of the liver, and it has a good favorable effect on this mass with type 2 diabetes, without type 2 diabetes also. Thank you, sir, for your presence hearing. Thank you.
It has been a fabulous presentation. I mean, I like it. What you said, you have not lost anything part of the Essence trial. Thank you very much. What is my question to you? I mean, don't mind the question. You are the DM professor. Is the effect on the liver fibrosis is because of weight loss or because its impact on the liver?
Sir, thing is that the first part of my discussions I have discussed what causes this MSLD. That is obesity, that is the unfavorable lipid profile, that is hypertension, that is other chronic low-grade inflammations, that is responsible for that after MSLD. And the obesity is causing all these things. So these molecules, I'm not going to the semaglutide, GLP-1 is a molecule that will have a favorable effect on all these parameters, and also inflammation, reduction of inflammation is one of the important matter, and it will reduce the chronic endotoxemia.
I think I wanted that answer, that the effect of semaglutide injectable 2.4 is not only because of weight. Because somebody made a comment, anything that loses weight will improve muscle.
No, sir, that is
not true.
It is in this cardiovascular trials, this improvement occurs at the beginning, before achievement of the 30 graph is separate.
The oral semaglutide itself has impact on the liver fibrosis.
Yes,
therefore, in 2025, the FDA did the label expansion and said this drug can be used for preventing liver fibrosis because it prevented 37% of cases. The second question, again, a pointed question to you, because we have done extremely well the presentation. Now, can we transcribe similar effect? Will it be possible to get from the oral semaglutide? Now they are doing, as you said, C11, number 11 trial. It is
Yeah.
possible to transcribe the results from the oral semaglutide. Anything possible?
Sir,
Literature-
it may be the class effect. You may not get the such type of such extents of a 32% fibrosis reduction, but it is possible because of this. We know this favorable effect of the GLP-1.
Yeah.
GLP-1.
I
Sir,
think
it may be
great
possible.
talk. So this is a new chapter in the history of muscle, and other drugs might come, but in today's only injectable 2.4 Wegovy has this result that it can reduce the inflammation. Rightly she said up to F2 in 63%, and in 37%
In
it can
F3.
also
F3.
target the fibrosis. Therefore, this finding was so far not available, and most important, the safety and the tolerability.
Tolerability.
That is the drug which is safe and tolerable. And finally, this drug can be a game changer because it addresses CKLM, C cardio, kidney, M for
Liver.
metabolic, and L for liver. So this trial has shown that these drugs are CKLM friendly. Thank you, Jesse. Thank you
sir.
very
Thank
much.
sir.
Thank you, sir, for excellently summarizing the effects of semaglutide in liver cirrhosis and fibrosis. The most wonder is that it causes reversal of fibrosis. That is the most wonderful effect. Yes, F2, of course. But reversal is a very wonderful achievement. And to finish the session, we have our last speaker and the youngest speaker, of course, Dr. Sukriti Jaina, who's the consultant endocrinologist, Kalinga Hospital, Bhubaneswar. She has been the university topper and gold medalist in her MBBS career. Young scholar in endocrinology, TOISA 2023, has been second runner, second prize quiz in Inspire 2022, and a lot of other prizes. 6 publications in national and international journals.
Correction, 20 publications.
It's written, sir. Sorry for that. 20 publications. And she has got received first prize in OSCON quiz 2019 and 2022. Thank you, Secretary. Please.
I must start the Indian girl, women endocrinology.
Yes.
Very strong. I was talking to Lakshmi. They have a colleague there, Lakshmi Nagapura. He publishes every alternate day. I said, our Indian girls are even superior.
Yes. She'll be speaking on single agent, supreme results, semaglutide winning the CKM story. Please do.
Thank you, sir. Thank you for those kind words. A very good afternoon to everyone, all chairpersons, faculties, and delegates. After 3 brilliant sessions on semaglutide, I don't think there's much left to say. However, I would like to emphasize on the fact that semaglutide is not competing with other drugs. It is now competing with the history of obesity itself. So with that, I'll start my presentation, acing the MACE paradigm, selecting semaglutide 2.4 for CV care in people with diabetes, without diabetes, overweight, obesity. So this is my disclosure. It has been supported by Novo. Now my agenda is, now obesity is not just a cosmetic concern. It is a disease with different metabolic effects, whether it's CV, it's MASH, or it's dyslipidemia, hypertension, all these are associated with obesity. Secondly, most importantly, now for obesity management, we need a drug which is not only important for weight loss, we want it to touch all these complications of obesity. So what are the benefits of semaglutide? So everyone has been speaking about obesity and the burden of CV deaths, how almost 2 million of CVD deaths are attributable to elevated BMI. CV mortality has decreased over the last 2 decades, but the CV related deaths in overweight and obesity has increased up to 3-fold. So 1 point increase in BMI above the normal weight, it causes a 10% increase in the risk of atherosclerosis and coronary heart disease. And you can see the numbers, almost 80% of MASH patients are obese, 70% of CKD patients, almost 70% of primary hypertension are obese patients, almost 15% of heart failure cases are obese, more than 80% of coronary heart disease patients are obese, and almost 40% of stroke patients are obese. So yes, weight loss itself independently does improve CV risk factors, whether it is reduction in blood pressure or lipids or glucose or insulin resistance and inflammation. And since we know that overweight and obesity is associated with these multiple risk factors, the guidelines recommend a sustained weight loss. This is an important point, not just weight loss, a sustained weight loss in patients with overweight and obesity to reduce the CV risk factors. So yes, there is an unmet need, or there was an unmet need for therapies that reduce the CV risk events and support weight management. As sir was saying, see, weight loss it improves the traditional CV risk factors, but has it been an effective strategy to reduce CV risk reduction? No, not independently, except for bariatric surgery induced weight loss. Now, this is important because as sir was discussing how bariatric surgery, the equivalent weight loss is also seen with GLP-1 analogs, but this CV risk reduction is also seen in bariatric surgery because it also alters the GLP-1 biology almost similarly as GLP-1 analogs. When we talk about SELECT trial, it is one of the largest CVOT trials, which expanded over 41 countries, more than 800 sites with almost 17,000 participants, and almost 492 from India. It was a double-blind, placebo-controlled superiority trial with semaglutide versus placebo plus standard of care, with primary endpoint was the time from randomization to the first occurrence of composite endpoint, including CV death, non-fatal MI, non-fatal stroke. Confirmatory secondary endpoints, time from randomization to occurrence of CV death, composite heart failure endpoint, or all-cause death. So semaglutide 2.4 milligram, the first and only anti-obesity medication, which showed CV benefit with 20% reduction in the 3-point MACE. The EAC 2024 obesity and CVD clinical consensus statement, also in the pharmacological treatment obesity, does mention the other older drugs like orlistat, bupropion, naltrexone, which should be used cautiously in these patients due to modest weight loss and limited CV safety with potential long-term CV risk. GLP-1 RAs are effective for weight loss and also additionally improving the CV risk factors. So this once weekly sema 2.4 milligram is the only weight loss intervention with proven efficacy in patients who have established CVD without type 2DM. So this SEMA has surpassed other anti-obesity medications with proven superiority in SELECT in reducing CV events. So there have been older trials on older drugs like Scout, Crescendo, Light, Convene, Camellia, and ongoing trials like Surmount MMO, which is with tirzepatide, Redefine with cagrilintide and semaglutide, Synchronized survodutide. But the results of SEMA in SELECT trial, which shows that it has surpassed all these other drugs and has proven CV benefit. Additionally, also it has been approved in India by the CDSCO on 25th Feb 2025 to reduce the risk of CV events in obesity. So after randomization, almost on day 20, the first statistically significant MACE reduction was seen in the SELECT trial, and by day 86, the sustained the significant difference was sustained in observed on day 86 since randomization. So it was a sustained effect, and this early MACE reduction, it showed a meaningful weight loss and a sustained weight loss, suggesting an effect of semaglutide, which is beyond the weight loss reduction. So 80% of this MACE reduction was mediated with factors beyond weight. Also, it does have other effects on the endothelial lining, whether it's the myocardial energetics. So as we spoke about the hepatic steatosis, mitochondrial increases the fatty acid oxidation in the hepatocytes. So it is just not about reducing the fat mass. It has other effects on these points which are seen in obesity. So has these benefits been replicated in real world? So we have real world evidence. We have the SCORE and STEER studies, which SCORE was a retrospective longitudinal observational study, and STEER was propensity match cohort, which was versus tirzepatide specifically, and SCORE was SEMA versus non-SEMA. So it showed that SEMA showed a better reduction in whether it was a 0.5 point MACE or a 3-point MACE or a all-cause mortality. And this gave an idea that it was not a class-specific benefit, but rather a molecule-specific benefit for independently as semaglutide. And if you talk about numbers, it demonstrated further benefits with almost 70% reduction in the risk of composite outcome of CV death and heart failure events, 73% reduction of HF events, and improvement or 25 meters improvement in the 6-minute walk test. So it reduces the risk of composite CV death or even the first worsening of heart failure event. So summarizing, I spoke, basically it was a summary of the SELECT trial, how semaglutide is beneficial in obesity or overweight in reducing the MACE risk points without diabetes. And despite standard of care, the burden of CV events is still high. And semaglutide is the first and only obesity medication with a proven 20-point MACE reduction. And CV benefits are seen immediately after initiation and have been shown to be sustained even after a factor beyond the weight loss. And it showed consistent CV benefits across real world evidence studies. And in steer, it showed that it is a better molecule when compared to tirzepatide when we talk about MACE reduction. So with that, I end my presentation. Thank you for your patient hearing.
I think Sukriti, I think the gold medal university topper and everything is very well justified. Taisa award and the winning of the most important quiz, all these justified in your talk. What you said is very true. That why we call it semaglutide is a supreme. That name you have given, huh? Is a supreme agent, a supreme result. I think that's what is justified. I'll tell you why. You know, so far diabetes treatment, they say it is broken. It goes to cardiology, it goes to nephrology, it goes to hepatology, it goes to foot surgeon, it goes to everybody. So they said diabetes care used to be in silos. Everybody has one silo. But semaglutide is a single drug which takes care of the cardiac, renal, metabolic, not only takes care, weight and liver disease. Therefore, a single agent which can take care of all the things is a supreme agent. I've got two questions to ask you, which I noted down because order from the boss. Two questions we asked for making actually the questions are here. We can pass on to everybody. The question itself is on the website. Now, please tell us out of all this impact, super results of oral or injectable 2.4 sema, which one you think is the most important?
Out of all the results.
Which one?
Sir, out of all the
All
results.
these four results, sir. 4 or 5 results. Weight, hepatic, liver, kidney, cardiac.
Sir, I think it's like choosing between 5 children. But
I hope you left happy.
no, my mother-in-law will be very happy to hear that. So, sir, I think still going against what I spoke, I said that obesity is independent effect than the CV risk reduction because they have independent effects on the inflammation, endothelial barriers, mitochondrial energetics, myocardium energetics. But still, I would say because obesity is the primary driver of everything, we want a sustained weight loss that will again decrease in the weight loss also will additionally reduce the risk points for all these CKLM associated with it.
The last question. You said is an endothelial lining affecting drug. So I think that's also one of the endothelium is the largest endocrine gland that we have taught us. Now, with when it impacts the largest endocrine, so that prevent the leaky syndrome, UACR, albumin excession. It provides through that cardiac safety. What's your comment on that?
Definitely, sir. Microalbum, if we are talking about leaky capillaries or leaky vessels, microalbuminuria is just not about the kidney. It is a marker of generalized endothelial dysfunction. But when we are seeing albumin in the urine, that means it is already leaky in the heart, in the liver, other places. So definitely, so microalbuminuria reduction is an indicator that it is acting in all other spaces correctly.
Thank you. Great. I'll give it to Sir. But Sir is the vice principal, so he is the right person to summarize that.
Nothing related to this. An excellent presentation, Dr. Sukriti. And Sir has asked the gem of questions to enlighten us, the speakers and the audience. And it has been a good session. I again thank to Dr. Kanungo and all the speakers have been excellent. Youngest and the best. So we can close the session, sir. It says close the session time. Thank you, everyone.
Thank you.
That was really highly engaging session highlighting the evolving role of weight management and GLP-1 based therapies in diabetes care. While lifestyle and pharmacological interventions play a vital role, insulin remains a cornerstone in achieving durable glycemic control for many patients. With this perspective, we now move to session 8, basal insulins, strong foundations organized by Sanofi India. I invite Dr. Alok Kanungo, Chairman, Chief Consultant, Dr. Kanungo's Diabetes Center and Kids Hospital, to kindly come forward. I also invite Dr. B.D. Sahu, MD Medicine, SCB Medical College, Cuttack, to please join us on the dais. Thank you. Thank you so much.
Dear friends, now we have an interesting session on basal insulin, strong foundation. We have some academic support from Sanofi India. And we have two great speakers in this, Dr. Neeraj Mishra, who will be speaking on Iglar Lixi, a solid approach to break treatment complexity, and Dr. Ramesh Goenka, the evidence continuum for second generation basal insulin. I request my co-chair, Dr. B.D. Sahu, Chief Medicine Specialist of Kids Hospital, to introduce Dr. Neeraj Mishra.
Thank you, sir. So now we'll go to the next session, the basal insulins. Actually, basal insulins are very important in the management of diabetes mellitus because previously we were using the NPH. Now the second generation basal insulins, the glargine and degludec, they are very essential because they have long effect 24 to 42 hours, so less number of takes and patient compliance is more and chance of hypoglycemia is very less in this second generation basal insulins. So two agents like rhizodec, the degludec and the insulin aspart, they are very important nowadays in most of the patients. And the insulin glargine and lexanatide, a GLP-1 receptor agonist combination, help in control of fasting hyperglycemia and postprandial hyperglycemia by decreasing the insulin emptying. So these are very helpful. Now for this session, we have two speakers. First speaker is Dr. Neeraj Mishra, the eminent diabetologist and endocrinologist of Bhubaneswar. I request Dr. Neeraj Mishra first please to come to the desk to speak and to elaborate on this.
I think just a good noon, I'll say. It's neither morning, neither is afternoon. And my regards to Sir Namaskar, Alok Bhai, and all the seniors and my friends. Basically, we know that diabetes is a very complex metabolic disease. So complex means metabolic means you need lot many things to give it to a diabetic. Not only about the blood sugar control, the blood you need drugs to control the lipids, to control the blood pressure, maybe something for the liver also. So basically a person requiring lot of medications. So again, that is a complex treatment approach. So there comes adherence and persistence. Lot of medicine means patient probably will not be compliant. So in that context, we'll try to find a solution so that while managing diabetes, can you give a single agent that takes care most of the part of the diabetes management so that we can make it a simple approach in treating such a complex disease. In that context, we will be discussing about the role of insulin glargine and lexasenatide combination, what we call the IGLAR Lixi, and its role in management of type 2 diabetes. And we know that type 2 diabetes is simply is exploding. The incidence is going day by day is increasing. I'll just differ slightly from what is written here, and it's about 89.9. So that is millions diabetics in 2024 as per the IDA perspective, and as per the ICMR study, we have already crossed the 100 million mark. And unfortunate part of it is 50% are still undiagnosed, and we are just only seeing the tip of the iceberg of diabetics. And more than 10.7% is the means proportion of adult patients who are diabetic, and is only going to get worse over the period of time. So basically what we need that you give oral anti-diabetic drugs, and maybe we just also start the patient on drugs on basal insulin, maybe if you are failing to achieve a good glycemic goal. Then what are the other options when you need advancement? Because diabetes is a progressive disease, so you need to give more drugs, and probably over a period of time as the beta cell dysfunction continues and worsens. And then the option becomes you have got a basal insulin, and once you add to that basal insulin, what the common approach is called a basal plus. It means you give one sort of a bolus insulin. Then if required, you have to go for multiple boluses. That what ultimately leads is called a basal bolus therapy. So multiple injectable drugs, or you go for a premix insulin, which is commonly used in most part of the world, including our country also, where you give two sorts of a premix insulin. So then again, it needs two injections. Or you give a basal insulin plus a GLP-1 receptor agonist, which is more commonly recommended that you go for before means you giving basal plus or basal bolus, you give a basal insulin and a GLP-1 receptor agonist. If you give it separately, then again two injections, or you give a fixed ratio combination of a basal insulin and a GLP-1 receptor agonist. So that is, we need only one pen. So convenient is only you give one pen. So that is convenient. So let us look at what are the options, what are the advantages and disadvantages of it. You give a basal plus or continue to a basal bolus and start with a single prandial dose, and then go on to give required 2 doses or 3 doses. It has a greater flexibility for people with irregular meal habits, so greater flexibility, but the risk of hypoglycemia, more insulin number of pricks means risk of hypoglycemia, and frequent blood glucose monitoring is required, and even the weight gain related to insulin therapy, and adaptation of the bolus to food, and negative impact on treatment adherence, quality of life. 4 sorts of insulin a day has a negative impact on quality of life. Premix insulin is convenient, but the problem is that titration is difficult and increased risk of weight and hypoglycemia. Then once you add a GLP-1 receptor agonist, that is convenient, and the only that there is a lower risk of, definitely lower risk of hypoglycemia and weight gain compared to when you amplify the insulin therapy. And they do have an advantage of weight loss and organ protection with at least some of the GLP-1 receptor agonists. But they do have the gastrointestinal adverse effect, and there is a requirement that you have to give 2 pricks, once a basal insulin, one a GLP-1, and you need to adjust the dose of insulin also. Coming to the fixed ratio combination of basal insulin and GLP-1, so it is one short injection, and the potency of both the basal insulin and GLP-1 receptor agonists are there, so better the control of blood sugar. The insulin requirement is reduced, less weight gain and hypoglycemia, easy dose titration. So once a prick, so you easily adjust the titrate the dose, and once daily administration. So what the opportunities that a single prick will provide? The opportunity addresses multiple physiological defects using combination of various anti-diabetic drugs to complement, having complementary mechanism action. So when you give a combination, increase convenience, of course, and improved adherence, one sort. Earlier achievement and greater persistence of glycemia and other therapeutic goals. Potential reduction of risk of side effects with combined drugs at a lower dosage. When you start with the lower dose and gradually titrate, the side effects will be less. And potential to delay underlying disease progression and disease related vascular complication, because you have a better glycemic control. So what basal insulin part does is that it targets the hepatic glucose overproduction by decreasing gluconeogenesis, thereby reducing fasting blood glucose. What the GLP-1 does is that we know that it has a glucose-dependent insulin release, causes from the beta cells, decreases glucagon secretion from pancreatic alpha cells. There is delayed gastric emptying, and so thereby reducing postprandial glucose excursions. So combining them takes care of both the fasting and prandial component of blood sugar. And we know about this ominous octet where insulin takes care of the excessive glucose production from the liver by decreasing gluconeogenesis. It also improves glucose uptake into the muscles, and it also reduces lipolysis. So it takes care of the three of the pathogenetic mechanisms, whereas GLP-1 takes care of the beta cell function, improves beta cell functions, also has a alpha cell decreases glucagon secretion effect on the alpha cells, improves satiety of working on the brain, and decreases gastric emptying. So basically, when you combine these two, it takes care of 7 out of the 8 pathogenetic mechanisms. So what about the guideline that say about the combination? We start way back in 2022, ADA-ESD statement says that the combination of a basal insulin and GLP-1 receptor agonist results in greater glycemic lowering efficacy than monocomponent, with less weight gain and lower rates of hypoglycemia. Then 2023 S guideline says that once somebody has a failure with OAD or a GLP-1 receptor agonist, basal insulin should be added alone, or a basal insulin, or as a basal insulin GLP-1 combination injection. So we add to the GLP-1, add a basal insulin alone, or give a combination of it. ADA 2025 says that a combination of basal insulin GLP-1 has potent glucose lowering action and less weight gain and hypoglycemia compared with the intensification of insulin therapy. IDF 2025 says that fixed dose combination of GLP-1 and insulin are administered once daily and aim to optimize efficacy and minimize drawbacks associated with the individual components. And as per the latest ADA 2026 standard of care, a GLP-1 receptor agonist, either as an individual product or a fixed ratio combination with a basal insulin product, or a dual GLP-1 GIP receptor agonist, should be considered prior to starting prandial insulin to address prandial management and to lower the risk of hypoglycemia and weight gain associated with insulin therapy. So you give either GLP-1 with basal insulin or a fixed dose combination, or you give a GIP GLP-1 receptor agonist before you if you start the prandial insulin therapy. So what are the clinical evidence for Iglar-Lexi? So we'll go for the solid dig study. This is basically patients who are suboptimally controlled oral antihyperglycemic therapy. They are insulin naive. So it is a 24-week open label phase 3 study done in China, and where it was compared with IDEG-ASP, one sort of IDEG-ASP and one sort of SOLID. So that is how the one sort of Iglar-Lexi. So the study was there. So 291 patients on either group, and the baseline patients were on poorly controlled on metformin plus or minus second oral anti-diabetic drugs. 50% them were there of SGLT2 inhibitors. The BMI of less than 40, HbA1c 7.5 to 11 if the patient on metformin plus or minus SGLT2, or it is 7.5 to 10 if they were on metformin on second non-SGLT2 oral anti-diabetic drug. And this was a 24-week study. The primary endpoint was non-inferiority in HbA1c change from baseline to week 24. So these are the baseline that they were matched. So there was an average around 56 to 57 years of age. 48% were female. BMI was around 25, and duration of diabetes was around 8 to 9 years. HbA1c was around 8.5. When you look at the result, the HbA1c reduction appears to be better with a mean difference of around 0.2%, and it was found to be non-inferior. Not only it was found to be non-inferior, it was also found to be superior. So there is a superior reduction in HbA1c Iglar-Lexi vis-a-vis IDEG-ASP. And then when you look at the secondary endpoints of body weight, so there was some increased body weight with IDEG-ASP, what is around 1.2 kg, and there is some reduction of 0.3 kg with a difference around 1.5 kg in body weight difference, favoring Iglar-Lexi. Other key secondary endpoints like HbA1c reduction less than 7, HbA1c reduction less than 7 without body weight gain, or HbA1c reduction less than 7 without body weight gain, and no hypoglycemia is also significantly better with Iglar-Lexi in comparison to IDEG-ASP. And when they do a 7-point self-monitoring plasma glucose profile, it was found that the blood sugar was better controlled post-prandial, particularly post-breakfast and post-lunch. And overall, there was a difference of blood sugar of around 7.9 milligram per deciliter. And insulin dosage was also lower at the end of the study when you compare AS versus Igler-Lixi. Overall hypoglycemia incidences were lower, whether it is any hypoglycemia, ADA level 1 hypoglycemia, ADA level 2 hypoglycemia, but they were not statistically significant, but numerically lower. Just to summarize what the study says, that in SOLID study, Igler-Lixi vis-a-vis IDEC-ASP, it was non-inferior and statistically superior HbA1c reduction, superior body weight benefit of 1.5 kg. More patient could achieve the composite outcome of HbA1c less than 7 and without hypoglycemia, and lower risk of hypoglycemic events and no unexpected safety findings. So that was comparing IDEC-ASP versus Igler-Lixi. And then there is another study that looked after one dose of Igler-Lixi vis-a-vis 2 doses of bias 30. So what we call known as Novorapid. These are the patients, again, open label randomized 26 weeks phase 3B study. And these are the patients who are on basal insulin plus oral anti-diabetic drugs. And once you want to optimize, so instead of basal, whether you give Igler-Lixi or you give premix insulin, that is Novomix twice a day. So that was the study. And this was again a 26-week study. It was done in 17 countries, and total 887 participants. India contributed 182 patients to that study. So this study also is important so far as our country is concerned. And when they looked at the primary outcome, there was a superior HbA1c reduction of 0.2. When you give premix instead of you give Igler-Lixi instead of premix, this bias 30 to that patient who are poorly controlled basal insulin oral anti-diabetic drug, HbA1c reduction appears to be better, and this was statistically superior. And body weight also appears to be there is a favorable effect. So body weight of around 1.9 kg favoring Igler-Lixi instead of bias 30. HbA1c reduction of less than 7, HbA1c reduction less than 7 without weight gain, and HbA1c reduction less than 7 without weight gain and without hypoglycemia also better with Igler-Lixi vis-a-vis bias 30. Total insulin doses were also lesser with Igler-Lixi. There is a low risk of hypoglycemia, whether any hypoglycemia, ADA level 1 hypoglycemia, ADA level 2 hypoglycemia, there is significant reduction, and these are all statistically significant findings. And when you look at any risk of hypoglycemia, anytime particularly, we are worried about the hypoglycemia in the late night from 12 p.m. to early 12 midnight to 6 o'clock in the morning. There is a 68% reduction in ADA level 2 hypoglycemia, means any hypoglycemia less than 54 milligram per deciliter. And between bedtime and waking also, the reduction was quite significant, 63%, because we were worried about the hypoglycemic part of the night, because they were usually missed or could not be attended at the earliest. Just to summarize what we discussed is that when you compare Igler-Lixi vis-a-vis bias 30, so there is a better glycemic control with weight benefit, less hypoglycemia and fewer daily injections, and similar proportion of serious adverse effect. Then there is another study called a once you tell in that SOLI-mix, continuing that SOLI-mix study, participant receiving Igler-Lixi received a complete or mark. This is a questionnaire given to the patients in that study, and once they assess that there is a marked improvement in diabetes control compared with those receiving bias 30, and people are satisfied. When you satisfaction is 81% satisfied Igler-Lixi, it is 63% bias 30. When you talk about the patient satisfaction also, it appears that Igler-Lixi is better than bias 30. And This is a pen. We start with the ratio of 2 units of glargine and 1 microgram of lexacenatide. So the starting dose is 10 units, means 10 units of glargine and 5 units of 5 microgram of lexacenatide. And the 3 ml pre-filled pens and containing 300 units of insulin, glargine, 150 micron lexacenatide, and the dosage ranges will be discussing how to start the dose. The starting dose is for insulin naive patients or somebody on glargine less than 20 units. The starting dose is 10 units. Then you uptitrate every week depending on the fasting blood glucose done on the previous 3 days. So average on the blood glucose, you go on increasing the increasing the doses till you achieve the highest dose of lexacenatide, that is 20 microgram, and that corresponds to a in the glargine dose of 40 units. So 40 units of glargine and 20 microgram of lexacenatide, that's the highest dose you can achieve. You start with 10 units or 20 units depending on the requirement. If somebody was already on say glargine of more than 20 units, start with the 20 dose. 20 dose means 20 units of glargine and 10 units of lexacenatide, and then go on uptitrating. Maximum you can go for a 40 units of insulin, glargine, and 20 microgram of lexacenatide. That's the highest dose you can achieve. And the dose titration, as I was telling, if it is between 100 to 140 fasting blood sugar, so what you do, you uptitrate by 2. Between 80 to 100 fasting blood sugar, no change. If when the blood sugar starts to coming down, reduce the dose by 2. The timing is that it should be given subcutaneously within 1 hour prior to any meal, preferably a convenient meal. So lunch is, somebody is staying at home, so lunch is the convenient meal. Take it, if you are taking lunch 2 o'clock, give it any time after 1 o'clock. And if somebody is taking in the breakfast, somehow misses taking it in the breakfast, he can take it in the lunch time. And uses in special population, it can be used in elderly persons, and no dose adjustment is required. Renal impairment can be used up to eGFR of 30. No dosage adjustment is required. Pregnancy, it should not be used, it should be discontinued. And hepatic impairment, it can be used. Just to summarize, so basically this is one injection, give it once daily, and within 1 hour of prior to the meal. And the potential benefit of potential benefit fixed ratio combination, the lower rates of additional or lower rates of hypoglycemia, I'll say, improved GI tolerability, and then monocomponent effective HbA1c reduction, not only HbA1c reduction, fasting and postprandial blood glucose control, and there is some weight benefit, once daily dosing, and more people achieving glycemic targets, and address of multiple pathological defects. Just to summarize, there's some mix. So this is SOLID-D trial indicates that Iglarlix is efficacious, simpler, well tolerated, provides better glycemic control, weight benefit, and less hypoglycemia compared to IDEC as not bias 30. And SOLIMIX trial indicates that Iglarlix is efficacious, simpler, well tolerated, provided better glycemic control or weight benefit, and less hypoglycemia compared with twice daily bias 30. There is another trial which I have not mentioned because lack of time, that is called a SOLI-SWITCH. This is the patients who are on a premix insulin bias 30. They were not controlled and they were subsequently changed to Iglarlix. And what they found out that not only there was a better glycemic control, the HbA1c reduction was about to the tune of 1.2%, hypoglycemia incidence was less. Also, there is some weight benefit. So when you come talk about the SOLI-SWITCH study, it indicates that Iglarlix might be a simple and effective treatment option associated with improved glycemic control without body weight gain or increased hypoglycemia, and the patient particularly who are not controlled or premix insulin. I think that's all. Thank you.
Thank you, Dr. Neeraj Mishra, for your excellent presentation. Now, this is a new drug, and you have given everything very nicely. Sir, a question will be taken at the end of the session in the panel discussion. Now, I request our next speaker, Dr. Ramesh Kumar Goenka, will speak on evidence continuum for second generation basal insulin. Dr. Goenka presently the consultant physician and diabetologist Bhubaneswar. He is the chairman RSDI Odisha, professor of medicine KIMS Bhubaneswar. He is the principal investigator PODIS study, ex chapter secretary RSDI Odisha, organizing secretary RSDI Odisha 2015, 2018, 2019, treasurer national RSDI 2017 Bhubaneswar, national and international publications in Index Medicus. I request Dr. Goenka to start, please.
Good morning, friends. First of all, I'd like to thank my good friend Alok Bhai for inviting me to this session. Hello. And with due respect to Professor Das, I'll start my session on second generation basal insulin. We all know about Tuzio by now, that it is now competing with the best basal insulin available to us, that is insulin degludec. So after degludec, if you know anything about the second generation insulin, is Tuzio. So the evolution, we know that we started our journey with NPH insulin, and NPH insulin was till 1991, we had no other choice than NPH insulin with frequent midnight hypos with the insulin. And if you change the timing, maybe daytime hypos and early morning fasting hyperglycemia. So we had a real, or if you make it twice, then again you get two hypos, because there was a peak at 4th hour with NPH insulin. So we came with Lantus in 2000, and then Lantus, that insulin glargine was really something which is which has changed the scenario, and we had a gold standard insulin which was lasting with a half-life of more than 20 hours, and it was a true basal insulin available to us. But there were still certain unsaid limitations of the insulin, and the quest continued, and we had ultra long-acting insulin degludec, and to overcome the same thing, the glargine molecule was modified to U300, and then to get the similar effect, what the advantages we are getting with insulin degludec. So advantage of second generation insulin, if you see, it has a robust glycemic control, less hypoglycemia, safe during titration and maintenance, minimal weight gain, flexible dosing, stable and prolonged action, less glycemic variability, effective and sustained glycemic control, and less overall and nocturnal hypoglycemia. That was the best part of this insulin, which was not covered with Lantus. So why this difference comes with U300? Because molecule is same, just polymerization and making it more concentrated. How does it make a difference? The first thing is change in surface area. If you see the same molecule, equivalent molecule of U300 and U100, the surface area of the depot is reduced, hence the dispersion is reduced. You can see in the diagram that the lower one is U100, the surface area and dispersion, and upper one is 300, the similar amount, the smaller area and the dispersion is slower. And we have a strong wall of evidence in terms of glargine 300 in comparison to 100 and insulin degludec. And in all, it has proved non-inferiority in terms of efficacy and advantages in terms of nocturnal hypoglycemia and severe hypoglycemia. In terms of PKPD, in terms of its effectiveness, in terms of hypoglycemia, we have PKPD study, additions program, deliver trial, type 1 diabetic effect, and patient experience with glargine 100. And we have a PKPD comparison and patients with high hypoglycemic risk, special population, and then BRIGHT study, one care study, and this in-range trial all have compared insulin degludec with glargine 300. So BRIGHT study, it has compared, we have seen that insulin degludec versus glargine U300, The eligible population were more than 18 years. HbA1c was, the baseline HbA1c was more than 7.5 to less than 10.5. OAD use plus GLP-1 was more than 3 months, and there was no prior insulin use. This was the eligibility criteria. The insulin was started at 0.2 unit per kg as per the labeling, and the initial active titration period was 12 weeks, and then maintenance phase was 12 weeks. So 24 weeks trial, and then the follow-up the study was ended. So the results were, it has proved non-inferiority to insulin degludec in terms of efficacy. And if you see the reduction in overall HbA1c over 24 weeks, both are similar. The percent of population achieving the target HbA1c of 7 is also similar in both the arms. And incidence of anytime confirmed hypoglycemia with a cutoff of 70 is 26% less in Glargine 300. Incidence of confirmed hypoglycemia with cutoff of 54 milligram was 37% lower. Event rate anytime with confirmed hypoglycemia less than 70 was 23% less, and event rate anytime with confirmed hypoglycemia less than 54 was 43% less. And nocturnal confirmed hypoglycemia with a cutoff of 70 milligram per deciliter was 35% less. So early hypoglycemic events during titration, this was the initial 12 weeks period. So early titration, if you get frequent hypoglycemias, the patient is afraid of taking insulin, and we have many dropouts in the study. So Glargine U 300 offers an advantages in hypoglycemic risk reduction versus insulin degludec during the titration period in insulin naive patient with type 2 diabetes. This is a safeguard trial. The aim was to evaluate the efficacy and safety of insulin Glargine 300 in insulin naive adults with type 2 diabetes in India. It addresses the lack of Indian data, and the study design was, it was a multicentric phase 4 interventional single arm open label 24 weeks trial conducted in 15 centers in India from August 21 to December 22. The study population were insulin naive patient more than 18 years with type 2 diabetes, and HbA1c was more than 7.5 or less than 10%, and patients were more than or equal to 1 OAD and plus minus GLP-1. The exclusion was prior insulin use in last 6 months or prior injectable anti-hyperglycemics and contraindication to Glargine 300. The endpoints were the percentage of participants with treatment related adverse events and serious adverse events and hypoglycemic events. So if we see the efficacy and safety, the HbA1c reduction in all the baseline and 12 weeks and 24 weeks, these 3 graphs you can see that the HbA1c reduction is significantly there. You see glycemic efficacy 159, 129, and 122 in 12 weeks. After 12 weeks, of course, the reduction is not, you don't expect also that it will further reduce. It is maintaining its hypoglycemic effect. And the treatment with SMBG also showing the same result. HbA1c targets were also achieved in the similar way. And safety profile, if you see, again, it is showing a good safety profile. And the body weight, the minimal weight change of 0.1 kg, and DTSQ satisfaction score, if you see, that is improved. Pre-trial, it was 21.2, and post-trial, it is 31.3. And common treatment-related adverse events were infections, general disorders like admin site condition, dissatisfaction, and GI disorders. So clinical implications were Glargine 300 was well tolerated with low hypoglycemia risk and meaningful glycemic improvement, and that supports Glargine 300 use in insulin naive Indian adults with type 2 diabetes. So this was the first purely Indian data available to us. So now we discuss Glargine U 300 in special population, the management of hyperglycemia in certain population where there is more hypoglycemic risk but you need to address the hyperglycemia. The first thing is older population who has a very high risk of getting induced hypoglycemia. And the second population is those who are fasting, like people with Ramadan, and then the patients with kidney impairment. So these are the three groups we discuss one by one because they need a special attention in terms of addressing the hyperglycemia. So first is addition study that compares glargine U 300 with 100 in GFR more than 65 and less than 65. So see, these are the 4 lines, 2 with more than 65, glargine 300 and 100, and 2 with glargine 300 less than 65. So if you see both the arms, all the 4 arms, they had a good HbA1c reduction at the end of the trial, and the nocturnal hypoglycemia were significantly less, about 30% less in glargine 300 arm. So if we see HbA1c reduction also in subpopulation of more than 70 years of age, there was a significant extra HbA1c reduction of 0.34% seen at the end of 24 weeks. So hypoglycemia comparison is, if you see again versus degludec, insulin degludec at population less than 65 years, about the insulin glargine 300 was doing better, and more than 65 years glargine insulin degludec was doing better. So, but there was no statistical difference between the hypoglycemia risk between the two. So fasting during Ramadan, again, there was a trial, Orion study, which was a global study, and that has shown the people with type 2 diabetes who had glargine 300 at 28 weeks and intended to fast for more than 15 days during Ramadan, and pre-Ramadan, 1 to 3 months, the insulin was given, and during the Ramadan, they continued the insulin, and post-Ramadan, for 1 month, they continued the insulin. And the trial endpoint was, primary endpoint, it was to determine the percentage of people with more than 1 episode of severe or symptomatic documented hypoglycemia with self-monitored plasma glucose of less than 70, pre-Ramadan, Ramadan, and post-Ramadan. So efficacy-wise, if you see the Orion Global and its South Asia fraction, the HbA1c reduction was similar, about 0.4%, and fasting glucose reduction was also comparable. And about South Asia fraction, if we see, 86 participants, that 82% fasted for entire Ramadan period with a mean of 29.8% fasting days. 29.8 fasting, out of 30, 29.8 fasting days. 19 participants who broke their fast during Ramadan, they were for different reasons. Among these 19, 13 fasted for more than 25 days. So only last 5 days they have not fasted. About the 94 participants reported full adherence to daily treatment, and glargine 300 was administered every day during Ramadan period. In a real-life clinical practice setting, glargine 300 was associated with positive outcome in adults with type 2 diabetes. There was low incidence of severe and symptomatic documented hypoglycemia, HbA1c fasting and SMPG reduction, pre and post Ramadan, corresponding to clinical improvement. So whatever clinical improvement you get is accordingly you get fasting reduction, HbA1c reduction, and home glucose reduction as well. So result supports use of glargine 300 during the fasting of Ramadan. So the last subgroup we want to discuss about kidney impairment population. To address their hyperglycemia, we have an addition program which has compared glargine 100 versus glargine 300, and with eGFR less than 60 and more than 60. If you see both the graphs, glargine U 300 was doing better. The reduction is more in glargine U 300 arm, and nocturnal hypoglycemia was much less in glargine 300 than glargine 100. In BRIGHT study, it was compared with insulin degludec, and if you see the subfraction of the population of less than 60 eGFR, the HbA1c reduction was much more with glargine U300 versus glargine 100. Or other two groups, more than 90 and 60 to 90, the reduction was similar. About nocturnal hypoglycemia, you see the number of dots favoring glargine 300 and number of dots favoring insulin degludec. If you see, at some point insulin degludec was better, but other frequently, if you see the dots falling in favor of glargine 300. So it is comparable. Mostly the result as well as the hypoglycemia were comparable to insulin degludec. This is a European pooled data analysis. This is really trial that has done a meta-analysis of 6 24-week prospective studies with 1,712 patients. After 24 weeks, glargine 300 therapy decreased the HbA1c from baseline, and the proportion of patients achieving HbA1c were comparable across the subgroups respectively. The incidence of hypoglycemia was overall low across the subgroups. So glargine 300 provided glycemic improvement with overall favorable safety profile regardless of the eGFR. So whatever the eGFR group, one can safely prescribe this glargine U300. This is X-star study. This is a Japanese trial, 12-month study. The participants were stratified by age, less than 65 and 65 to 75 and more than 75, and estimated GFR. There was no apparent increase in the proportion of people who experienced hypoglycemia were found in all subgroups. The result was similar for HbA1c level below and at or above 7 in all age group. Whatever the HbA1c they achieved, they had no extra hypos. So no apparent increase in hypoglycemia risk in people with older age and renal impairment who were administered glargine 300. The results would provide reassuring information on glargine 300 use. So the elderly population, we have an additions program, ATOS program, BRIGHT study, and DELIVER study, which proves its safety. And about renal parameters, we have addition program, DELIVER trial, BRIGHT study, and ATOS trial, which has shown the safety of glargine U300. Glargine U300 in pregnancy, the safety of glargine U300 during pregnancy was examined in post-marketing pharmacoevidence data. The cases from 49 countries were taken. There was 546 exposures to glargine 300 during pregnancy. The reporting rate for pregnancy and lactation-related cases was 30.95 per 1 million patient years. The rate of spontaneous abortion and congenital anomalies were low and consistent with general population. So use of glargine 300 during pregnancy was not associated with specific adverse event or congenital anomalies. The results suggest no safety issues with glargine 300 during pregnancy. So a large number of prospective pregnancy outcome with glargine of exposed pregnancy from post-marketing surveillance indicate no specific adverse event on pregnancy or health on the fetus and newborn child. About the device, we know about the device by now. It has a dedicated cartridge. It is clear dose display and the flexible dose selection. And it has a simple dose delivery, and it is simple to operate. Once you show the patient doesn't make mistake with the pen. So the patient with impaired renal function, glargine U300 provides improved glycemic control and reduced hypoglycemia risk with glargine 100 in type 2 diabetic patient, regardless of renal function. Use of glargine 300 versus insulin degludec resulted in greater HbA1c reduction without treatment differences in hypoglycemia. And in older subjects, glargine U300 resulted in comparable reduction of HbA1c with low or lower risk of documented symptomatic hypoglycemia versus glargine 100. And older patients with type 2, particularly those with more than 75 years, were doing much better with glargine 300 than 100. In pregnancy, use of glargine 100 or 300 during pregnancy was not associated with any adverse outcome. and use of Glargine 300 may be considered during pregnancy if clinically needed. During Ramadan, Glargine 300 use in people with type 2 diabetes who fast during Ramadan was associated with a low incidence of severe or symptomatic documented hypoglycemia, because in Southeast Asia, there was a zero event in severe adverse outcome, and improved glycemic control from pre to post Ramadan period. And that's all. Thank you.
Thank you, Dr. Bhumika, for your excellent presentation. I have a small question. Can Glargine 300 pre-mixed with any short-acting insulin?
No, not it cannot
Then
be
why?
pre-mixed. It cannot be mixed because till now all trials to mix the insulin have failed, and they recommend Basal Plus is only possible with aspart and insulin degludec. But Glargine is yet cannot be mixed with any short-acting insulin.
Thank you. Thank you. Now I request
Dr. Srikant Dar, please moderate this session, and I request Dr. Neeraj Misra and Dr. Goenka to take their chairs. It was an indeed great session because Soliqua and Tugio in their generic quality have changed the proportion of the quality that which clinicians were using, the confidence in which clinicians were using. So, one second. So these two molecules have given confidence to prescribers, comfort to the patients, and lot of flexibility to both. So I request Professor Dhar, a clinical expert, professor, and astute clinician, to moderate this session. Professor Dhar, please.
Thank you, sir, for the nice word, and thank you, Kanungo sir, again for this 12th annual meet for this academic extravaganza, showing the science and its role towards implementation to the clinicians. And rightly, this session has been taken by most promising clinicians, Neeraj sir, Alok sir, you yourself, Ramesh sir, and I'm going to deliberate, just compile all this scientific agenda to few questions and ask them what are the common clinical questions that come to a physician once we start this medicine. Sir has already been, Neeraj sir already been mentioned about the Iglar legacy, how does it work and how to initiate. My first questions to start from Dr. Neeraj, which patient profile benefit from the fixed ratio combination of Iglar legacy compared with separate basal insulin? Because it's a new molecule to start with, how the patient will initiate, the physician will initiate, and along with how does Iglar help address common barriers such as weight gain, hypoglycemia already mentioned. Just to summarize all this for clinicians when to start.
If somebody is insulin naive and you want to start maybe a GLP-1 basal insulin, but the GLP-1 alone probably having a very high HbA1c level where you probably need to add both the drugs to start with, then this will be a good option to start with because only one injections and very simple to titrate, and somehow it is better tolerated because you start with a very low dose and gradually go on increasing and the cost, and appears to be I'll say the cheapest in the market where you can start a GLP-1 and basal insulin combination, and hardly the insulin, the pain costs 1500 rupees, and when you compare with the GLP-1 is very expensive, or you compare with other basal insulin, very expensive. So somebody need a drug where the is a pocket friendly and need a combination of both. And again, compliance issue with one injection is very good. And I have tried with some of the patients, and really patient, they do take up when you take all these issues into consideration.
Thank you, sir. You have already mentioned about the hypoglycemia part, the weight gain. You have mentioned in your slides, and also your experience about using this. How much HbA1c reduction you expect from the onset if it's an insulin naive patient, or from the onset, or if you add on to a patient those who have already on OHA?
It depends on the baseline HbA1c. If the baseline HbA1c is very high, we expect anything around 2.5 to 3 at least, the reduction. If it is maybe around 10, you can very well bring it to around 7. But if you start maybe around 8.5, maybe it will reduce around 1.5. So it all depends on the baseline HbA1c. Start with a higher baseline HbA1c, the reduction will be much more pronounced. And if you start with a lower HbA1c, the HbA1c reduction will be much lesser. But again, depends. So probably what you need is that even with somebody, you start this in the naive patient, means somebody having HbA1c more than 10, 11, where probably you have to give this combination of both from the very beginning. And they'll definitely, if you take it, titrate it properly, it will bring down the HbA1c to target in most of the patients.
When you think clinicians should start, what is the indication, or when you start, so clinicians should think of this agent in fixed dose whenever patient is in OHA or fixed dose other combination?
First thing, when you think that patient is not going to accept multiple injections, they are definitely one shot, probably patient will agree. Second part is the cost, because you think about any GLP-1 is expensive still so far. So patient will not accept or not continue the drug for long time. Again, the compliance issue, adherence, persistence issue. So when you think about the patient, take the patient into account, he needs a combination of both, but he needs a drug which is cost effective and which is simple to administer and simple to titrate, which is definitely this drug is very simple to titrate and cost effective, and only one device. So patient, it is all depends on the patient, what the patient wants. If somebody is very obese, patient wants a better drug to blood glucose, means weight control, blood glucose control, if I'll go for other GLP-1, which has a better weight reduction effect, because this drug hardly causes a weight loss of maybe around 0.3 kg. It's basically weight neutral GLP-1.
Rightly, sir. So every patient is different. So it should be patient based. My next question to Dr. Ramesh Goenka: what are the most common error in basal insulin initiation? You have already mentioned about glargine 300, 100. To start with, what will be common error in initiation and titration? How do clinicians avoid them? This the side effects parts or the questions that arise mostly in initiating this patient, and barrier also. Most common, I think the hindrance will be the barrier in initiation.
Barrier, sir, already said that the same thing. When you insulin naive patient, you want to start insulin on secondary OHA failure, or a difficult patient, or a very high HbA1c with symptomatic case where you want to start insulin. I think the patient will not accept multiple injection. So adding a basal along with the OHA is a good choice. And the error in initiating is one should not jump into, like suppose we have a recommendation that 0.2 to 0.5 milligram per kg body weight you can start. But then if you see very high blood sugar in an insulin naive patient and you start with a higher dose, is a big mistake one is to make, because insulin naive patient you never know how sensitive he is, and he might be controlled on 6 units only. So one should not jump into starting with a very high dose. Go slow, target fasting first, fix the fasting first. That should be the formula. That if you see a blood sugar of 150 fasting and 250 prandial, and as per the prandial you increase the blood sugar, then again you are going to make a mistake, because one should think of a basal insulin with fasting blood sugar, not with prandial. Prandial, always you should think of a short-acting insulin or adding an OHA for that.
What would be your take on those patients, those are having repeated hypo or with renal impairment? And because these are concerns in most of the patients, starting an insulin, initiating and upgrading.
That's what. If there is a special situation we discussed right now, that second generation insulin scores over the first generation insulin, to start with, you should not think of glargine U100. There you can think of insulin degludec or a insulin glargine 300 in special population.
When you think basal insulin is insufficient in your patient, what next in your mind?
Short-acting, adding a short-acting insulin with the greatest meal first, and then up titrate. Number of pricks can be up titrated.
Thank you. My next question, Dr. Alok sir, what is the difference between second generation basal insulin from earlier analog in terms of pharmacologic and clinical outcome? Because these are the agents of choice nowadays. If you think of
insulin starting, intensification, or titration?
If the patient's blood sugar fasting is not more than 250 and you think of giving insulin, then basal insulin of any nature, first generation or second generation, is the choice. We have lot of experience in first generation. This 300 IU came when it was found that patients will be more comfortable with second generation basal insulin. It is long acting. Most important thing is flexibility of dosing. 1 or 2 hours after food or 1 or 2 hours before food can be given. So skipping the meals or skipping the dose is not a question. You give 2G or second generation and you feel comfortable. Patient will not go to a hypoglycemia, very little hypoglycemia, and flexibility is good, clinically stable, and as Dr. Goenka has told, if it is inadequate, you can add either any prandial, preprandial short acting or lixisenatide combination with basal insulin.
Now, which group in Indian patients you think are most consistent to start with second generation?
I find I am now using in many cases from villages to city dwellers, and all are comfortable. Single daily dose along with OHA, and they are comfortable, their sugar is controlled, and they are feeling better. And their complication, as my experience for last 3-4 years.
Alok bhai, if you don't disagree, I don't think there is a difference between population starting 100 or 300. You can start 100 and take both.
When
you have already shown in your slide that they are comparable. So patient to patient may differ.
It is all initial payment matters. How much money he has to buy Lantus or to buy 2GO. So that makes a lot of difference. But 2GO, if they accept, that is much better, safer from them.
If they can afford.
You rightly say, sir. Sahu sir, I will ask the same question. How do you see the cost, access, and patient education shape basal insulin use in India? Because this is the primary thing the patient will ask. What is the cost?
Oh, because it's mine. Because after the semaglutide came, price barrier is gone. No more. When oral Rebelsus came, we thought 300 rupees per tablet per day. That was a difficult thing to believe. So when those things are, that is कहते यदि शिला शिलुपुआ गगने उड़ंती, यदि सेमाने आकाश रे उड़ुचंती, ताले there is no problem in giving these 2GO or Lantus or any Degludec or anything now to our patients, and most are covered by insurance, even if not in Ayushman Yojana, but people are volunteering to take good treatment because parents are poor, but children have become richer.
Yes, sir. People has gone to the internet and they are coming and asking, sir, give us that you have seen your video, and that video, it is new thing. Can it be reversible? How much gain we can? They are coming self by their own and asking about prescribing all things. Dr. Sai, you are on part about what will be the cost factor in India about all these agents.
Cost factor in India actually is not so much, because nowadays, as Dr. Alokan has told, the government is giving full support. So our main work is to educate the patient. We should educate the patient, because when we use second generation insulin and when you use other drugs, there will be not so much cost difference, because second generation insulins are there longer acting. So when they work for 42 hours, insulin Degludec, if you compare with other drugs, then it will cost effective. It is not very cost effective, because it is 42 hours, one dose. So it is very effective. And second thing, if you educate patients, and these things are now available in government hospitals, it is available in Capital Hospital in Bhubaneswar. So we should educate our patients. If they cannot afford to take from private hospitals, they can take from government hospitals.
Sir, rightly said, but I think we can educate our doctors first, because first hindrance is in our pain.
We have to keep in our mind that we have to start this, we have to initiate it, and then we have got that much of confidence. What do you think in the coming decade? How do you see the basal insulin evolving alongside newer injectable and oral agents?
They are already evolved. So basal insulins have become a practice of the day. Nobody is giving anymore those combination drugs in the night. These two drugs, simple drugs, maybe the price. And now some companies have withdrawn their cartridges. So now the question, better basal insulin is the choice than the combination insulins that we are trying in the evening dose. Second thing, I would like you to ask Dr. Neeraj regarding the Eigler Lixi, a little more about that, and he has to explain.
Sir, your taken point on this, sir has already asked the question.
Actually, as I told, this is a drug which is very cost effective. That I like the most. One simple injection, very cost effective. I've given to some patients and prefer them to give it lunchtime. Some of them I've given those go to the office with a heavy breakfast. I tell them take it in the morning hours, and acceptance is very good. Somehow the side effects of GLP-1 virtually not there. It's very well tolerated. You just once a week just uptitrate. Maybe the glycemic control takes some time, but the withdrawal because of the side effects is much less when you compare with other GLP-1, because the patient, they have to convince a patient to continue GLP-1 is very difficult. They will just simply after sorry just discontinue this medicine. But that is not there with this drug, and somehow the hypoglycemia incidences are quite low. In fact, none of the patients have come with any severe hypoglycemia, at least some of the patients where I have given it. In that context, because this is a drug, you are using the glargine, is not the glargine, but and is the glargine 100 basically. So the cost is very less. And lexisenatide also cost appears to be very less. So 300 units glargine, 150 unit microgram of lexisenatide cost directly to the patient 1500. So like any other basal insulin, so at the same cost of the basal insulin, getting two drugs. So definitely glycemic control is better. But somebody, as I told, somebody is very obese, somebody having fatty liver disease, somebody having obstructive sleep apnea, somebody having atherosclerotic cardiovascular disease, where need some other GLP-1. But
Sir, you
other
have been
patients
a
like
brand ambassador for the GLP-1 since last years. What is your experience and what will be your take on the new SUMA taking over these agents and being a
as I
role
told,
model?
because fatty liver is the disease we should be worried about, and we should be and take my word, over the period of years, that is the disease, and Sir will agree, that is the disease we should be. Initially, we thought that it is a simple disease. No, that is a very complex disease, and that is probably the root of cause of everything. And because semaglutide acts on that part of it, and essence trial, once it is complete, the full part of it, I think that will have a huge impact. And you need somehow to prevent that, because once you have a fibrosis, F1 fibrosis, it takes 7 years for F2, 7 years F3, and once you enter F4, this is a chronically relentless, a progressive disease. So somehow you have to halt that progression at the stage of F2, F3. So again, semaglutide for the time being. And I think also you have the other GLP-1 having the same effect, because the phase 2 trial is very promising. So because of the fatty liver disease, for somebody who is overweight and obese, and because most of the diabetic are having fatty liver disease, it is semaglutide or
I think the Munjaro trials are on also on
that phase 3 trial is going. Phase 2 trial is very promising. So they are the future. But as I told somebody, once the cost comes down, and semaglutide cost is going to come down drastically in another 2.5 months
come
time.
down already. Already come down.
Another 2.5 months is going to come
Alok
down
sir, your
drastically.
take on this new SUMA coming over and taking over the older generations, either it may be basal or other agent, other GLP-1.
The originals will remain originals. First thing. Vastra bhave sutrang dehi. These new molecules are not very much tried also. We need more of Indian trial, international trial on that. They say
that this is international trial since
they say it is
17 they are
tried.
trying it.
They say it is tried and all that. Professor Das will highlight on this. But somebody can afford, then originals will remain originals. Both in glargine, youth 100, 300, semaglutide, and Monjaro. They will remain as they are. But there will be naturally penetration as DAPA took over everything. It was a storm because the price was reduced. So let us wait and watch. I'll request you to request Professor Das
Next question
to come over to the dais and
please come up to the dais.
Brief everything to us.
Sir, we have gone for a very lucid.
Extracted all the answers and nothing much to add. I just want to tell that, I think the discussions have been excellent. That's the beauty of this meeting. And, very painstakingly for every speaker, we have prepared about 5 questions. So that's why. Now, what I will possibly add by saying is what Alok said, Bastra Bhave Sutradhari. You cannot replace a beautiful Kanchipuram sari by giving a small thread of sari that makes out of which sari is made. So the original is the original and a copy molecule is a copy molecule. Now on this, there have been a lot of debates whether the original molecule and the copy molecule or the after patency over is same or not the same. If you ask me, we are conscious about the brand conscious, but many of us are also price conscious. So price is a very important issue which drives it. And many of the companies have reduced their original price to almost 1/3 after the copy molecules came. Now, there are some copy molecules, biosimilars, they say they are bioequals, and they also claim sometimes they're bio better. That is too much to swallow. But I must say, what Alok said, that the trials are done with the original. You see, Emparec trial is done with the original Empacliflunjadians. You cannot have Empasip, Empalip, Empalin, whatever, so many things are there. You cannot say they're 100% similar. The original remains one step ahead. And there are some people who prefer to take, by taking Jadians, it has come down to, with the concession shopkeepers give, about 31 to 21. Whereas the original Empalim or Empasip, Empalin, they all cost about 11. And you can buy 25 and make it half. Jadians 25, make it half. So the cost also is equal almost.
It's especially for peptides, it's not true.
That is true, because what he says is true. Can you make Rybelsus or any protein half? Because you may not have the equal components in both the halves. That said, but Jugaad is Jugaad, and we have Jugaad in India. The most important thing I like to highlight, which was clearly Sikant get a beautiful, the Eigler Lixi. I did the landmark trial. You might have known landmark trial for 6 years. So the Sana people are quite close to me. They first filed their application, Eigler Lixi, as a weight reducing dose. And it was in about 3 weeks back, they came to me and said they want to promote it as anti-diabetes drug. The reason is that the weight reduction is not marked compared to basal insulin, on which Eigler Lixi is a Lixi or Lantus has become Eigler Lixi. So the benefit of Eigler Lixi is not weight reduction, but avoiding weight gain in some cases. So basal insulins are known for weight gain. They do not give weight gain. Neeraj is beautiful. He said that beautifully. Number 2, he also said that the basal insulin can give you hypoglycemia. They don't give the Eigler Lixi does not give you hypoglycemia. The titration is as simple as Lantus, 2, 4, 6, variation. Same titration, but it is same. The other use of Eigler Lixi is that it has a GLP-1 molecule in it. Am I correct, sir? So they say it is the biology of basal insulin, but it's upgraded to a addition of GLP-1. Am I correct, Neeraj? So the beauty of Eigler Lixi, that with the price we give, we get a bit of eye glare, or we give a bit of GLP-1 array in a very small price added to that. And the final thing is that in the GLP-1 era, simple bezel will not be possible to drive. Therefore, adding GLP-1 makes it better. About the TUGO, beautiful discussion. I personally believe that 3 hours of flexibility totally becomes plus minus 3 is 6 hours. It's a great thing. You know, we have a term called insulin overwhelming us. We cannot take doctor's medicine at the same time in the morning. A patient taking injection every day, same time in India, somebody's mother-in-law, sorry, not mother-in-law, sister-in-law, daughter-in-law will come back, give the injections, he may not come back in time. So there is must some flexibility. And TGO give that flexibility. 6 hours. Number 2, we send patients morning for investigations. So morning dose is not given in time. That works out very well. And most importantly, that giving a flexibility to original glargine is possibly a great thing. You know, glargine today price is 631. 631, you can get for 615. And for a little price extra, you have this flexibility. And there is also the talk that you can give it for the most optimal control of blood glucose. There is not much of a weight gain. And compared to degludec, that is Tresiba, it has stood the test of time. And you showed the BRIGHT trial, you showed all the trials were test of the time. And the price, same, 1400. So it is, am I correct? Almost the same price. So I think from that point of view, you can have your take, whether you will take degludec, or you will take Tresiba, or you will take
U300 is cheaper than degludec.
Yeah, it's cheaper, little bit cheaper.
450 units.
450 units. That is 300. 300. It is cheaper than. So I think that's where TGO has come to stay. It is, you know, we are so much addicted to glargine. Am I correct? When we write glargine, patients will say, same dose, sir, to write TGO for a simple extra price. Thank you. Great discussion. Big round of applause for Sridhar and all.
We have another 5 minutes to go. Professor Srikant Dhar has a clinical case. He wants all your opinion on that, and he wants to present it for 5 minutes.
Please.
Thank you, sir. It's not a diabetic patient, just giving a live case. Admitted 2 days back to my unit, presented with features of heart failure, patient breathlessness, leg swelling, and on examination with no history of fever. What I could diagnose the patient clinically was diagnosed to be a case of heart failure because the BP was raised, pedal edema, obese, 130 kg, without any history of diabetes and hypertension. With the initial assessment of clinically it was jaundice. So it was clinically assessed, and it was a case of heart failure, most likely due to CLD, without any diabetes, without any prior history of dyslipidemia, CLD with heart failure, and with severe anemia. He presented with around 4.8 hemoglobin. Now we have already transfused 2 units of blood transfusion. Still today's hemoglobin is 5.6. There is bicytopenia in it, most probably due to CLD, because stool blood is negative, ultrasound showing most of the part clinically pH, and endoscopy you have not done because of the hemoglobin is low. So this is the clinical scenario in this patient. Because patient is obese, 130 kg, probably next day also we are going for an endoscopy in this patient. What next to this patient? I'm not asking about the CLD part. This obesity, 136 kg with a heart failure presenting initially without no history of hospitalization, no history of any sorts of problem since last 1 year. So he has not shown to any doctor. Come up with this type of presentation. He is Marwadi by profession. B12 is normal, sir. I'm saying. So this is the present scenario. Today's report is 5.6 kilometers. We are giving him another transfer. What next? I'm asking about the GLP-1 along this. Sir has already mentioned about the CLD part, liver being the primary cause. This is a bright example of that case, Sanjay. What next? Will be all experts here. What will be the next in obesity management? Will be SEMA will be great in this patient, or some other agent also?
Sir, fasting in this case, because this is he is having heart failure, first we have to control heart failure. And the cause of heart failure is anemia and hyperproteinemia. So we have to increase the protein as well as the
Patient has
hemoglobin.
already improved, sir. Heart failure component is gone, sir. Now NT-proBNP is around 1800 or 2000. He is now, after giving a one transfusion and last six infusion, patient is now okay. He is in ward. Heart failure is gone now. Anemia part is we can improve. CLD is persisting and obesity is persisting. What next? I am asking about this forum about obesity only, not about the CLD part, sir.
I asked we didn't do that, but if you come for obesity, the contraindications for giving anti-obesity drugs are three. Number one, below 18 years of age. That patient is, how old is the patient, sir?
Sir, 40 something.
40. So it can be given. Number two, pancreatitis and MCT. No question doesn't arise.
Normal.
Arise.
Ultrasound
So,
not
and 130 takes this patient to morbid obesity.
Yes.
Morbid obesity,
yes, sir.
which has to be addressed. Now, the maladies of morbid obesity are MMM, mechanical, metabolic, and also mental. And all these three can contribute to heart failure. So I will possibly treat obesity with the available drugs. For a morbid obesity, probably the drug, a combination of GIP and GLP may be ideal, but I'll go very slow. If I'm putting 0.25 to start with, I'll stay on 0.25 for a month. I have to go a little slow because the patient has multiple, severe anemia. Patient has things like he had hyperlipidemia, jaundice you said?
Yes, sir. 5.8 or something.
Jaundice, no.
Yes, 5.8 bilirubin.
Why jaundice?
CLD. Chronic liver
disease. So you have to be very careful in giving these drugs. You have to be very careful giving these drugs. And the other thing is that if you bring down even 5 kg weight loss over a month by giving very minimal dose of 0.25 as a acclimatizing dose, even acclimatizing dose can bring it down. We have seen 2.5 kg in about 6 weeks time. So I would go slow. I will go low. I will look whether this liver enzyme being high is a contraindication. There is no written contraindication.
No written contraindication.
So therefore we can give these drugs. But my basic principle will be, since morbid obesity, I have to give something to bring down the weight. I will go slow, go low, and stay on one particular dose instead of 1 week, 3 weeks, 2 to 3 weeks.
Sir, when to start, sir? Patient presently in hospital.
Now you have to see the acute part must be over. You must evaluate the CLD. What is the pro time and INR?
PT-INR is almost in upper end. I don't remember. It is 18 or something. PT INR is normal. Not high.
INR is normal. Then I can start even tomorrow. If it is there, we can start slowly. Because one of the drugs for the heart failure is also the
GLP-1.
And therefore,
do you prefer combination GLP-1 GIP in this patient?
Sir, if you give only one GLP-1, morbid obesity, it will take very long time to come down. And the one thing that Abhay said, that the Ozempic came to India recently is not true. The government
is a non-diabetic, sir.
We had
he is
given
a non-diabetic.
approval 1 year back.
Sir is asking for 12 to start with 12.
12?
Dual.
Yeah, I'm telling GIP and GLP combination will be better to start with. Because, we have to have at least within a month and 6 weeks, about 3 to 4 kg weight loss. Then there is a graded weight loss if you give this.
Neeraj, sir, your take on this patient.
I think also have to add it SGLT2 inhibitor. Definitely. What form of the heart failure is there? SGLT2 inhibitors is required. And here, if there is is a heart failure, I think it's a preserved ejection fraction. It's not a reduced ejection fraction. Then I'll straight go for Pinniran. So go for Pinniran and Pinniran, Kerendia. Because that is the drug has been found to be useful in heart failure preserved ejection fraction. Very good results. So these are the drugs for heart failure preserved ejection fraction because you are dealing with.
Sir, I'm asking for obesity, sir.
Yes. So means that when it say it has to be SGLT2 inhibitors and Pinniran added to already sir was a GIP GLP combination because definitely a weight reduction is much more pronounced and the trial with heart failure preserved is much more robust with tirzepatide.
Then that's the Summit 3 trial. Summit 3 trial showed it is robust, and I like For the heart failure, even a non-diabetic, GDMT is applied. What does GDMT say? GDMT say you have to give any diabetic, which is a MRA. So Neeraj prefers Pendrinol. That's good. And number two, it also says you have to give SGLT2. So both these drugs have to be on board. I agree with you.
What
Along
is,
with that,
what is his nutrition now? Is it TPN?
He is obese and checking adequately. I said him, you are having some heart failure. He's denying. "No, I don't have any heart failure."
No, if
Who
you
says
don't,
I'm having heart
if
failure?
you
Your
do
report
not,
says.
if you do not modify your diet pattern, then how do you expect obesity to come down? Because
That
all these drugs can only work if there is lifestyle and diet in addition to. Here, lifestyle cannot be done anything because he is bedridden.
No, he's working, sir. He's not.
So, still then not exercising all. Diet has to be modified.
Alok, once you give these drugs, the hedonic pleasure,
diet
this
will
Marwadi is a
automatically-
hedonic pleasure of
the diet
taking
will
dal and ghee
automatically
will
go
go away. It will work on the hypothalamus, these are the. So I think
The satiety will be there.
the
Satiety will be there.
it will be at this level of food it will go. But what Alok said is correct. It is the physical activity will give you cardiovascular fitness, but it is diet which will bring down the weight. And we are doing these drugs to act on the hypothalamus and the axis to produce suppression of appetite. Am I correct? So appetite suppress and they will take. And if he is eating for pleasure, hedonic pleasure, then that pleasure will go, he will not eat.
Thank you, sir. Thank
That you have to see.
Sir, the triple H mean hepatitis B, C, A, everything is negative, and we have sent us, not too high. I don't remember it is 200 to 300 only.
Srikant,
We
most
have
important thing he wants to know
the
what
cause.
is the liver ultrasound. What grade of fatty liver he has got, because he's
Sir,
so
it is
weak.
already CLD, sir.
No,
Chronic liver disease, portal hypertension. Tomorrow we are going for an endoscopy if hemoglobin is around 7.
Acha, I don't know, but I think even though CLD, one can see the degree of fat. Suppose it's a fatty. What will
So we have to
suspect
go
if
for
there
a
is
fibroscan.
1 minute? If there is no hepatitis, no alcohol,
No,
no
non-alcoholic.
such, then we will attribute. We have been taught to
Sir,
attribute
we have
everything
sent a
to.
serum serenoplasmic also to this patient because everything is normal in this patient.
No, I'm thinking, why don't you think of a fatty liver which has gone to chronicity?
That might be the cause. Once other things is, this is MASLD only, unless otherwise proved.
So for this drug, even GIP, GLP is the drug of choice.
Sir, really, I'm really worried. I've seen last 2 months 7 elderly ladies with CLD and all MASLD. They are not very.
Sir, this
fat.
is not the first case
They are
I'm
not very
having
fast.
in
That
several
I am
cases
telling
like
you.
this.
That
Same
is
thing,
what
sir.
I am worried, and what we should be worried that we should screen. They are not obese even. And elderly, after 50, it is the ladies who will be born the brunt of the disease, MASLD, liver fibrosis. After 50, before 50 probably is the men, but after 50, the elderly ladies, and no past history, and they're all cirrhosis already.
Already cirrhotic.
7
I
patients
think
in last 2
we are all
weeks, 2
saying the
months.
same thing.
So that is what we should be worried. We should do something so that we prevent. Otherwise, the estimate is that by 2030, incidence of CLD, incidence of liver transplant, incidence of liver cancer is going to triple. And by as early as 2030, and after that, forget.
I think
It
I
is
cannot
simply-
agree
it
more.
will be-
That's why we are popularizing not CKM alone. We are
Yes,
saying
yes, sir.
CKLM.
Yes, sir.
L is for liver, and we have brought out a small booklet where we have said what Ayushman Bharat is covering now. For a diabetic, fasting, postprandial, HbA1c, urea, creatinine. It will cover the liver ultrasound. It will also cover the part if you're going to do any advanced ultrasound like VTE or fibroscan. Will justify there is beyond stage 2 fibroscan or VTE. It will also cover, and it will cover because we are now going to say that diabetes is not in silo. Diabetes is a part of the metabolic medicine. So if you find it out early, especially MSLD, find it early, you can give reversal. If you find it late, point of return, point of no return.
Thank you, sir. Thank you for concluding. Already yesterday.
I think simple test, sir, FIV4 score.
FIV
Very
score has
simple.
to be done.
I met
yes,
that
sir.
gentleman. I met that gentleman
This is already
last year.
done.
Fifth four score is
Yes.
the most ideal.
Most
If it is
ideal.
1.3, 1.34, okay. If it is going to 2, 2.6, 2.7, you can grade the muscle and give the appropriate treatment. Fantastic. Neeraj is great.
Yes, sir. He is always good. Thank you, sir. Thank you for the nice interaction. Thank all the chairpersons for this nice interaction. And just concluding the take-home message in my case, that lifestyle modification is priority. Heart failure has already been controlled. Patient is non-diabetic. Weight reduction, most likely dual agent will be best in this patient. When to ask, we'll see. We'll follow up the patient in. Huh?
We are all belong to that category. We are living to eat. You are all eating to eat. We are living to eat. We cannot control. We have to give drugs to control the appetite, and that is the aim. Am I correct?
Yes.
So 130 is imagine.
Thank you.
So thank you, Srikant, for a wonderful lesson on this basal insulin along with Eigler Lixi, and all aspects have been discussed by our esteemed speakers, the Professor Goenka, Professor Neeraj Mishra, Professor B.D. Sahu, and above all, concluded by Professor Ashok Das, the teacher of teachers of India. And Srikant Dhar
Thank
is
you.
I'm
I'm feeling so humbled. I must tell you one more benefit of Eigler Lixi, which Neeraj said very silently, was that it controls postprandial, which Bajaj will never ever control. So it is the, am I correct? Yes. So postprandial control, which is very difficult in India, this drug addresses. So that is the beauty of this Eigler Lixi. Thank you.
Thank you.
Thank you all the speakers and panelists for simplifying the complexities of basal insulin therapy and real-world decision making. We'll now take a short lunch break. Lunch is arranged in the front building on the ground floor. Please proceed at your convenience. During the break, we invite all to explore the industry exhibition stalls in the lobby area and engage with our industry partners. Kindly be back on time as we resume with further scientific sessions.
Thank you, sir.
तो अशोक सर ଏବେ ପହଞ୍ଚି ପାରିବେ ଏଠି ଅଛି ସିବି ଅଛି ସାର୍
Welcome back, everyone. I hope you had a pleasant lunch and networking session. We now move into the post-lunch scientific segment, focusing on one of the most crucial aspects of diabetes care, the prevention and management of complications. With this, we begin season 9, Complications in Diabetes, Part 2. I request Dr. Alok Kanungo to please set the context. Thank you.
Thank you. Now our topic is modern approaches in diabetic retinopathy, and it will be discussed by none other than senior consultant ophthalmologist Core Vision Eye Hospital, Dr. Sanghamitra Kanungo. She has contributed about 40 free papers and posters in various national and international conferences, 12 publications in index peer-reviewed journals, including Indian Journal of Ophthalmology, Eye, Retina, Retinal Cases and Brief Reports, Ophthalmic Surgery, Lasers and Imaging, etc. She is co-guide in 2 DNB theses. Dr. Sanghamitra Kanungo, please. Please play the recorded talk.
Of the eye in the retina, it is termed as diabetic retinopathy. Diabetic retinopathy affects almost 1/3 of the population of diabetes, and vision-threatening diabetic retinopathy is seen. So, early screening on the onset will be the use of for giving me this opportunity to be over here to speak on modern approaches in diabetic retinopathy. As we all know, diabetes affects one. When it affects the microvasculature of the eye in the retina, it is termed as to speak on modern approaches in diabetic retinopathy. As we all know, diabetes affects almost all the organs of the body. When it affects the microvasculature of the eye in the retina, it is termed as diabetic retinopathy. Diabetic retinopathy affects almost 1/3 of the population of diabetes, and vision threatening diabetic retinopathy is seen in 5% of the diabetic population. Such is the enormous number of patients that are affected with diabetic retinopathy. So early screening and early detection of diabetic retinopathy and early treatment leads to preservation of the vision. Therefore, my presentation outline today would be advances in screening, advances in diabetic diagnostic procedures, advances in treatment, and futuristic perspectives. There are many areas in our country where, in the remote areas where screening of diabetic retinopathy becomes it becomes very difficult, and healthcare facilities are also not available in the remote periphery. In these places, teleophthalmology and handheld cameras play a very, very important role. It is a cost-effective method, and it's highly sensitive and specific, wherein you can, as you see, this is a handheld camera. It comes in a very low cost from Remedio, and you can also make your own fundus cameras, like using your own mobile phones with the adapter and a condensing lens. In this, non-ophthalmic personals also can be utilized. They can take the photographs, send it to a base center where it can be graded, and those people who require treatment can be called on to the base center. Therefore, it actually helps these patients in not coming and getting, all of these patients may not come and come to the base hospital. Only a handful of people who require it would be required to come. Then we have advances in the diagnostic procedure, OCT and OCT angiography. OCT is optical coherence tomography, which gives us the complete, almost the biopsy of the 10 layers of the retina. And it can detect subclinical macular edema, which cannot be seen with our eyes also. And this is a very, very important tool, almost available with all ophthalmologists in all clinics right now. It helps us in detecting the macular area, as well as there are certain biomarkers which tells us that how the patient would improve post-injection or post-treatment. OCT angiography is another modality wherein in an angiography, when you do angiography, probably you have to give a dye. You have to give a dye and then see the vasculature of the retina. But in OCT angiography, no dye has to be injected. It's a non-invasive procedure, and it can show you the macular area as well as the peripheral areas. OCT angiography is 95% sensitive. As you can see in this picture, the macular area, there is widening of the macular area suggesting macular ischemia. And these are the new vessels that are seen, and adjoining capillary non-perfusion areas are seen, which helps us in detecting the new vessels to treat, whether with anti-VEGF treatment or do a laser. These CNP areas are the areas to be treated. Then we have wide field imaging system, also both fundus photography as well as angiography. The previous, all the studies of diabetic retinopathy were done with Earlyhouse classification, where 7 standard photographs in the central posterior pole was taken, which shows about the central field about 55 degree. Whereas in a wide field photography, you can go up to 200 degree. That is almost 80% of the retina can be visualized. It has, many studies have shown that almost 14% of neovascularization or CNP areas exist in the far periphery, which were actually, we were not able to see with the standard photographs. So this can well be seen in wide field photography and angiography, and treatment based on that would be much better.
So this is a wide field angiography which shows us that the peripheral areas, as you can see in this area, which were not possible previously, we can see these areas, and these are the capillary non-perfusion area which can be targeted in our treatment. There have been a lot of advances in the treatment of diabetic retinopathy, especially the anti-VEGFs that have come to the market, the newer anti-VEGFs, the brolucizumab, faricimab, combacept, and axitinib. Now, how these works, the brolucizumab or the Peginex, that is the trade name, it is a very small molecule, only a fragment of the antibody. Therefore, more amount of drug is available in the required dosage. As it is a smaller molecule, its penetration is much better, and it stays, it works much faster and stays in the eye much for a longer period of time. Faricimab, again, is a bispecific antibody molecule which acts both on anti-VEGFs, so vascular endothelial growth factor inhibitor receptors, as well as angiopoietin 2 receptors. So this also has got a dual mode of action, and therefore it stays for a longer period in the eye, because our aim is how it would work much better and how it should work for a longer period of time, such that the patient don't have to come to us for review again and again, and don't have to take the injection again and again. The combacept is another drug which is not available in India. Aflibercept 8 milligram is now available. Aflibercept is, again, it works on VEGF receptors as well as placental growth factor inhibitor receptors also. And 8 milligram is a larger dose which stays in the eye for a longer period of time. Axitinib or TKI inhibitors, they are in the pipeline. Phase 3 studies are going on, and they have shown promising results. Now they have the port delivery system also, wherein a small surgery is required where the port is inserted into the eye and the drugs are filled such that it disperses the drugs in a dose-dependent method, and it stays in the eye for a longer period of time. Its benefit is it reduces the clinical burden, and it has a stable control over the disease. They have improved outcome, fewer complications. So once these drugs gets resolved completely, you can refill it. Surgery in diabetic retinopathy has undergone a wide range of development. We started with 20 gauge vitrectomy, where the needles, the port were much bigger, larger. We used to suture the wounds, and the prognosis was not also that great. There used to be a lot of bleeding. Now it has undergone changes from 23 to 25. Now the 27 gauge vitrectomy probes are available, which is a micro-incision vitrectomy surgery, wherein just a 0.4 millimeter incision is made, and the advantages are it causes less trauma, it has faster healing, reduces bleeding, and improving maneuver. So almost the patient goes away like a normal eye because no sutures are put. Gene therapy is also under consideration. It's still in the nation stage. Phase 2 and 3 studies are going on. Hope they will give us a very promising results. Lasers have undergone a wide range of modifications also. The micropulse laser is a low energy pulse laser, which can be used in the macular area very nicely, and it stimulates retinal pigment epithelial cells without causing any scarring. Then we have the pattern laser or the Pascal's laser, wherein a large area of the retina can be done with a lesser amount of time, and it gives us a very even amount of spots. Then we have the navigated laser system, wherein the laser can be superimposed on the OCT or the FFA, so targeted lasers can be done. Then we have the robotic surgery and the neuroprotective agents. Again, these are for the future. They are still undergoing in the phase 3 trial. Robotic surgery have come up in some of the countries, showing some good results, but we are still to experience that. Nanotechnology is applied in fundus examination of fluorescent angiography, wherein these nanoparticles can go, it reduces the cellular uptake of the dye, reduces retention in the body, its comparable optical performance with good bioavailability and a high metabolic rate. The future is, of course, artificial intelligence. As in all fields, artificial intelligence is of great importance. We have certain fundus cameras right now where artificial intelligence has been incorporated, which helps us in detecting the diabetic stages of diabetic retinopathy. But we have still a long way to go with artificial intelligence percolating to other modalities of treatment in ophthalmology. So to conclude, modern approaches to diagnosis diabetic retinopathy promise early detection and effective management of diabetic retinopathy, potentially mitigating avoidable vision loss. Thank you. Good afternoon, everybody.
Thank you, Dr. Sangamitra, for your nice presentation. Now, since Dr. Das is not here, will be reaching any time, I will start interviewing Dr. Sen, and I request Dr. Sen to come to the dais. Sir, do you have slides? No. Please come. Ete duro kahingi moto? Mo pakapaki rondu. विभू ठीक है बेटा ना आउट के आड़ू ठीक है कैमरा साथ को दिए Dr. Sen joined Kids Hospital in 2009. He was a general surgeon. I requested him to become a diabetic foot specialist. Believe it or not, in years after years, Dr. Sen has started becoming the number one in the country. In all of India, if you consider 4, 5, 6 best quality diabetic foot surgeons, Dr. Sen is one of them. Welcome to this NUCD session, sir. You have lifetime achievement in this, and being a diabetes institute, you have an ample opportunity to see patients with diabetes facing foot problems. What is your takeaway from that? So now Professor Das has come, he will take over. Please come.
Thank you. I think we designed this introduction because diabetic foot is a very big problem. So I'll start by asking Dr. Sen, what is the burden of diabetic foot as you perceive it?
Sir, there are a lot of burden in this society because first is people do not know that they are suffering from diabetes as well as there is diabetic foot problem. So in diabetic foot problem, not only patient suffers, the family suffer, the society suffer, the government suffers, the insurance company suffers.
Yeah, I think he's very correct. We're going to make it short. So what was in my mind to say that if you take all diabetic complications together, you will find the maximum stay in the hospital. One of the causes of maximum stay because of diabetes is diabetic food. You agree with that?
Yes, sir.
And that adds to the cost. Number two, diabetic food doesn't occur alone. It has got three components like diabetic neuropathy, diabetic vasculopathy, and infection. And all the three management costs money. The second question to you, sir, Dr. Sen, in a week or in a month, roughly how many cases you encounter?
Sir, probably this is in the state or in this district or in this area. This is the only dedicated diabetic food care institution. So people are referred from different institutions. And as new and old case, every day except Sunday, I see around 15-16%.
Very good. I think that the key number is 15. Why it is key? Because it is said that if you take 100 diabetics, 15% at least will develop diabetic foot problem. Number two, out of this, again 50% will develop in the other leg. 9%, 9 to 15% will undergo amputation, and out of them, again 50% will undergo amputation in the other foot. Just see the huge burden we have. Number two is the fact that if you take diabetics as a whole, as Professor Sen said, you do not have, because of the patient, the disease burden alone. It affects the family, it affects the society. He become not contributing society because of amputee is very difficult for him to contribute. And it was been rightly said by Bernard Shaw that people will give 10,000, that time he said dollars, let us say rupees, is not enough here, $10,000 to amputate a foot, but they don't pay any money to prevent the foot. So what is your approach, Dr. Sen, to preventing diabetic foot? What do you do?
Sir, there is a saying, ounce of care is better than pounds of cure. So here, patients who attend the diabetic clinic, they also attend the diabetic food clinic. So we basing on few things like awareness.
Very good.
So about awareness, we involve patient, relative, and their associates. How to examine the feet, when to come, what is the right time. And moreover, here I always, those patients who come to me, I always tell them, any problem, you give the photograph of your feet and the complaint to our nurses. They will communicate. So they send with this WhatsApp. So condition of the foot, what is their
Very
problem?
good, very good. I think today's digital diabetic foot care has come to stay because you can transmit your foot ulcer photograph, and from there, doctor we'll discuss that in a minute, will be finding out whether it is neuropathic foot, or it is a ischemic foot, or it is a combined both, plus there is infection leading towards gangrene or not. What is the extent of involvement of the lower limb beyond the foot, and etc. etc. Now, one important thing I want to ask you is that at the time of the session, appropriate technology that we must use, affordable, common technology that we must use in our diabetic foot clinic. What is to your mind the most appropriate technology? Just I want single sentence answer, sir.
Sir, definitely this media communication gives me, that is the affordable. So there are few things like
there is no single answer to this.
There is no single answer.
What I was trying to drive home to my esteemed colleague over here.
I can give you in 3-4 points if you like. Sir, suppose affordable means, first thing, we have to train the basic doctors or the peripheral doctors when to send out is the right time. Second thing, awareness. Third thing, communication. Fourth thing, once the patient is hospitalized, so we have to see which are the proper medicine to be given. How we have, the main aim should be to cut short the hospital stay. We
I
teach
think-
the people how to dress the wound.
Yeah, I'll come to that.
Okay.
What was in my mind, which is a little, you may not like it. You know, there was a gentleman called Paul Brand. How many of you have heard his name? He stays in a place called Karigiri, which is very close to my place and very close to Shamsi Vellore. He is called father of leprosy care because he adopted the leprosy, persons with leprosy in our country, and did a women's service. He used to take their feet in the hand. He used to give them drugs. He used to examine them. He was a surgeon. And he developed for this leprotic food. Leprosy and diabetic food are very similar. They are both anesthetic food. Am I correct? The sense is not there. Am I correct, sir? Both of them, they take away even you take away the limbs drop off. They don't know, auto amputation. So very similar. So this question was asked to him in 2022 in the international meeting. I was present there. He was giving the lecture. At the end of the lecture, he said, most important technology is to call the patient to a higher pedestal, little higher than you. You take out the shoes, the socks, and take out the dressing and inspect the foot for about 10 minutes. And he was very true. What does it mean? What Sir said is correct. All the 4 points are correct. What does it mean is the fact that many of us, myself, we do not examine the food in a diabetic, which is not acceptable in our society today. Why? Because diabetic foot problem is at least 15%, at least. If you do not look at the foot, you just say, my foot, then patient will never survive, will never come back to you. So the most important thing he said, take out the shoes, take out the socks, and start looking at the feet. This has been also illustrated in the Indian literature. You know, we give 2 photographs. When Rama was going for the 12 years Vanavas, my friend is here who is an authority on the, like his father, authority on the, he gave to Bharat his shoes, his footwear. Am I correct? Kathau. The footwear in a diabetes is very important. Diabetic foot is anesthetic foot. It's called insensate foot. So there can be needles, there can be small pins, shoe pins, there can be even small children's toy, which the patient do not feel. And they're the beginning of the ulcer. So if you take out the leg and look at the footwear, number 1, you see that. Number 2, looking at the foot, you can decide whether it's a neuropathic foot, which needs rest and offloading. I'll ask her in a minute. Or a ischemic foot. Ischemic foot leaves drugs like GLA we discussed today, like celostazol, needs angiography, needs intervention to take away the obstruction, to make the flow available. But neuropathic ulcer will heal with rest and antibiotics. So that's the first thing he said. He is quite true that
pain is a blessing. Pain is a blessing, he told.
Yeah. He said, very important, he said that the blessings to mankind of the divine is the pain. No pain, no examination. No pain, no complaints. No pain, no looking at the particular person's organ. If there would have been pain in the foot, he will come to you immediately. But since it's insensate foot, the foot, we have seen people with big ulcers. They don't know they have ulcers. We have seen people sitting behind a motorcycle. Silencer is too hot. The silencer has burned their feet. They are not aware. When they reach, they find that the foot is gone. They go to the temple barefoot, walking in the hot sun. They come back and they found blisters because the diabetic foot. I think Dr. Sen is absolutely correct that pain is the gift of the God to mankind. And there's some people, some doctors like me, not you are all good doctors, they say no pain, no complaint. No complaint, no examination. This myth, I would like to say, is most important technology that we must say diabetic foot has to be inspected. Dr. Sen, what simple things to include in the instrumentation in your practice? Just name 1, 2, 3, 4. What do you use?
So let me concentrate on cost-effective methods.
Exactly. That is the
Okay.
title of the meeting.
Okay. So first is monofilament.
Use a mono. So what sir is
Monofilament.
telling, very correct. A 10 gram monofilament is very
Monofilament.
important. We'll come to it.
Ah.
Number 2.
Number 2 is first the doctor should palpate the pedal
No,
pulse.
instrument, sir.
Instrument. So you can use one Doppler, which is also very
He's
not
talking
very
about an
costly.
handheld Doppler.
Ah.
I wish I would have brought it. It
Ah.
costs about, it used to cost 6,000 to 7,000. Now he has increased to 20,000. He has given some extra.
18,000 with graph.
80.
18, 1
Something
8.
affordable, no graph. Only see the what is the we derive a ratio. We find the brachial blood pressure and find the ankle blood pressure.
ABI.
We find ankle brachial index. If the ankle brachial index is about 80, 90, it is acceptable. Because in neuropathy, the foot circulation is better. So it is more than 1. More than hand, the foot circulation will be better. But in ischemic foot, it will be less than 6, less than 5, critical ischemia less than 4. So ABI is a good instrument to have. You must have, beg, borrow, steal. You must have an ankle brachial index if you're looking at the diabetic foot. And you can bill it to the patient. Next.
Another is Harris mat. Harris mat.
He has Harris mat.
Pressure.
Yes, correct. Harris mat is nothing but a mat which has light color. You ask the patient to walk on it, and there is a ink in the pad. So ink takes your footprint, and with that ink, when you walk on the mat, the foot picture as a print of the ink comes in the pad. That is called, big name for it, called pedobiography. You take the biography of the foot pedo on that, and from there you can find out what are the pressure points. There are some points in the feet which are pressure, like you have the tip of the big toe, you have the heel, you have the metacarpophalangeal joints, all the 4 legs. So there are pressure points, and in those pressure points, you can find if the pressure is high, it will be very darkly ink. If the pressure is low, it will be less. If it is moderate, normal, it will be less different color. You can find out the pressure points, and that is taken as a technique for diagnosing foot at risk, quote unquote, foot at risk. 4th instrument. He has said you buy monofilament, 10 milligram monofilament. Then he has told you about the ABI. He has told you about the Harris mat. What else?
And plain X-ray radiograph of the foot.
Which one, sir?
Plain X-ray radiograph of the foot.
Do you use a biostatiometer for the
Yeah, vibration we can do it with tuning fork also.
Yeah. So there are ways we look for the tuning fork, because diabetic foot has, neuropathy has 2 things, either a small fiber or a large fiber. Small fiber will affect pain, temperature, and touch. Large fiber will affect the vibration, perception, etc., etc. So we have a machine called biostatiometer, which costs about 27,000. Where what happens, you can have a robot tractor which vibrates, and you can increase the rate of vibration,
voltage.
The patient feels the vibration, and if it is more than 50, the vibration perception threshold, we call it, nickname is BPT. BPT is more than 50 is a diabetic. The posterior column is gone. If it is 15 to 25, above 25 is over. That means the large fibers are dead. If it is 15 to 25, they still can be managed. 0 to 15 is good. So BPT we use in our practice. There is no recurring expense. No recurring expense. No recurring expense. Totally. Number 2, what Sat said is correct. You can also do that with the tuning fork. But tuning cannot quantify it. Cannot quantify. Here you can quantify what is the vibration loss.
There is a qualitative test.
That is only qualitative, yes or no. If since you are quantifying, you'll know your treatment is improving or not improving. That's one important. So BPT, or there is also tuning fork, which has a graded measurement. That is also available for 15,000, and small biostatiometer available for 11,000. Just go to net, and I would say buy one. Next, any other instrument.
Sir, I have told you, instrument
We're discussing technology. Then instrument,
okay.
then technology.
That's all.
That's all. I think it's correct. He's absolutely.
No, no,
And
no.
maybe he doesn't want to mention about a cotton wool. You need a cotton wool. You need hot water and cold water. Am I clear? So pain, needle, touch with your hand and cotton wool, temperature, vibration perception threshold from the biostatisometer, and the vascular tree from the ankle fractal ratio, and monofilament for the touch sensation. Touch, pressure, pain, all combined together. So if it is buckles and patient does not feel, he has very tight foot attacks. So very good. So I'll repeat again. All of you try to get it inexpensive. One is BPT machine or one graded hammer or small one, which is 9 to 11,000. One of the Doppler, which is between 8,000 to 14,000. Bias decimeter, you can get, if possible, Harrismat, and you can get this. These doesn't cost more than 20,000 rupees for the instrumentation. What are the technologies you use in the clinical practice? One is a media link. What else?
So mainly, how I do actually in every case by showing the patients about the condition of the food. So make them aware from here to here, because patient relative must know whether the patient is improving. But sometimes what happens, it helps. How I will just tell you. Then media we use, we to every patient we distribute one handout. So in my clinics, so there are so many photographs of patients to come like this, and then how they are healed. And from the very outset, I always tell this ulcer will take minimum 12 to 16 weeks, because people have the expectation within 7 days it will be, so nothing doing. So to start with, a lot of constraint regarding the total contact cost. So gradually, whenever I tell people this is required, okay, sir. So the whole idea is we want to give the patient a walking foot, whether it is half, it is 1/4, but I always try to preserve the heel part. If 4 toes are also 5 toes to be amputated, patient do I know I have so far in my 16 years experience I have never faced any problem. And suppose just I will give you one. Here in one director of health, now he is at Bombay with a small ulcer. He came, and some doctors also operated that. When he came to me, first lesson is never allow anybody to operate on this, because he told me two things which, sir, I am having claudication and this is a painful ulcer. So before going for this angio or simple Doppler study, you should not do anything. Even if when he went for the Doppler study of arterial system, the radiologist told, sir, I don't think I don't find anything, but all the vessels are calcified. So still he is at Bombay. Dr. Badya is under treating him. Already he has spent for that small ulcer 10 lakhs plus. But with that celestazole and other things.
I think it's very important to know whether it is the neuropathic food
or
ischemic
or neuroischemic food.
Or neuroischemic. So neuropathic, insensate, no pain sensation. Vascular ulcer, very painful. Neuropathic ulcer on the pressure points. Vascular ulcer will not be on the pressure, the sides of the fingers. Third, BPT or the monofilament positive in neuropathic ulcer, negative in the ischemic ulcer. Ankle fractal ratio, I told you 8, 9, 10. So that is the main technology we use. What are the dressings we use? What are the ointments we use? And what are the other things that we give? I mean, for the offloading means the diabetic foot pressure area, the ulcer occurs. So you offload the pressure. That means the ulcer is not under any weight. So it starts healing. Am I correct? That is offloading. So what is the offloading material? 3 questions in one set. What is the offloading material you use for the TCC? Number 2, sir, is what are the dressings and what are the things you use for this?
Okay. Sir, about total contrast scratch, especially myself, I do not like that glass wool plaster because it is difficult for me to mold it. So I always the regular plaster of Paris I use. So I give one insole also with rubber insole for padding. And suppose there is anterior foot ulcer, I use Samadhan also I use. That is the cheapest one.
One of the offloading developed by one of my friends, Sam in Lucknow. Yes, called Samadhan. He has put this shoal foam material like this, and he has put two straps so that if your foot ulcer is here, he will put it here and put a strap. So foot ulcer will not touch the shoes or the ground. Clear? It's called Samadhan. Yes, he has patented it.
Ah, yes.
Like it in the book. Correct.
So I use metatarsal support to support also I use. But if there is recurrence of callus or infection, I go for T lengthening, percutaneous T lengthening.
Callus is a type of neuropathic ulcer because of recurrence friction, it occurs on the skin. But below the callus, there is infection. Am I correct, sir? The callus will be here, very thick skin. I'm going to go bindi.
Bindi.
Bindi. Today bindi hai. My soul becomes very, very thick. I get my point, sir. But you see, below this thick callus, there is ulcer. So we call it. There will be callus about a callus.
Callus.
There will be callous callus about it, callus. Because that is the way you can, if you take out the callus, you will find there is a muscular bed, there is an ulcer bed, and that's the only way to heal the ulcer. So you have to be very careful to take out the callus.
So after that, when the wound is healed, I suggest them for one temple socks to be used in the house or any diabetic footwear. And this should be continuous. See, people always insist, I'm not going outside. So temple socks is a foam socks. The upper person is just like a regular socks. Lower person, there is a heel with soft material so that the pressure will be reduced. About your second question, dressing. So if the ulcer is quite extensive, before dressing, I always give negative pressure wound therapy. Because
negative pressure wound therapy is absolutely important to give the ulcer. You can give it the KCI machine. KCI is very costly because we have got 500 crores.
Sir, I have in 16 years of my practice, I have never used KCI machine.
So what you must use is you have got negative pressure from the suction.
Bellow eyes.
That suction, or even small pressure machines that you use for sucking it out, that can be also used for negative pressure.
Sir, but this is most cheaper. The abdominal suction just bellow. So I use that. It gives minus 80 to 70 to 80 negative pressure. So my results are very good and it is most affordable.
It's commercially available.
I use homemade.
Then what other dressing materials?
Dressing materials are the best is I always educate people not to use betadine, Dettol, hydrogen peroxide.
Absolutely.
Nothing.
You should not put anything
Other than normal side.
On the food also. Therefore, they say the whole idea is to offload this area also is not touch the ground. If you put this ointment, this betadine, it still corrodes it. Am I correct, sir?
Yes, sir.
Corrodes it. So you cannot. You can only clean the sides.
So ischemia will be there also.
And number two, just do saline dressing. And once it is dried, then you can apply whatever you want to tea bag, curachet. I don't know how much it helps, but we all do that. We give glitter, growth factor. We put all these things to see whether it's healing or not. Yesterday we had a beautiful talk by Dr. Kalyan Ganguly at the end of the day. He said, anytime in this infection, fungus grows. So he said, and we know it from our experience, diabetic food should always be washed. Tell the patient to take up the food like his own face. To look at the feet, you cannot look like this. You have a mirror in which you can look at the feet, wash it and dry it. So we always, when you saline wash, we dry.
Dry.
Yesterday, he said, it dries the area so that no infection persists. Very good. Normally, do you use any of these commercial things?
Sir, usually because most of my patients are rural background, they can't afford. So that colloidal silver or nanocrystalline silver I use. But at the same time, in some cases, I use collagen particles.
Collagen particles, silver nitrate is the best dressing material. Silver nitrate is
Yeah.
best dressing material, and we use that. I'll tell you one secret, sir. The neuropathic food, which in India is 85%, will heal if you give him rest. But very strict. No, I'm working in the house. Your wife will be asking to go, you will be working in the house for all the day. No working, except the toilet and all that. The TCC, total contact testing, must be on. You can make a small hole to see that there is no discharge, nothing like that. And it can be changed after a month, 3 weeks to a month, and it is inexpensive. And number two, the patient must take absolute rest. Now we'll come to the last part. What antibiotics to give for diabetic foot ulcer?
Okay, sir, when the patient is hospitalized, so at that time I do always gram stain. So whether it is negative or positive, because first 3-4 days we give empirical treatment, because to get the culture sensitivity will take minimum 4-5 days. So to start with, after let us say 24 hours, I know whether the organism is gram positive or gram negative. So definitely I prefer injectable antibiotic. I prefer if the wound is severe, grade 3 like that, piperacillin tazobactam I give. And after at least 2 to 3 days, I give clindamycin.
Clindamycin. That is guideline best therapy. PIFTAS or very severe ulcer, meropenem or psilocybin tazobactam, whatever you want to give. And then you add something for the other organisms. And sir adds clindamycin. I also add clindamycin. I sometimes take on board something to take care of the staff also.
Yes.
So I take whatever you want to give, amoxicillin, whatever.
Sir, of late, I am probably for last 2 years or 1.5 years, I have been using, because we give multiple antibiotic therapy. I use rifampicin. So rifampicin, it gives really good result. So if there is kidney problem, I cannot go for that your quinolone derivatives. PIFTAS, I lower the dose. Instead of 4 point, I give 2 point. But quinolones we cannot give. So or any gentamicin we cannot give. So our hands are tight, because most of the patients come with nephropathy also. So before starting the antibiotic, to start with kidney friendly antibiotic, after that we think of whether we can go for quinolones or not.
There is a term called renal diabetic foot, because kidney people in diabetes, kidney failure patients who have developed foot ulcer. Tell me why? Because dialysis, they go every day, alternate day or twice a week, the leg stays like this. So develop ulcer on the most dependent part. So we always give them which are safe for the kidney. Kidney safe antibiotic objective. We sometimes give augmentin, we sometimes give the name you took now, we give little bit of metronidazole, thinking there can be always anaerobic and the saprophyte organisms, and we give them linezolid is quite a bit used in my practice because it can provide oral good. And the last option.
One little addition. We have a retinorenal syndrome, very common. If you find something in the eye, you find something in the feet. Now to that, in the kidney. Now it is retinorenal foot syndrome. Definitely all the 3 organs are affected, vasculopathy and thereby complications. So diabetic treatment, whatever is those who are not examining feet, they are not doing complete checkup of diabetes. That is a must, and every diabetes clinic must have a foot laboratory.
I think very correct. It has been said that retinal association is very common. If you have retinal disease, if you have a renal diabetic foot, you must be having kidney microbiome. That is very important. Other thing, we must also remember that if you have a musculopathy, then your ankle pressure is normal, 120 by 80, 140 by 85, 140 by 85. Lower limb pressure is 90. That means there is some blockage, some atherosclerosis, some flakes. So the leg is becoming relatively ischemic. If that is there, there's an indicator of generalized atherosclerosis. Some people have said if the diabetic foot pulse is poor, one must be having erectile dysfunction. If diabetic foot pulse is weak, one must look for cardiac atherosclerosis and look for the ischemic heart. These are the tips that you must do. Foot is the reflection of your generalized muscular structure, atherosclerosis, cardiac condition, erectile dysfunction, lot of things. So diabetic foot is very important.
So thank you, Professor Das. Thank you, Dr. Sen. I think it was not an interview. It was a parallel talk between Dr. Sen and Dr. Das. Very informative, very much, so many things to learn. Thank you, sir. Thank you, Dr. Sen. And now Dr. Das will give a talk on early detection and management of myocardial infarction.
Dear friends, this is a talk. It has been designed because the cardiac. We have 15 minutes. 15. Yes. Yeah. So the diabetes is taken as a heart disease. So infarction is very common. So we thought without this topic, this will not be possible to complete the meeting on the diabetes. So this talk and the slides have been prepared by my student, Dr. Babu Elumalai, who is a big cardiologist at the MGM Healthcare. You must have heard MGM Healthcare, which does every week 2 cardiac transplants, very big organization. He's a senior cardiologist there. So he requested that, sir, I'm not able to come. So I'll be presenting the slides, which I have contributed, but basically it is his slides. Next. So I'll do it here. So the title of the talk is the early detection and management of myocardial infarction in diabetes. So this is a talk oriented towards both cardiologists, because he's a cardiologist, and also diabetologist. So you'll find something which will be regarding the high-end echocardiography. We'll omit that. We'll not discuss that. We'll discuss what is most important to us. Now, it is needless to mention that 75% of the diabetics die of heart attacks, 3/4. And I'll have some water. So 75% die of the heart attacks. And the presence of diabetes increases the MI risk in the population. How much it increases? Doubles or sometimes triples. So a person diabetes very, very prone to myocardial infarction. Now this infarction can be manifest or it can be silent. So diabetics, when they get heart attacks, they may not have the usual pain, radiation, may not have sweating, because their autonomic nerves have been put off. So if you take 100 diabetic patients, you will find about 30% of type. Thank you, Bibu. So about 30% of them, the MI is silent. That means does not make any noise. So the presentations, I am coming little later, can be just patients says, I'm feeling under the weather. I'm not feeling well. They say, I'm feeling very fatigued. I'm very, very tired. I come back home very tired. Today, I'm very tired. They say, there is some sort of a pain in my abdomen, but no heart pain. Some in the abdomen, some indigestion. They go to the toilet and they have a heart attack, full-blown attack in the toilet. They will say that something is happening to me. I cannot, ghabrahat ho raha hai. I'm not feeling well. So one has to be careful about it. The autonomic neuropathy, which occurs in diabetes, that blunts the pain sensation. That's why there is no pain. And I told you that CV event increases glycemia. So you find even non-diabetics, when they have infarction, they can have hyperglycemia. So the question is, how do you differentiate whether it's a hyperglycemia because of diabetes or hyperglycemia because of the heart attack he had, because heart attack is a stress. There's a term called stress hyperglycemia. Am I correct? So it's just that is do an HbA1c. If you have doubt, do HbA1c. HbA1c is high, is a diabetic. Clear? And delay diagnosis, poor outcome. Early diagnosis important. That's why the talk is meant for that. Number two, why diabetics get heart attack? They have got not only they get heart attack. Number one, they get it more. Number two, they stay longer in the ICU or intermediate care. Number three, they develop more heart failure than non-diabetic. Number five, even after discharge from the ICU, they do not perform like non-diabetics. Then equal. Number five, now they are doing well with the I'll come to that, with the angiography and the stenting. And they are also candidates. If somebody has a 3-vessel disease, diabetic usually get multi-vessel disease. Others can get single vessel, double vessel disease. They get triple vessel disease. If you have a multi-vessel disease, the treatment is not stenting. Treatment is CABG, coronary artery bypass surgery. So that is the basics we must all remember. There can be accelerated atherosclerosis because of hyperglycemia. We discussed sometime by oxidative stress, endothelial dysfunction, and insulin resistance, which is unique to type 2 diabetes, IR, and insulin deficiency. So IR contributes to thrombosis. And autonomic neuropathy masks the chest pain, and HbA1c when more than 7%, that correlates with the plex instability. Therefore, type 1 diabetics destroy the beta cells of the pancreas, leading to insulin deficiency, reduction of the glucose utilization, enhanced lipolysis, insulin deficiency. We have enhanced protein catabolism. We have also diabetic ketoacidosis, diabetic coma, and in the insulin depletion. So the main culprit is hyperglycemia, which produces atherosclerosis. What are the atypical presentations that occurs in a diabetic? Number one, about 50%, 45% to 50% present silently. They have silent heart attack with non-classical symptoms. You know classical symptoms, I'll describe it. Non-classical symptoms. Like they'll say, I'm feeling shortness of breath. After I speak few words, I become a little breathless. After climbing up 4 or 5 stairs, not 4 or 5, 4 or 5, everybody will become 1 flight of stairs, I become a little breathless. Unusual weakness and unusual fatigability, nausea, epigastric pain, quote unquote hyperacidity. And you know, it is the women and the elderly people who have symptoms not properly experienced and described. Now, what is risk stratification? How to classify a diabetic? What is risk for getting heart attack? If the diabetes more than 10 years, if there is albuminuria, I will give a truth. These are my slides. I'll come to Babu's slide a little later. Now, I made this slide to say that chronic kidney disease of any etiology, diabetic nephropathy, non-diabetic nephropathy, because of the whatever polycystic, whatever is it called, the polycystic kidney disease, either recessive or dominant, all these, whatever the factor, if there is a kidney disease, one is very, very likely to get heart attack. So we give a term, I've given the term here, when we say that the kidney disease is a fertile soil, not to grow rice, not to grow apples, fertile soil on which heart attacks occur. So if somebody has a kidney problem, please remember, you have to keep heart attack in the back of your mind. I've written that if somebody has albuminuria, he's very likely to get heart attacks. So albuminuria, nephropathy, established chronic kidney disease, person who is undergoing hemodialysis, peritonitis, person who has got the kidney transplant, who has got NODA transfer, new onset diabetes after transplant. These are all perfect candidates to develop heart attacks. You must maintain high index of suspicion. And of course, somebody who has got autonomic neuropathy, he will be the heart nerves are caught. So he will not have any pain. Am I clear? There will be no pain because of the heart attack. There will be only non-specific symptoms. And you know, sometimes we do a NT and pro-BNP. You'll find they're raised, but normally raised we find in thousands. For diagnosing, 14, 15 is enough. But sometimes we find very high. Here the rise is not very high. You will find 100, 105, 125. That also you can find in investigation. Now, this is very important. This is our own data. If you do ECG screening, only 20 to 30% people, you will find Q waves in this silent MI. Even if it is silent MI, from the point of view of pain, even in ECG, it will be silent. You may not find Q wave. You may not find ST elevation. Am I correct, sir? You do not find Q wave, ST elevation, ST depression, total normal ECG. So in silent MI, not only that the pain is not there, the ECG may not have anything. Only in 25%, 1/4 of the patients of diabetic, we may have in the silent MI the Q waves. Then what do? We do ECG serially. We keep the patient observation. You have to keep the patient observation, keep the observation, do one ECG, then do one after 1 hour, after 2 hours. Serial ECGs we do to improve the sensitivity of detection. Number 2, there are some soft signs, like you find RV strain or LV strain. There is only T depression, say in the lateral 6, in the L6, in the lateral 6, or there's RV strain. We take it as an indicator for it can be ischemic heart attack or suggestive ischemic heart attack. And for every diabetic, we recommend annual ECG. And nowadays, because of the Ayushman covers the coronary CT score, we also do coronary CT score in every diabetic. Number 2, if you're doing cardiac enzymes, if you find that high sensitive troponin T signals myocardial necrosis, as I told you. Number 2, NT-proBNP can predict silent MI. I told you that even if minimally high, you can think of silent MI. Now, threshold of the high sensitive troponin is 14. I told that number 14. When I saw 125, I said 14. Prompts urgent evaluation. And combined with GLS, I'll explain. This is not my particular idea. GLS means global longitudinal strain. That's the echo parameter. So if it is there, 85% sensitivity to know silent MI. So this slide was made during COVID. I have put it here because during COVID in 2021, I was asked to prepare a set of slides how to diagnose. People are not going to see the patient. People are not leaving their home. I mean, they're very scared to go to see patient. So we said, cardiac biomarkers in the time of COVID, if somebody has SARS or COVID-2 infection, what you find, the traditional cardiovascular markers. So traditional means troponin T, NT-proBNP, and CKMB. These are the 3 we take as the biomarkers. And you do a lot of microRNAs. That time it was done free. Now we are not doing it. Like a lot of the microRNAs can give the diagnosis. The novel biomarkers, which have come to stay, but we do not use it routinely, are ST2, galectin-3, and GDF15. Expensive, so you do not use it routinely. So please confine to the symptoms, traditional markers like troponin T, NT-proBNP, CKMB, and that should be enough to give an idea. Now, this is the cardiologist slide. Now, if you do a global longitudinal strain, if it is less than 16%, then you find that it may be a coronary artery disease. It diagnoses subclinical LV dysfunction. LV dysfunction is by ejection fraction. No, ejection fraction normally above 65%. 65 below is the LV dysfunction. Up to 55 normal. Below 55, we say there is a LV dysfunction. Now, this GLS identifies people who have less ejection fraction, less contraction. And EA is the echo finding again for diastolic dysfunction. EA dysfunction is less than 0.8, predicts myocardial scar. Routine echo in asymptomatic high-risk patients must be done. If you find global hypokinesia, you can find RWA, regional wall motion abnormalities. Somebody has anterior infarction, will find the V1, V2 leads their area. There is a less contraction. You may find there's a paradoxical beating. And you get my point. So if you do an echo in the asymptomatic patients who are high risk, that will give an answer. Now, this again cardiology slide. There's advanced imaging modalities like CMR with the longitudinal global echocardiography, 90% sensitivity, CCTA, and stress echo. But we do not do this because we are not in favor of doing that at the time of having an acute attack. Recommended scanning algorithm, systematic approach for all type 2 diabetics, annual risk score, that is clinical plus calcium risk score, ECG biomarkers, abnormal result, echo, and do a stress test if the results are abnormal. High risk patients, you do CMR. Now, this is regarding the acute MI recognition. This is a very common slide. Suspect MI in dyspnea or fatigue with troponin rise. Because why do suspect early? Because for an effective thrombolysis, door to needle time, that means from the point you leave the house after the pain till the needle gives you thrombolysis. Anything, streptokinase, anything. Now you don't use that. Any higher kinases that we use for thrombolysis, this must be given within 30 minutes. Use half an hour, 1 hour troponin T to rule out protocols. This is typical of ECG finding of the PR. Sometimes PR may be prolonged. There will be QRS. There can be ST elevation. 2 millimeter elevation is important. 1 millimeter depression is important. There can be small Q. There's a small Q here, but it may not be significant. It's not 1/4. So there's a small Q here. These are the significant things to look into it. Now, if you want to have a case diabetic who has got infarction, you must do a primary PCI. That means should not do angio first and then take another session to do angio. Put the stent. We recommend primary PCI. Now there's a new term, called rescue PCI. When person gets severe chest pain, you cannot wait for doing angio and next session putting a stent. We do rescue, means you rescue the patient by doing a angio, rescue angio, and then you do the needful stenting. So angioplasty, door to balloon time 90 minutes, should be done within 1.5 hours. Fibrinolysis, if the more than 90 minutes, more than 2 hours, you go for fibrinolysis. Glycoprotein 2B3A inhibitors in NSTEMI and rapid access reduces complications. Whatever you do, what is important for us is acute glycemic management. IV insulin is used to maintain the blood sugar between 140 and 180. We avoid hypoglycemia because hypoglycemia can trigger fatal arrhythmias. Close monitoring is vital during acute phase. Reduce mortality if you apply this protocol. What do you give? We give DPA. DPT stands for double antiplatelet drugs. So DAPT, all my patients get aspirin plus clopidogrel. People cannot afford ticagrelor. If they afford ticagrelor, I give ticagrelor. It is also covered by the Ayushman. Ticagrelor is given by the Ayushman for 12 months. No, high sensitivity intensity statins. Please remember, previously we were giving 10 milligram, 5 milligram, 20 milligram statin. Now the rule is to give high intensity statin. What does high mean? 40 to 80 milligram. We do not give 80, we give 40 milligrams. So the loading dose in a case of ischemic heart diabetic, for any ischemia, the loading dose is double antiplatelet therapy, that is aspirin 75, clopidogrel 75 into 4 tablets we give. High intensity statin, if you're giving atorvastatin, we give 40 to 80. Similar doses give other things. And we give everybody either ACI or ARB. Never combine ACI and ARB. There's a renal trial, we showed enhanced death. We give either ACE inhibitor or anti-ARBs. We never combine them. So that they put the oblique in all diabetic MIs. And SGLT2 is a wonderful molecule to reduce heart failure and reduce the MACE in about 30% cases. So we always give SGLT2. SGLT2 also helps in non-diabetic. That has become the standard of care for any patient having heart failure or ischemic heart disease. For the secondary prevention, you maintain a BP of 130/80. LDL, the order is to maintain 55. But there is one of my very famous friends, Raman Puri, who presides over LAI. LAI means lipid as from India. He says bring it down as low as possible. So people are taking Locaseren, but I feel 50, 37, and this number is all right. Bringing down LDL too much can produce something in the cerebral. I won't scare you. Sometimes there are reports it can produce cerebral hemorrhage, but Ramanpuri will say, show me the report. I don't believe it. So he brings it down to 15. I saw a recent paper is advocating to LDL to be 0. Don't believe him. Don't believe him. Normal value is about 130, 135 in non-diabetics. Diabetic less than 100, make it 55. 2 minutes more. So you make it about 155. You smoking cessation. I do not see smokers because smoking has to be stopped. Smoking gives rise to heart attack. It has to be stopped. Has to be stopped. Has to be stopped. Exercise. You give 150 minutes of walk and cardiac rehabilitation. There's a model. You do that and. So a special population, as I told you, many of the infarctions have CKD. We give SGLT2, we adjust the dose because if it is the eGFR is less than 20, I cannot give. I have to give SGLT2 minimal with finerenone. If more than 20, I give SGLT2. Now we combine with finerenone, that is the confidence trial. Heart failure, we give ARNI. ARNI is sacubitril plus valsartan. Its price has come down. That is anti-heart failure medication. If EFR is less than 40%, pregnancy, I use insulin, and you have to go for a PCI. That is the intervention. And post-bariatric, reassess the cardiovascular risk. Now, usually we follow up all diabetics, 1 month echo biomarkers medication, 3 to 6 months stress test, annual CV reassessment, and we have a telemedicine. And if you detect early, it cuts mortality by 25%. SGLT2 reduces recurrent MI by 20%. Silent MI screening improves the MACE-free survival. And integrated care saves life. The final messages: early detection of a ischemic heart disease in a diabetic cuts mortality by 25%. They say muscle is money. Time is muscle. The more time you take to diagnose, more muscles are lost, cardiac muscles. So early detection cuts mortality by minimally 25%. SGLT2 inhibitor, if you give earlier or now, reduces recurrent MI, you need another 20%. Silent MI, if you diagnose by screening, you can only do it by screening. You find there's a EC changes or there's a abnormal wall motion abnormality, you diagnose. Then it improves the MACE-free survival. And if you do integrated care, you can save life. Thank you very much for a patient hearing. I can answer 1 or 2 questions.
Thank you, Professor Das. Please come. We'll have a short panel discussion. I'll request Professor Sen to come and join us. Sir, after the COVID, how do you observe the change in behavior of younger patients as regards cardiac problems are involved?
I think the younger patients are scared patients. 2 things we find: the people young who had COVID during the COVID episode, they come to us with lung fibrosis very often, and we use them phenendron, and that particular drug, antifibrotic drug, phenendron has made the change, and they survive. The cough disappears, the crackle disappears, they're better. Now, if those who have survived the COVID, they had COVID, they have survived COVID, they become bold. I find many of them alcohol, they take to smoking and all that. They become fearless. But now, I must tell you that you have to keep a high index of suspicion in the young people, especially those young people who are obese or who have a family history positive or who are sedentary. Majority of the people today are sedentary. Very few people like Brigadier Behra will go for a polo. He's going to a polo game today. So very few people are as active as he. So therefore, sedentary people, they have their attitude is they don't take their health as a precious thing. They're very careless. I think, I don't know whether they're satisfied or not.
Whether the incidence has increased
Yeah.
due to vasculopathy.
Absolutely. The incidence of infarction in young people has increased.
Young
very
and
much.
old.
Yes, I'll tell you, young and old both. As the head of the department, every morning I have a morning check. Morning check starts at 8:30, goes up to 9:30. They have to tell us the previous day admissions. Believe me, you please. It starts with, they will say, 2 infarctions, 2 intermediate syndrome, 2 ACS. They don't tell you the name and clinical feature. It's so common. 2 ACS, 1 wanted rescue PCI. We could not do it here. Sent to Jipmer. So, about 7 to 8 cases every day. I agree with you. Huge burden. Now say what DM to do. Cardiology will never be on the road, sir. There are plenty of heart attacks. Every PCI you put, the price of the stent has come down. Nobody can charge more than 29,000, but doctors charge. We pay through the Iceman. We pay for every PCI. We pay 13,000. 13,000 the procedure. So is as options has increased. Totally correct.
Sir, as you rightly told, the stent price has come down. My personal experience, I was told that one stent will cost 1,20,000. Then it was 3,40,000.
For single.
No.
Sir, you see, if we did drug-eluting stent, if we did drug-eluting stent from the best of the best companies, American companies, cannot cost 3 lakhs with the procedure. I have no comments to make, but people want to make. I'm not commenting the Apollo. People want to make easy money.
Professor Sen,
What work have you done to earn 3 lakhs? Even the price will be less than 50,000.
they told you 1T. Then I had
What right you have got to procedure for 20 minutes and 180,000 extra. Sir, all our patients under IVUS, IVUS, intravascular ultrasound guided, all patients are today IVUS. IVUS means in whatever referring to.
No, nobody forced them to tell the actual price. They told 1,20,000. The patient is ready. The moment they saw that there is an insurance card, they added another 2,70,000.
So IVUS.
So this is no explanation.
IVUS is done in the local hospitals here also. Sparse hospital.
IVUS, everybody is doing IVUS.
IVUS, and that cost, balloon, that cost, stent, that cost, doctor charge, that cost, hospital charge, that cost. So everything, they are taking 4 lakhs, 5 lakhs for one stent.
Dr. B.D. Chaudhary should be your hospital financial advisor.
Sir, no, sir was in Apollo. You were never in Apollo.
I was not in Apollo, but I have discussed with them why it is, cost is very so high. Because my friends are there, so they tell this way, because everything costs. Balloon cost.
You see, now,
they put the balloon, sir, you have shown the balloon. You have shown the balloon. That is costly. Balloon, they will put the balloon. Then stent, that is costly. Then IVUS, that IVUS implement, one-time use, that is costly. And the hospital cost and the medicine cost. So everything on combined.
Sir, I agree with you.
We should not because by Apollo, by CARE or by these hospitals, we are getting this chance. In government hospitals, like many hospitals are there, government, so we are not getting this chance. People are not benefited. So we should not tell that Apollo is doing like this. We are getting this chance.
What is the standard procedure in SCB Medical College for a stent?
Free.
Total free.
Totally free.
So
free of cost. Government supplied.
Then
we
you don't understand that. Anyway, please.
Now the issue is that, I was API president, and I was called by Pratap Reddy to meet him in Hyderabad. He sent me a ticket, and I went to meet him because he's a big man. I went to meet him. So he has a very high-ended attitude. He said, "My blessings for you," and all that. He started in his chamber. Then he said, "Can you declare health as an infrastructure?" You know what is infrastructure? Infrastructure means the taxes will be zero and there will be high end. So I told him it will affect my nation. I did not do it. And after that, he never talked to me. So, Dr. Sir, I will not dilate upon it, but here I'm telling you truth because so people want to make this. See, you just declare. I mean, like water industry cannot be compared to health industry.
So, Dr. Sen, in our setup at Kids Hospital, which was primarily a diabetes hospital, now multi-specialty, you saw so many cases. What is the socio-economic status of people, those who come to us? What is their ratio? Rich people and moderate and poor.
Sir, I cannot call anybody a poor, but low socioeconomic status, 60%, and people who can afford 5 to 10%, and the rest is in between. But definitely, after this BSKY government's program, kids should be proud to save a lot of limbs because the treatment cost is so high. Even if I do not know, probably because finance matter, I do not know. I think the hospital for diabetic foot hospital must be in a loss because the amount we spend here is we don't get from the government or anything, but still then nothing is more valuable than human life. So probably in 90% or more than that cases, we discharge the patient or we allow the patient to walk in his own feet and earn their livelihood.
So I'll tell you one thing. You see, we have a department of counseling, and counseling is linked to insurance. Those girls do counseling. They're trained counselors. They also do the insurance. That means they find out what the that everybody does nowadays. Now, if the patient cannot afford, the strictest instruction to them, they have to negotiate with 4 or 5 government hospitals which are around. And the negotiation means phone call, one-to-one call with the assistant professor on duty. We have assistant professor MD 3 years plus 6 years after MD. He will call personally to the doctor, maybe a senior assistant. Then the patient will go. Previously, the rule was one intern should accompany. Now interns are not willing to accompany. So we don't have intern, but one of the emergency medical worker trained by the Allied Health Science, he accompanies and he goes, and you cannot send the patient without talking to the doctor. That is High Court rule. You talk to the doctor, record what is said, then send it. Once you go there, it is done free because there are plenty of stents available. Today, cardiology is such a specialty, sir. There are so many people available that they're fighting themselves within themselves for what they call chance. And so therefore, they do it. And only rescue PCI in the middle of the night may be a problem because government doctors will not come in the night. So for them, we send them to East Coast Hospital, which is one of the best private hospital, because they charge 45,000 and the cardiologist for a half an hour, 1 hour work will come in the night to do that. 45,000 to about 60,000 he will charge, but that's rescue. So night I have to send them. So we have to measure, you have developed a procedure, how we can help the patient.
In our case, when we started diabetic foot division, all the surgeons told me, don't start it. It is a thankless job. I don't want to mention their names. But Professor Sen is a dedicated. Started it and for the poorest of the poor people. But for your information, which I have never told anywhere, our loss from foot care division was humongous. we provided him all support, even if we were not getting any return. So for 10 years, we have lost more than 1 crore on diabetic food itself. So, but he has done humongous job by providing care. People come with a hope to him. So, thank you, Dr. Sen, for all this. Thank you, everybody.
Sir,
We'll
I
go
have
to
got-
the.
I have got a question for
Yes.
Professor. Sir, about the risk factor, because everything revolves around me, food. Duration of diabetes more than 10 years. 100% of my patients are that. Albuminuria, 60%. Age 65, 80%. Age above 65. Okay. So NT-proBNP, probably those cases who have come here with heart failure and operated, no one is less than 3,000. So right now also 2 patients are there. They are probably 900 or something anti-pro. But what we will do? We will operate or we will not operate?
Sir,
And
it depends upon the impending gangrene. If the acute condition, acute diabetes.
sir, not only gangrene, what about the infection?
That's
Unless
why-
we, so
that's
what
why
I will do?
Pro-BNP 45,000, it goes into 1,000, 45,000, 40,000. We have, because heart failure streamline management. Like we have got JDFT, ARNI, we give ARB, we give MRA, and we give SAP.
No, with all precaution, but something.
All the precautions. You see, you also grade the heart failure. If the ejection fraction is 40, 45, 35, we do it. Below 30, below 25, maybe you should.
Sir, suppose below 27%.
But even if it 27, if it 10%, if there's
What will die?
impending gangrene going to septicemia, you have to take out. Guillotine.
That is true. Naturally, you have to go for guillotine. But you see, for infected cases, repeated debridement is also required. What I will do at that time?
Sir, debridement will not produce that much of HH, hospitalized and heart failure.
That is the extensive from leg to foot.
Yeah, you have to see, debridement has to be done.
The small debridement doesn't come here.
Sir, between the heart failure and the leg failure which is more important.
Exactly.
So you have, I think that's
Very nice.
Okay. Thank you,
Very
sir.
well said.
Thank you, sir.
I'll request Subhasri to announce for the next session.
Thank you to all our panelists for a highly engaging discussion on microvascular and macrovascular complications in diabetes. As diabetes continues to present itself in diverse and complex ways, it is important to address lesser discussed yet equally impactful complications. With this, we move into session 10, Complications in Diabetes, Part 3. I invite Brigadier Dr. K.C. Behra, Senior Consultant Diabetology, Kids Hospital, Bhubaneswar, to please join us on the dais. I also request Dr. Makarananda Devra,
Oh, I see.
Medical Superintendent, Senior Consultant, Obstetrics and Gynecology, Kids Hospital, Bhubaneswar, to kindly come forward for context setting. I also request Dr. Alok Kanungo to chair the session.
Ita, first talk, sir. Ita, Koibe. Kishore asle. Kishore introduction. Sir, आप परे कोटे प्रोफेसर हेमंत करन को देखो. Skill. थोड़ा बजाय चल. I request Professor Kishore to come to the dais. He's an academician with a lot of research in many fields of diabetes and endocrinology, and he has special work on sarcopenia I'll request Dr. Behera to introduce him.
Sir, he has good skills in the law. He has the bent of mind. Every time he meets me, he will tell me what are the what are the things with ICMR pending and what is that right.
Good evening to everybody. The person who is standing just in front of me, Professor Kishore Behera, to whom I know very well. As Professor Das told me, he is the product of Vellore. It is just the HOD endocrinology of All Indian Institute, Bhubaneswar. And any doubts I am having, or a person is coming from AIMS to this hospitalized, I used to ask him, you have not met actual Professor Behera. He is there. So he is such a nice gentleman and professional is very sound. And to his credit, he is having 43 publications in national and international journals, 6 abstracts in international conference, presently involved in 1 clinical trial. And whenever you listen to him, you'll feel very happy because he speaks very well. And today is the subject that prevention and management sarcopenia. We are just waiting for you, sir. Please start.
Thank you, sir, for kind words at the outset. I am thankful to Professor Das and Dr. Kanungo inviting me to give the last session of the talk. And it's a very interesting talk. And actually, as we grow older, and probably in India also the lifespan has been increased because of, change in lifestyle, and also there is people can afford the drugs which has been now on pipeline for the management of type 2 diabetes and obesity. So I'll be discussing about the treatment option for sarcopenia and the frailty among the older diabetic patient. Also I will cover in general how we'll diagnose the sarcopenia, why it is so important at present. So these are my outline of the talk. I'll be discussing introduction, defining sarcopenia, evaluation of sarcopenia, epidemiology, cause and risk factors, treatment, and some of the work which has been done recently in our institution, and some of the epidemiological studies which has been going on. Probably we are planning to have a normative data of this East India. The only normative data which is available by the CUBE study has been done by the Dr. Badada et al. From the Chandigarh. So the sarcopenia actually it is a reduction of the muscle mass, and also when you have a decrease in the muscle strength or performance. So usually now it has been told by the ASEAN guideline that probably when you are sitting in the OPD, first you check the muscle power. If your power is low, probably you can go ahead with the muscle mass estimation and the muscle performance. And it really associated with the morbidity, mortality due to physical disability, falls, fractures, and poor quality of life, and also depression and hospitalization. So when we check or when we diagnose the sarcopenia, actually we first check the hand grip strength. If it is less than 28 in male and 26 in men and 18 in women, probably it said that the hand grip power is less. Muscle mass, usually we use DEXA and bioelectrical impedance. The DEXA, it is 7 for men, and for women it is 5.4. In BI also, the 7 kg per meter square is also same that of the BI, what is been measured in the DEXA. And for when you use the bioelectrical impedance, instead of appendicular lean mass, we take skeletal muscle index. For women, it is 5.2 kg per meter square. And for gait speed, usually we ask the patient to walk for a 6 meter. So if they cover of less than 6 seconds, then probably we say probably they don't have any difficulties in the performance. If they delay more than 6 seconds by covering the 6 meter walk, then we say probably they have a problem with the performance. So that is how we diagnose the process of sarcopenia. So primary counseling, we can have a SARC F4, or you can ask the patient to sit in the chair and get up, or you can ask to walk around, or you can give to check the muscle power. Then followed by, if these two are having difficult or problem or less than what is been given, then you can go for estimation of the muscle mass by bioelectrical impedance or DEXA. So low muscle mass plus either low muscle strength or low physical performance, we say this is sarcopenia. If you have all three are low, probably you can say they have a severe sarcopenia. In top of that, when you are using the DEXA, you can have the BMD, bone mineral density, and you can add that with osteoporosis or osteopenia. We can tell that probably the patient having osteosarcopenia. And if you can add sarcopenia with obesity, you can take the BMI or a muscle fat estimation. If it is 30, more than 30 in male and more than 25 in, more than 25 in male and more than 30 in female, then you can say probably the patient having sarcopenic obesity. But today's talk about the sarcopenia. So that is how the ASEAN Working Group for Sarcopenia has defined in 2019, which is I have already explained. So evaluate the sarcopenia, you check the muscle mass. If it is less than 7 in male, less than 5.4 per meter square in women, with hand grip is less than 28 male and 18 for women, probably you have a probable sarcopenia. And if you have a less muscle mass plus either of the hands meter, you will cover more than 6 seconds, probably you have a less performance, and so you will define as a sarcopenia. So these are the various prevalence which has been shown. But what I want to show you, and it has been shown in our study, like in Orissa, that is, they've taken the type 2 diabetes of age more than 50, which is found the prevalence of the sarcopenia is 35%. And another study from India, it has been shown by using the AWGS criteria, it is almost 45%. And the cause of sarcopenia, you can have the primary sarcopenia, like you don't have any cause, but as the age progress, you can have a primary sarcopenia, or you can have a secondary sarcopenia, most probably, for example, you can say some of the endocrine disorder like type 2 diabetes, or you have a growth hormone deficiency, or some of the nutritional or metabolic condition like malnutrition or decreased protein intake. So that can cause the secondary sarcopenia. And the most important factor what cause sarcopenia is probably the mitochondrial dysfunction with release of reactive oxygen species that leads to decrease in muscle mass, muscle strength, muscle quality, and physical activity. So underlying cause of sarcopenia, we can just remember 4D. Common is use of statin, fibrate, steroid, or alcohol intake. Less common like chloroquine, colchicine, antiretroviral drugs, and some of the chemotherapy medicine. And most importantly, because around 10% to 15% of the general population in India are suffering from type 2 diabetes, so they can develop sarcopenia. And we'll be discussing what is the prevalence, which we have done a recent study taking from the age 50 onwards, and other disease like chronic lungs disease, kidney disease, liver heart disease, and also NFLD, and also chronic liver disease can cause also sarcopenia. And deficiency like poor dentition, swelling difficulties, vitamin D deficiency, and other condition can leads to initiation of the sarcopenia. So these are the molecular mechanism of sarcopenia. When the age progress, that inhibits the agrin MuSK LRP4 receptor, so that leads to defect in the neuromuscular junction lesion, and so the propagation of the impulse is halted, so there will be less contraction of the muscles. Second thing, when you have a less IGF-1, when you become aged, so the insulin growth factor 1 will be decreased, so that leads to phosphatidylinositol AKT mTOR pathway that leads to decreased protein synthesis, or you can have a TNF alpha or ROS that leads to UPS upregulation that leads to increased proteolysis, or malnutrition leads to stimulation of the FOX3, so that also leads to increased proteolysis, or stellate cell dysfunction by the pathway of the WT catenin pathway, that all leads to the genesis of the sarcopenia. Now coming to the treatment, the most important treatment of the sarcopenia is Number one, what has been shown, adequate supply of nutrition in the form of protein. Physical activity, the most important is the resistance training or resistance or aerobic training or balance. Both is what is essential. Nutrition, probably the more protein intake will be discussed in detail. And that consists of branch cell amino acid like valine, leucine or isoleucine. And it's been shown that vitamin D and calcium intake also leads to increased muscle performance. And combination of the both physical activity and the nutrition. And what about the pharmacological intervention? Probably it is not been shown. I'll be showing some of the trial, but it's still yet to be implemented in the clinical practice, and some of the herbal medicine which will also be helpful for the prevention of the sarcopenia. So far as the guideline of ICSFR recommended, a minimum of 150 minutes of moderate exercise per week, 30 minutes of moderate intensity endurance physical activity on 5 days per week, or 75 minutes of vigorous intensity aerobic activity. But this vigorous activities, it may not be feasible for the old age. Those are having more than 50, more than 70 years. So what you can do, you can ask them to give some flexible string and ask to have the resistance exercise. That also quite easy. Everybody can do that. So resistance exercise is most important. And these are the various pattern of the resistance exercise. You have to look up the training frequency, exercise selection, intensity, exercise volume, and the rest period. All these need to be taken into account. So treatment is first resistance training, followed by protein intake. And it was advised that you should take around 1.2 to 1.5 gram per kg body weight of protein. Only things that you have a kidney dysfunction with EGFR less than 30, probably there is a contradiction. Should not give protein more than 1.2 gram per kg body weight. So resistant training is performed option for the management of the sarcopenia along with the good intake of protein. And these are the nutritional intervention for the sarcopenia. So what I want to just convey here, the next slide, that those are the compound like urosolic acid that increase the IGF-1, increasing circulating muscle IGF-1, activate AKT-mTOR cascades, or HMG, that is beta hydroxy beta methyl butyrate, that increase the protein synthesis and decrease the autophagy. Omega-3 fatty acid, it has got membrane remodeling on protein synthesis efficacy and also having anti-inflammatory activities. And olingonol, this autophagy, that inhibits the autophagy. And also it has got some effect in mitochondrial protection. And recently it has been shown that anecdotal probably imigrilin has got some effect in the preservation of the muscle weakness, but this study is still lacking. So now the emerging treatment is omega-3 fatty acid, which has been shown that is a primary outcome was upper extremity muscle strength and lower extremity physical function. And the 16 RCT trial with high dose 2.5 gram per day yield a greatest improvement in both upper extremity muscle strength and lower extremity physical function. And how it acts, it modulates the neuromuscular junction, increase the muscle protein synthesis, and decrease the muscle breakdown. So it has got some effect in prevention of the muscle mass and increase the muscle performance. And leucine hydroxybutyrate, which has been shown that it's open label randomized control healthy women concluded that shows the promising in resilience strength, although it has got no significant effect on short physical performance battery score. However, the role of HMG in older adults is still under debate. And the other drugs, which is most, that is myostatin activin pathway, that is the monoclonal antibody that binds and neutralizes the myostatin. Actually, myostatin has got the impact on, inhibits the muscle mass, and the bimagrumab, a monoclonal antibody that binds to the and inhibits the activin receptor type 2B. These drugs are still considered investigational and further research is required. And this is the efficiency of different intervention in treatment of the sarcopenia in middle-aged elderly people a network meta-analysis which shows that probably the resistance exercise combined with nutritional significantly increase the fat-free mass, and also it has got some effect in increase the physical performance. So resistance exercise combined with nutritional intervention have the best effect in relieving the sarcopenia and can effectively improve the muscle mass strength and the functional performance. So these are the key players like myostatin, activin A, and activin receptor 1B receptor. These are the molecules now been on active trials. And coming to the diabetes and sarcopenia is the bidirectional condition, and that leads to hyperglycemia elderly, leads to sarcopenia, dementia, and depression, and that leads to decreased daily activity. Now, this is the study we have done in our AIMS, which found the proportion of sarcopenia was 68%, and sarcopenic obesity was 48.6%, and the severe sarcopenia constitutes around 13% in our series. So these are the drugs which has been now in the pipeline. That is the drugs which is bimagrumab blocks activin receptor 2, and now used to treat sarcopenic obesity. It is used in combination with semaglutide, which shows that by using the drugs actually it decreases the fat mass around more than 70 to 80% and increases the lean mass, which is very important to preserve the lean mass. And epitugrumab targets pro-myostatin, and phase 2 EMBRACE trial provide 54.9% muscle preservation in patient on GLP-1 weight loss drugs, and tribogrumab that neutralize the myostatin often tested in combination with geritumab activin A inhibitor for maximum muscle sparing effect, and sacronius, the mass receptor agonist, successfully combined with phase 2 trial moving to phase 3 for improving in the physical activity, that is the GET speed. And these are the herbal medicine in sarcopenia. Actually, the safe, inexpensive, easily available, the coumarin, resveratrol, green tea, and ginkgo biloba, and it has been shown that it's got multiple effect. It increases the physical performance, increase the hand grip extension strength, and probably it acts in the modulation of the ROS and increase the phosphatidylinositol AKT pathway. So it can preserve the muscle, and sometimes also it's shown that it can preserve the muscle mass also. So the overview of the current strategy, potential benefits and limitation of the managing sarcopenia. So exercise intervention, protein ingestion, amino acids and vitamin D, therapeutic agents like testosterone, some like only drugs which is approved in landrolone, which can be used in 25 to 50 milligram weekly for 6 months only. You cannot use more than that for the preservation of the muscle mass and muscle performance. And increase muscle mass, this is the potential benefit. And adherence to exercise regimen, exercise intolerance, frailty, poor nutritional status, or anabolic resistance. These are the, sometimes you may not get that may be the only limitation. And the takeaways, sarcopenia and diabetes are bidirectional in nature. Resistance exercise, protein supplementation, and good glycemic controls are key to success when type 2 diabetes causing the sarcopenia. And when the sarcopenia, the primary sarcopenia without any disease, like the age-related sarcopenia, probably resistance exercise with protein supplementation around 1.2 grams to 1.5 grams per kg body weight, or 20 grams in setting like breakfast, lunch, and dinner, which hold good. Along with when you do the resistance exercise, just recovery of the resistance exercise, probably you can give the vitamin D calcium supplementation around 1 gram of calcium per day. That has been shown that it improves the muscle performance and the muscle power, but usually does not increase the muscle mass. So the diagnosis of the sarcopenia, various diagnostic criteria has been put forward, but what has been done, probably we have to stick to the ASEAN guideline till we have our own guideline, we have our own normative data. So with this, thank you for the present hearing.
Thank you, Kishore. A wonderful talk on sarcopenia. chairpersons will give you thanks. But I have one question. You have seen so many sarcopenics. How many of them do improve? And in the present context, most of them are diabetic, and diabetic sarcopenics, what is the duration of improvement and how many of them exactly improve?
It's an interesting question actually. When we just 2000, this is 26 or 2022, we have started this. I was thinking because that time DEXA was not there with us. 2019 it has come. So we have a bioelectrical impedance. So then I thought probably this is the new area we should explore. So 120%, and actually if you'll see the glycemic, the glycosylated hemoglobin, what we found in our study, the BMI is the sole factors. But now when I give in a thesis to our PG student, so we found that it is not the BMI, it also the protein intake, this SNRI, protein intake also is a detrimental for sarcopenia. And what we found about we have followed for last 5 to 6 years, and surprisingly those are having H1AC more than 8 and 9. And when we recheck the muscle power, actually the muscle power has improved drastically. We didn't do anything, we had just have a good glycemic control, and we advise to go for a walk. And after for repeatedly around 120, 40, 60 patients are coming, those are having the performance was very low, around 8 seconds, 10 seconds. Now it has become 6, 4. The performance has improved a lot. Power has improved, but the muscles mass not been improved. So the takeaway is that if we control the blood sugar also, it has got a very good impact on the performance and the power, which is make a huge sense because they are not able to do the resistance exercise unless you do the resistance exercise and you give the high amount of protein. Whey protein is good, but it is very costly. And other than the whey protein, the next best is casein. You can give the casein protein, or you can give the plant protein. So this cohort what we are just planning to have some protein by the indigenous proteins, and we can give the resistance exercise. We are planning to do a trial for 20% to see, because the protein, if you will give a amino protein, is very costly. 800 gram cost around 4,000 rupees. You will give a Proens D or some protein, even 500 grams is cost around 800 rupees. So it's very costly. So whether we can give the resistance exercise, do the good glycemic control, optimize the vitamin D. In our series, we found around 20% are having vitamin D sufficient, 60 to 80% patients, 60% having vitamin D deficiency, less than 20. But now because everybody is now giving the vitamin D, we have not got the vitamin D less than 10. That's a very important, because when 10 years back, everybody was having undetectable vitamin D. So the point is, if you give the vitamin D, good exercise, walking, and then probably the performance and the power will improve.
Your opinion on whole egg or egg white to these patients for protein replacement?
I think any protein is good rather than not taking any protein. And when Dr. Marwa sir has come, he told us only what you have not checked the protein intake. So what we did this time, we have a 24-hour nutritional recall, and we found that our protein intake is very low, very low. So if you can increase the egg white, or the best thing is you support in the morning time, because in Orissa everybody wants the chuda, and you can give the curd, or you can give the butta chukka. So when we check that, that has got a very good amount of protein, which at par that of the, I mean, those are for vegetarian. Those are non-veg, simply we can give the fish or the egg white, which is very good, and milk probably also very good.
Thank you. Professor Das, would you like to add one few lines?
Just wanted to ask a few things. We brought out a small paper, you must have seen that. We wrote about
Yes, sir.
anabolic
API.
steroids. Yes.
Yes.
We also wrote about the anabolic steroids. And what is your, I'll go one by one. What is your opinion on that?
Sir, we have not started because I think I have gone through this paper. You have the first author and Lakshmi and Nitin has written that.
Correct. Nitin is
and
there.
expert opinion, all that.
Yeah.
So, London rate, actually, I have not started because in this series, I have taken more than 60 years.
Correct.
And around 45% are having sarcopenia. And that time it is a non-funded project. So then I told, let us.
Now you got funding.
No, it is not funded because this is the thesis. So another one small funded.
Marwa came without fund.
No, that is for another. I mean, he has done for the thyroid one, that's ICMR project. So now one project is going on to have a normative data of 700 patients. So from that we can get what is happening, our strength, because what has been done, there is a difference between the ASEAN guideline and the Chandigarh. They have also difference in the muscle mass, all that. So really whether we can have the difference or not.
Yeah.
But Nalendranath, I think we can. The problem is that all the 65 years old, they have a prostate problem.
Yeah, you have to
so they have so that's a difficult to.
Yeah, we selected patients barring them. The second question I want to ask you is that, you have given bedside tests about 6 meters, less than 6 times. For a ready reckoner, because it's a very common problem. We see the photograph of people who's no cheekbone, no cheek muscle, nothing. And whatever they lost is 7 fat and 3 muscles. Am I correct? When the loss starts, it is 7/3. So what is the simple test out of all that you have described, which will take? Or you want us to buy the handbook, or you want to do the test, or we do also sit-down test? Just give a simple message for us.
I think such a simple message you have already told. Probably the best one, you just ask him to sit and get up. That is the best one. 6 times. Because for walking for 6 minutes for an old age may be difficult because they may fall down. So just ask them to sit and get up. From that, if performance is low, very quickly you can do the hand grip test, followed by you can go for bioelectrical impedance. It's a very cheap, 5 lakhs. Now we got, now one has come 270S. You can measure that phase angle. From the phase angle, you can find out whether they have any inflammation. This is really very interesting. And we have found that, sir, it's an excellent correlation between the appendicular lean mass to that of the SMI, around 0.86. So that's why no need to use the DEXA for measurement. And skeletal muscle index is excellent. Bioelectrical impedance.
Bioelectrical impedance, there is 8 lakh machine, 2 lakh, 6 lakh, 8 lakh.
Sir, we have a 5 lakhs, another, because that time I was a little scared, so I should have got that, because once we get in government 5 lakhs, you may not get another for 5 years.
So what I'm referring to is a machine which is marketed by a company called InBody.
InBody, yes.
You know everything. So InBody is a company which is giving you machines where you can use your resistance just by holding it. And that is very good. It starts with 2 lakhs, 5 lakhs, 6 lakhs, 8 lakhs.
Now the latest one is 27 lakhs. Yeah, I told you just wait for another 2 years, then we'll get it.
So that's a good machine. And the final question, very akin to our VIP. You also told about omega-3 fatty acids. Do you think fish protein?
Yes, sir.
I think degenerative heart attacks in our population is prevented. You're a veg or non-veg?
Sir, last 3 years I give up the non-veg.
What happened? So we are all absolute non-veg, we're vegetarians. So, and you said that if you take omega-3 fatty acids, you pointed out that it helps in surgery. So I advise my patients who are in non-fish eaters, we come to the medicine purpose. I think that
But you can take the chia seed which is chia seed. Sir, you can take, I think if you take the fish and if you take the 1 spoon, it costs around 10 rupees. I think 10 rupees is, anybody can a cup of tea. And that, yes, so I think Chennai is now 25 rupees, but still we get a 10 rupees Chennai. Costly. So if you give the chia seed and we have other things like, no sir. So I think the best, what I used to say, you take the chotua, keep it the cod, because for elderly people, we have a GI intolerance like milk. But cod, there is nothing, and you have a good microbiota. You can create good microbiota also. Butta chotu, chuda, and you keep this the staple food for the breakfast. No need to depend upon anybody. I think from that you can get 10 to 20 grams of protein. And rest, if somebody like to eat egg is fine. If somebody like the coastal area, we get lot of seafood, not in Bhubaneswar, like in Balasore.
Recall my professor, your professor's words. Professor Vivek, he used to say everybody should take fish.
Yes.
Because we have 50 million years of fish at the bottom of the sea. They have not come to surface. So they have not. So it is, and they replenish very much. But I'm not believing that everybody should be fish. But that's also one of the things that you said in the lecture. Chia seeds, I know, but getting it and getting it in the spoon, we have to take that. And of course, your.
No, sir, that is only those are vegetarian. So that's
one clarity for our people. We usually take a lot of sukhwa.
Yes.
Your opinion?
Sir, sukhwa's problem is, I don't know about it, contains a lot of salts.
No salt sukhwas are there. No salty sukhwas. Dry fish without, not those salted ones. There are plain ones.
So the punchline is any protein is better than not taking protein at all. So if you can take any kind of protein, but if you take the best protein, usually so far as the vegetarian, whey followed by casein, best one. And so far as the protein, I mean, these are comes under the white protein, not the red meat. I mean, so that is good. There is no problem. We can advise them to take, but it should be in a good, proper, hygienic way, because the way the sukhwa are sold, it is very difficult. And because we are come from the Balasore, you ask why I gave up the fish, because we don't get that kind of fish what used to take, I mean, in 15 years. Because we have to get the fish, we have 3 ponds in our house. So we take it, but here you will go to unit 4, it is all formalin. So that day I told it's better not to take the fish. That's why I gave up the fish. So that is the, and I mean, chicken, I don't advise anybody. It is a full of garbage there. It will make, it is a endocrine disruptors rather than, it's better to have the, yes, yes, sir. I mean, how you can expect
The broiler chicken has
20 days, they have putting everything, growth hormone, estrogen, everything. So, and fish you won't get, and whatever fish you will get, it is all the, I mean, chickens, thing they will eat and you will get. So now the, I mean, good fish to get, it is better to have a sea fish, at least good sea fish is fine.
Thank you.
Good evening to all. Our next speaker is Dr. Hemant Kaur. Professor Hemant Kaur, please come to the dais and present his delivery.
Professor Hemant Kaur, to whom I know very well. He was there in Delhi and known to all actually bureaucrats and the politicians, because he is HOD of that hospital, Ram Manohar Hospitals. And now he came to KIMS, he is HOD dermatology department. And I want to just tell him one thing, I know him very closely. He is respected by each and every person of the KIMS hospital, from all the faculty. That is what personality he is having. So a lot of respect for you. Please start, sir.
Thank you very
10
much.
days back, I purchased the latest edition of Harrison text. And Professor Kaur is an author in the dermatology section of Harrison textbook, and all the pictures that Harrison has given is from him. So he is an asset to the state and to the country.
Thank you so much. Good evening to everybody. Thanks, Dr. Kango, inviting me for this session. This is the last session, I think. So it's a very easy session. There is no mortality, but there is a lot of morbidity. Any diabetic patient comes to me, sir, बहुत खुजली हो रहा है, बहुत कुंडी हो जी. किम्स रे जने बड़ा प्रोफेसर आसी मो पाखे पहुंचले, सर मु ओटी छेड़ी की आसी, बहुत कुंडी हो जी, and he is diabetic. कि कौन लोग होसुंदी अपना? ना इतने जितने प्रकार मलम अच्छी मार्केट रे सब लगे चले, पर किसी भलो होनी. मुझे गोटे एडवाइस देली, अब गोटे कथा करतु, काली सकाळे गाधे सारी करी भलो कि नड़िया तेल लगे आसतु. जो नड़िया तेल मार्केट में मिलुछि पेसंतु. सकाळे लगेबे पुणी संध्या बेलକୁ लगेबे. 2 दिन पर आसी कहले सर की मैजिक कथा मते कहले. मोर तो सब इचिंग भलो ही हला. मु कहली आपण ओडिसा रे एते बढ़िया नड़िया तेल मिलुछि, रंधा नड़िया तेल. आपण ताकू के लोग उरंती. Dry skin, gerotic skin is a main complaint in all diabetic patients. The best is use coconut oil. That's the point I get to him. And he was so happy with me. I am no more coming out of OT now. Maybe 3 hours, 4 hours. I am not getting any itching. I am not taking any medicine also. Anyway, it's a. So I will try to, because it's a long lecture, I will not go back. I just go through the books, go through the pictures. These are my contents, but I will quickly go through it. So far as diabetes is concerned, almost 30 to 70% of diabetic patients get some amount of skin problems throughout the life. Any one time, 30 to 70%. So if you divide cutaneous manifestation in diabetes, I can say some skin manifestations are very strongly associated with diabetes. Some are non-specific dermatological conditions, signs and symptoms associated with diabetes. And some of the dermatological diseases are associated with diabetes. And most part is diabetic medicine, oral medications, and even insulin also can produce some amount of side effects, cutaneous side effects. Strongly associated diabetes, most of the diabetic patients come to us with acanthosis nigricans, very, very common. Acanthosis nigricans, there is a multiple poorly, you can find blackening, velvety color around the flexors, back of the neck, axilla, groin, they all come. And you will find they're very obese and diabetics. Though the lesions are symmetrically distributed in the interdigenous folds, and also in hands and palm also, they become very black. I am not coming to histopathology because they are pathogenesis also, or hyperinsulinic state activates the insulin growth factor, and that receptor are present in the keratinocytes in fibroblast, and they stimulate the fibroblast and keratinocytes to multiplication, and the skin become thickened and they become thick also. Associated conditions, insulin resistance and others like obesity, polycystic PCOD also, and Cushing syndrome, acromegaly, thyroid dysfunction, all are associated with acromegaly. Okay. So you can see the skin, how the skin of the diabetic patient become thick and blackish. They are all nothing but acanthosis nigricans. Treatment part is concerned, they are treating the most important, you have to treat the diabetes, lifestyle changing, diet modifications, physical activity, as Dr. Vera told, exercise, 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 nothing better than that, and walking. Any diabetic patient, I always like, what? Increase your muscle mass, so the glucose level will come down automatically. Medications like you can apply improved glycerin control and reduction of insulin resistance that you do. And most important is you can give some amount of emollients like topical retinoids, very good. And topical vitamin D analogs like calcitriol and also ammonium lactate, salicylic acid you can apply, give some amount of relief. Diabetic dermatopathy, all pathies. We have already covered retinopathy, nephropathy, neuropathy, now the dermatopathy. Diabetic dermatopathy, most common dermatologic finding in diabetes. Typically, you will find on the legs, seen of the tibia, not pigmented masses. Either is brownish or blackish on both tibia. And they also, there is first it develops well circumscribed atrophic brown macules, fine scales, and then the resolve it. Typically dissipate after 8 to 24 months, leaving behind concavity or hyperpigmentation. Very, very common diabetic dermatopathy, but doesn't create any problem. It doesn't produce any problem. These are very classical case of dermatodiabetopathy. Pathogenesis is unique. I don't want to go in detail, it's not required. Diagnosis also histopathological, you can find a lot of hemosiderin pigments you'll find on inside the dermis. Systemic association, diabetic dermatopathy is always asked with retinopathy and neuropathy. That will not go. I'm just skipping it because time is very short with me. So most important is glycemic control. Prevents the progression of associated microvascular complication. Any type of dermatopathy, it is associated with either vasculopathy or neuropathy. Most important diabetic foot syndrome already been discussed by the ulcer. Diabetic ulcer is the main problematic conditions which can lead to necrotizing fasciitis and even danger of amputation of the foot also. So DFS encompasses neuropathic and vasculopathic complications. Early signs will find a lot of callosity, patient develops a dry skin in the plantar aspects, and there may be erythromelalgia, redness, warmth, burning pain, worsened by heat and exercise, improved by cooling, and late stage patient develop chronic ulcer. Diabetic ulcer, almost 15 to 25% of diabetic patients should develop ulcer. It could be neuropathic, it could be ischemic, and sometimes most of them are both ischemic and neuropathic. Mixed combination are both, and the locations are usually prone to trauma. There is bone prominences there, like toes, foot drops, forefoot and ankles. And untreated ulcer heal within 1 year, but 50% recurrence usually occurs within 3 years. Pathogenesis we know very well: neuropathy, atherosclerosis, impaired wound healing, and as you know, long-standing hyperglycemia, advanced glycolations, end products like AGE, they are pro-inflammatory. There is oxidative stress, and there is nerve demyelination, neuropathy, and arterial atherosclerosis. All leads to non-healing wounds. And in the initial stage, M1 stage, there is macrophages. They are pro-inflammatory. Later on, they become macrophage healing stage. That is hyperglycemia prolongs the inflammatory response, impairs the macrophage functions. I'll just blot this complications of, as you know, there is Charcot's joint. Everybody will know it. Charcot's foot, Charcot neuroosteoarthropathy. There is irreversible, debilitating, deforming, progressive destruction of the weight-bearing bones and joints, and ultimately collapse of the midfoot, and it is called rocker button foot, very classical rocker button foot. Treatment is daily surveillance, appropriate foot hygiene is very important, proper footwear, very, very important. Microcellular rubber, MCR rubber is very important if you have neuropathy, and workers should distribute the patient. Wound care is very important, that has been discussed earlier. I will not go into it. Hyperbaric oxygen therapy is very, very important. That this is very important if you have hyperbaric chamber. The best way, I have in RML, I have a very good hyperbaric oxygen. All diabetic ulcers, we put them in there, and healing was very fast. Healing was very fast. Now I think is now available locally. Hyperbaric oxygen therapy now. Some company has come up with a hyperbaric oxygen therapy. Okay, diabetics, thick skin condition, very, very important. That scleroderma-like changes and maybe limited joint mobility also, and sometimes scleroderma diabeticum. There is a very specific condition, scleroderma diabeticum. I'll come back and show the pictures actually. These are because of thickness of the skin, both in hands and feet. Scleroderma-like skin is the thickest indurated mass and occasionally waxy in the appearance. Typical painless primarily affects the acral area, usually asymmetrical and bilateral, especially involves the dorsum of the fingers and not the sclerodactyly. Sclerodactyly is very common. The proximal interphalangeal and metacarpophalangeal joints are involved. That the severe disease extends centrally from the hands to the arm and back, gradually from dorsal to proximal. Complications, the microvascular increased risk of developing nephropathy and retinopathy. They are more prone to develop retinopathy and nephropathy, and that's called diabetic hand syndrome. Frequently, it is associated with limited joint mobility. That's called prayer sign. Palmar fibromatosis, the Dupuytren's contracture, and that is stenosing stenocyte with that trigger finger. The very common trigger finger. The treatment is glycemic control medications. Aldose reductase inhibitors are maybe efficacious, and physical therapy, that is maintain and improve the joint mobility in patients with restricted range of motion. Very important. Exercise is very important. Oil massage also very important. This is called typical prayer signs and tabletop signs, because of sclerodactyly, patient cannot approximate their palmar and the plantar aspects very closely. Scleroderma diabeticum, that is one of the many important findings. Chronic, slowly progressive sclerotic skin disorder. It is an indurated thick skin, usually normally upper part of the back, bilateral symmetrical, doesn't respond to any treatment. Only you have to treat the diabetes. Then only probably because it is beyond, because of the collagen fibers become proliferated, and also fibroblast also, and very difficult for it. There is no sclerosis like scleroderma, but it is, that's why it is called scleroderma diabeticum. The treatment part, the unsolving and progressively slowly every years, improved glycemic control may help prevent, but evidence does not show clinical improvement. Therapy, first line, medium to high dose phototherapy sometimes helpful. That's why we give some cases phototherapy, PUVA therapy, or UVB therapy. It may be helpful. In severe cases, we give oral methotrexate, and other immunosuppressants can be tried, and physiotherapy. Then necrobiosis diabeticum is a necrobiosis lipoidica is another very close, but very rare, maybe 1% in case of diabetes patients, and they are looks like they are bilaterally, usually on the pretibial areas, since rarely affects the forearm, skull, face, abdomen, and pruritus, hyposthesia, pain can occur, and 15% of untreated lesions resolve within 12 years. Histopathology, very classically palisatic granuloma, that is diabeticum. Complications, it may undergo ulcerations, secondary infections, and sometimes malignancy as with squamous cell carcinoma also. Treatment improves glucose control has not been found to improve the skin lesions, unfortunately, but we tried calcium inhibitor, topical cyclosporine you can try, wound care you have to give, surgery, spleen skin grafting may improve some of the ulcerative lesions. Bullous diabeticum, very often we see the bullous lesion on the acral areas. It could be because of oral diabetic agents, or it could be directly because of diabetes. It could be intraepidermal or dermoepidermal junction. And bulla surrounding area are non-tender, frequently bilateral, primarily involving the acral area of the lower extremities. So blistering acral area is very common among the diabetic patients. The condition is self-limiting and resolves without treatment. Avoid secondary infection, sequelae like necrosis and osteomyelitis. Blister should generally be left intact. Don't try to rupture it. Rather, if a large blister is there, you can aspirate to prevent the accidental rupture. Topical antibiotics are not necessary unless there is a specific indication such as positive culture or secondary infection. Just dressing is sufficient, the blister is come down. 3 days back, we saw a patient is already in the ward admitted. That is occurs because of oral diabetic drugs also. Some of the drugs can produce also this type of blistering. I'll come back to that. Some non-specific dermatology sign symptoms, as I told you, ichthyosis, xerosis, or dry skin. Acquired perforating dermatosis also very often occurs with diabetes. Eruptive xanthoma, I'm just skipping it because time is short. Acrocodons, diabetic associated pruritus, Huntley papules, finger papules on the back side of the dorsum of the fingers, you'll find some of the papules. These are the type of papules we find on the dorsum of the hands and the feet. And pigmented purpuric dermatitis, PPD, because of blood accumulation on the lower part of the leg, because of obesity. and this palmar erythema. You will find most of the, some of the diabetic patients have red hand and also face also. Rubeosis facie, yellow skin nails, yellowing of the nails also you may find because of presence of carotene and glycolylated protein accumulation on the nails. Periungual telangiectasia also, about 50% of diabetes will find periungual telangiectasia also. Some diabetic dermatologic diseases associated with diabetes. So along with diabetes, many of these skin conditions, I just generalized granuloma annulae, psoriasis, lichen planus, HS hidradenitis suppurativa because of obesity, cellulitis, erysipelas, a lot of bacterial infection is always associated with diabetes. Diabetic foot infection, necrotizing fasciitis is a severe complication associated with diabetes that sometimes leads to amputation, gangrene, erythrasma, and malignant otitis externa. These are the common skin condition, bacterial infection associated with diabetes. Among the fungal infections, candidiasis, many times I diagnosed diabetes from the monilial balanoposthitis. Many patients come for the first time with monilial balanoposthitis. Immediately I told do a blood checking, fasting blood sugar and postprandial. We'll find 50% of the monilial balanoposthitis, when they come to us, I send them back and half of them have diabetes. They do not know whether they're having diabetes or not. Only from there, you get the marker, monilial balanoposthitis is a marker of early diabetes. Mucormycosis, lot of we saw in corona time, those who are having diabetes, many of them died because of mucormycosis. Cutaneous, now the medications, which are the drugs which can produce insulin, lipohypertrophy is a very common complications. Whenever there is a hypertrophy, better not to use that region for again insulin injection because that decreases the absorption of the insulin in the subcutaneous tissue. Lipoatrophy also can occur also. And lipoatrophy basically is because of cryotrauma of the refrigerated insulin. Okay. Oral medications, sulfonylurea, now nobody is using. Earlier we saw a lot of sulfonylurea photosensitivity is a very common complication, flushing, like chloropropamide and urticaria, erythema multiforme, erythema nodosum. A lot of people have during those days. SGLT inhibitors, there is increased risk of genital infections, urinary tract infections, as you know. And Fournier's gangrene is one of the rarest complications, total infection usually associated with SGLT inhibitors. DPP-4 inhibitors, as I told you, 3 days back, I saw a case who developed a bullous pemphigoid, acral region, bullous lesions. And in addition, they may have Stevenson syndrome, anaphylaxis, angioedema. Very, very rare, but always keep in mind, skin manifestation, cutaneous side effects can occur because of DPP-4 inhibitors. Biguamides, metformin, I've seen few cases of leukocytoclastic vasculitis, erythema multiforme, lichen eruptions with metformin, but metformin is a very good drug. As you know, everybody takes metformin, and very, very rarely it can produce some side effects. Regarding GLP-1 receptor agonist, that all know very well, Ozempic face rapid weight loss because of rapid weight loss leading to facial fat necrosis is very, very rare. Because it is a very good drug now, everybody is giving. It produces a rapid fall of weight income, whereas we give metformin, slow reduction of body weight, whereas this GLP-1 receptor agonist, certain decrease of weight that may leads to many times shrunken of the face, fat atrophy on the face, particularly wrinkling, sagging of the face. You must be a little bit careful because of rapid fall of body weight. So this is all by, but I think I finished in 15 minutes. Thank you very much.
Thank you, sir. Yeah. Okay. Thank you, sir. You cover everything, but actually day-to-day practice, we get cases of dermatology cases. Very common is actually itching. You all covered actually how the doctor worked to you and he told. But you see, when we get the cases, the vulvovaginitis or balanoposthitis, because he is already diabetes, that's why the case is confirmed with it and yes, you get very nice results. But when the patient is coming up like this, Do you comment or give your advice to viewers that all the diabetes patients, when they are having some problems, they will refer to dermatologist?
Yes, many patients come. Fungal infection, bacterial infection is very common. I always tell you have to control your diabetes first. Without controlling diabetes, otherwise they will repeatedly get the same infection, bacterial, fungal infection. You have to control the glycemic phase. Otherwise, you can't treat. We treat, but again, reinfection is always there.
You're right, sir, because when I was students, my professor used to tell me, medicine professor, when the patient is giving history that he's having itching, then you don't ignore it that because during when you're taking history, he's taken 3-4 times, sir, I am having these things. You should not ignore and you must important to that.
Yeah, another point I must tell you, when you are treating fungal infection, you must treat both partners together.
Yeah.
Because otherwise they'll get back the infection again from their partner.
Sir.
Either both of them are diabetic or one of the diabetic. So you have to treat both the partners. That is very, very important. Otherwise they will get repeatedly infection.
Thank you, sir. We are very grateful and for your nice deliberation. Thank you
so
very much.
Thank you
sir.
so much. Thank you. I must acknowledge to my postgraduate students who prepared this PPT presentation. Within 2 days, I gave the material, they prepared it. So thank you so much. All my postgraduate students, particularly Dr. Sadhvi, she prepared it yesterday and gave it to me today.
Oh, nice
Thank you so much.
presentation, sir. Thank you very much. Please convey to them. Thanks, sir.
Video.
Yeah. Next speaker is ours, that is in managing infection and complete diabetes, is Professor Jayant Panda. And he's known to each and every medical officers of this state, which was very active member during Corona time. And whenever you find any discussion or conferences, you'll find Jayant Panda is there. Otherwise, he is also known to each and everybody, those who are a member of RSI nationally. He is always, you'll find every year, he's a national speaker. And I would like to request actually, and about him, you all know, directly I'm just not taking your time because after 2 days of marathon discussion about diabetes and all these things, the fag end of the day. So I request Professor Panda to start his deliberation directly. Thank you. Please.
Chairpersons and the elite audience of Nucd, the National Update of Clinical Diabetes. This edition of 2026, we are dedicating to you for the updating of the knowledge and the care of our patients. Year after year, the Nucd gives the best of clinical diabetes, and I must congratulate the team Nucd for the beautiful work they have been doing for the last 12, 13 years, especially my mentors, Dr. Alok Kanungo and Dr. Ashok Das, who has been the backbone of Nucd program. I must salute to them before I start my topic. I've been asked to speak on managing infection in complicated diabetics. We know the immune system is altered in diabetics, and managing infection itself is challenging. And besides that, if in a complicated diabetes, a diabetic who has a kidney disease, who has a heart failure, who has different organ involvement in the form of MASLD or a stroke or a myocardial infarction, it still becomes challenging to manage. So very quickly, I'll give you an overview of the infection in the next 12, 13 minutes. And I'm sure you all will be benefited by this revision of management of infection. These all are from the RSSDI handbook on diabetes, where we have contributed the infection of diabetes and infection in diabetes monogram, which we have contributed for the cause, where an overview covers all common infectious diseases, especially in diabetics. We know that association between the diabetes and increased susceptibility to infection is though not supported by strong evidence, but many specific infections are more common in diabetic patients, like a emphysematous cholecystitis, like a emphysematous cellulitis, a emphysematous pyelonephritis, that indicate that there must be some glycemic disorder. A rhinocerebral mucormycosis is another infection which gives a clue to the diabetes. And you will not be surprised, like AIDS defining infections, we have diabetes defining infections, and some occur almost exclusively in diabetes. So other infections occur with increased severity, with an increased risk of complications. We know that the diabetic patient represent almost 1/4 of all who present with sepsis, the lower respiratory tract infection, the upper respiratory tract infection, urinary tract infection, and skin and soft tissue infection is almost 1/3 in the patients of hospital, which occur only in diabetics. And most of them present with wound infections, urinary tract infections, and pneumonia. So they are at increasing risk of tuberculosis as well. And the diabetics with pneumococcal pneumonia are more likely to be bacteremic or die from it. And asymptomatic bacteriuria is defined as more than 10 to the power 5, and you know it's very common in our patients. So if the patient is hypoglycemic, remember our topic, it's about the complicated diabetic patients. So if the diabetes is not controlled and the hypoglycemia is associated with increased infection and mortality, because all the studies which I'm showing here indicate that there is an infection, increasing nosocomial infection, surgical site infection, and in hospital 30-day mortality, poor functional outcome. And diabetes and the risk of infection-related mortality increases very much. It's a cumulative mortality related to infectious diseases, and almost Indian study shows 44% of the diabetic patients die of infection, which is much more than the events like acute coronary syndrome, that's around 31%. The factors predisposing are the genetic susceptibility to infection, altered cellular and humoral immune defense mechanism, the alteration in the metabolism associated with diabetes, and the local factors like poor blood supply and the nerve damage. So the immune system in the patients with diabetes is altered. The leukocyte function is depressed, leukocyte adherence, chemotaxis, and the phagocytosis is affected. Antioxidant system involved in the bactericidal activity is also impaired, and the cutaneous response to antigen challenges and measures of the T cell function is depressed. So this cartoon shows how the hypoglycemic immune response is affected, like decrease the immunoglobulin fixation and the complements, the decreased complement binding to the bacterial surfaces, decreased oxidative burst with the superoxide radical production, and then polymorphonucleus cellular adherence to the endothelium, the chemotaxis, the phagocytosis, and the bacterial destruction all are affected. So the pathophysiology from neuropathy, it's lack of protective sensation leading to the skin breakdown, also excessive pressure and the immunologic disturbances where the infection take place, and the peripheral vascular disease, decreased arterial supply, impaired wound healing, again lead to infection. And the cause and the effect of the hypoglycemia, they all decrease the immune function, increase susceptibility to the infection, and they all together are caused by the severe hypoglycemia. And these are the major infections which can be classified under respiratory tract, urinary tract, GI tract, skin, soft tissue, head and neck, and the other infections. They're associated with diabetes and especially complications. So starting with the cutaneous infections and the diabetes, we know the skin pH value is higher in diabetic patients, and the diabetic neuropathy and the angiopathy is responsible for the fungal, the interdigital spaces infection, the genitalia infection, and the skin fold infections. So many times these particular issues, they are causing the increased morbidity and mortality. So in type 1 diabetes, the most frequent infections are the viral wash, while the pyoderms were the most frequent cutaneous infection in the type 2 diabetes. The bacterial infections like gram-positive involving group A and group B streptococcus, necrotizing fasciitis, and the staphylococcus, the clostridium, the bacteroids are very common. And then the staphylococcus are gram-positive organisms that normally constitute the microbiota of the skin and they commonly involve folliculitis. Group A streptococcal infection is very common, especially the Streptococcus pyogenes, sole bacterial species responsible for a wide range of infection. And the study carried the risk of soft tissue and the skin infection contracted the group A streptococcus is almost 4 times higher than in patients of diabetes. Group B streptococcus again caused cellulitis, skin and soft tissue infections, and a study carried out shows it was found to be increased 11 to 30-fold in persons with diabetes in comparison to non-diabetic population. There may occur the staphylococcal infections, very common, the acute otitis externa. Again, this is an infection by Pseudomonas aeruginosa, which is very specific in the diabetic patient. And the causative organism, the vast majority of the cases, the acute form is caused by the Pseudomonas aeruginosa and the Staphylococcus aureus. The necrotizing fasciitis, you'll see, the compartmental syndrome, you'll see, and then any patient with even minor trauma have these infections among non-pedal soft tissue infections, and the fasciitis is characterized by polymicrobial growth, and study carried out by the Cheng shows the report almost common in many of the patients. Diabetic foot, you know, the patients, almost 1/4 of the patients have cumulative lifetime risk of the foot ulcers, and in 30 to 40%, 1/3 to half patients need amputation in 3 years in these patients. And all of you have seen the devastation of diabetic foot, which makes our patient incapable. Here it shows the foot ulcer, the flow of sensory, motor, and autonomic dysfunction, and the neuropathic foot ulcer pathophysiology, which results in the neuropathic ulcer and the ischemic ulcer, ultimately leading to the amputation of the foot. The complex interplay between the overlapping factors which contribute to diabetic foot ulceration are comorbidity, infections, biomechanics, trauma, the diabetes, the peripheral arterial disease, as well as the peripheral neuropathy. And this foot syndrome, usually the ulceration, the representing serious long-term complications, and ultimately leads to the amputation. The fungal infections we'll see in the diabetes, they're very common, especially the mucormycosis, aspergillosis, cryptococcus, the histoplasmosis, and eumycetoma. And the individual infections are very dreaded, and especially the rhinocerebral mucormycosis is notorious for causing even mortality, morbidity in our patients. So you know, it can be rhinofacial, rhinoorbital, or rhinocerebral, can be pulmonary, cutaneous, or the GI, and an urgent debridement and antifungals, along with control of the blood glucose and metabolic abnormality is required. Similarly, the aspergillus, the cryptococcus, the histoplasmosis, the eumycetoma, they all are responsible for similar fungal infections which are specific in diabetics. Other peculiar infections in diabetics are tuberculosis. We know the tuberculosis people have a risk of developing diabetes, and diabetics have a risk of tuberculosis. They need to be screened, and at higher risk of the patients, they have more likely to develop multi-drug resistant tuberculosis, and then the infection need to be controlled very fast along with insulin and antitubercular drugs. Remember, when we try with the oral drugs, it never get cured because of the hepatic enzyme system being activated with antitubercular drugs as well as the anti-diabetic drugs. The bacterial pyelonephritis, I told about the cholecystitis and pyelonephritis, which usually have the gas-forming organism, the emphysematous presentation. So they also present with the papillary necrosis, renal abscess, and emphysematous pyelonephritis. Perinephric abscess is also not uncommon. Emphysematous cystitis is also common. And the Fournier gangrene in most of the patient, the most common etiologic agent like E. coli, Klebsiella, Proteus, and the Peptostreptococcus, up to 70% patients with this infection are correlated to diabetes. The necrotizing pyelonephritis, where the peculiar fulminating form of necrotizing infection is seen, and then the renal papilla is demonstrable on the further investigations, the emphysematous cholecystitis, the periodontitis. Many diabetics are detected in the dental ward. It's a chronic inflammatory disease where it's characterized by the formation of periodontal pockets, loss of connective tissue, and the alveolar bone resorption. So HIV and the diabetic has a very common relation. In patients getting antiretroviral therapy, especially PI, more likely to develop glucose intolerance and HIV. And then many patients have HIV, they're diabetics, and both are immunocompromising conditions. And the risk factor for diabetes and HIV are high viral burden, low CD4 count, long duration HIV infection, advancing age, and as I told, treatment with highly active antiretroviral viral drugs. The treatment at times causes diabetes, and along with that, other viral infections like hepatitis C, the hepatitis B, and mumps, rubella, Epstein-Barr, and cytomegaloviruses associated with increased infections. We saw that during COVID-19, that the patients of diabetic had turbulent course, very poor course, and died very early with multiple complications. So summarizing, infections like respiratory tract infections, community acquired like pneumonia, urinary tract like bacterial cystitis, acute pyelonephritis and emphysematous pyelonephritis, perinephric abscess and fungal cystitis are common. We have to detect in time from clinical features, diagnostic procedures, detect the organism and treat the patient. The soft tissue like necrotizing fasciitis, the invasive otitis, external rhinocerebral mucormycosis, the emphysematous cholecystitis are common, need to be detected and treated, but hypoglycemia should be corrected. Avoiding problems with predisposed to infection, early and aggressive treatment is required. Finally, I'll tell you about vaccination. There are many vaccine-preventable diseases, and all diabetics should be vaccinated against influenza, against pneumococcal infections, against infections like HPV, hepatitis, the typhoid fever, and the even herpes zoster, which are equally important in them. And if you're controlling the blood glucose well, the leukocyte function, the immunoglobulin fixation, the nutrient delivery, the infection risk, the intravascular volume changes, normalization of coagulation, the increased blood flow to the wounds, and the improved response of the endothelial dysfunction all improve. Normalizing GFR, the improved wound healing, improved oxygen delivery, less electrolyte shifts, increasing growth factors, elevated free fatty acid and cardiotoxicity, and less thrombotic complications and skin fibroblast proliferation become normal. So, ladies and gentlemen, this is my presentation to tell you in a diabetic, the infection is common and there are specific infections like rhinocerebral mucormycosis, emphysematous cholecystitis, emphysematous pyelonephritis, necrotizing fasciitis, acute otitis externa, which are diabetes defining infections. So we have to detect early, treat them aggressively, control the blood sugar very strictly so that they don't become very severe, causing morbidity and mortality. And we have to prevent the vaccine preventable diseases. And in a complicated diabetes, especially with hepatic and renal dysfunction, we have to be careful in dosing, where the dose has to be calculated as per the kg body weight and the creatinine, and that can help us to control the infection even with lesser amount of the drug very effectively, and in long run that becomes very rewarding. So especially in a complicated patient who is more at risk of developing infection, we have to detect them, we have to intervene in their treatment and see that the patient pulls well with good glycemic control, good infection control, and allow them to just recover first by a conducive environment. I thank again to Nucd, especially Dr. Alok Kanungo and Dr. Ashok Das for this opportunity, and I'll be happy to take up questions, if any. Thank you.
Dr. Jayant Panda on the infections.
Most respected chairpersons and
close it now.
the elite audience of Nucd, the National Update of Clinical Diabetes, this edit.
Dear friends, you have just heard the talk by Professor Jayant Panda on the infections in diabetes, and he has beautifully said defining infections in diabetes. And I must tell you that large number of patients in our country die because of other complications, NCDs, hypertension, kidney failure, stroke, heart attack. But quite a large number of people also die of infection. That is why this talk is very significant. I will tell you one thing before I close this topic is that we had last week a case of EPN, that is emphysematous pyelonephritis. Believe me, dear friends, we are able to save maximum patients of EPN by a simple principle. It's I work in a medical college, multidisciplinary approach, and we have people who will put the stent and will do surgery. That's how we could pull out the EPN. So infection is paramount, widely prevalent, as Jayant has said, and we can do a lot. See, chronic complications, lot of expenses. But acute complicated infection, by proper antibiotic, proper multimodal care, team approach, we can do change and change the destiny of the patient. Over to Professor Alok.
As Professor Das has told, the first line of emergency textbook of Oxford says, in emergency, take help. Your pride may be fatal. So you have to ask people, team approach is the best approach for diabetes management. Whether it is routine clinical or it is emergency medicine. In routine clinical, you need the help of nutritionist, dietitians, podiatrist, food care specialist, everybody, and physical trainers in your clinic, and they must train everybody. So Nucd is coming to an end. Like every year, this is the 12th year. And as Mr. P.K. Das told yesterday, that 12th is a different number, occult number, and he's there, Dr. Das, Mr. Das. So that's really 12th is a very good number. And I want to, this event, academic event, was successful because of unconditional academic support by USB Private Limited. From the day one, US Vitamin has taken this as a personal challenge to the whole team, and they work as one united team to support Nucd to the last point. I thank Farida ma'am, Mr. Prasant Tiwari, Lina Tiwari, and all the members of the team, managers, and everybody on the team.
And 1 minute, Alok. The presentations of the sessions that they had, 2 sessions they had, was absolutely fabulous. It was very, very impactful. You remember this morning?
Yes.
These are very impactful lectures. So I also congratulate the team for the beautiful scientific material and well received in the packed hall. And as Alok said, we are extremely grateful to university.
Yes, and yesterday their virtual session was also excellent with the best of speakers from across the country. Novo Nordisk has been with us the day we started writing insulin, Novo Nordisk became our partner. From NNDU 1, I have been attending Novo Nordisk update, diabetes update, first update also I have attended until now continuing. I thank Mr. Vikrant Sotria, the head of Novo Nordisk India, who was also in our inauguration yesterday. And thank you, his team, Siva, and everybody. Sanofi is an international class apart. They have the best product. Whether they meet you or do not meet you, Lantus moves. Now they have Tugio and Soliqua. And Bibhu and his team have been with us for always with us for any support that we have needed. Thank you, Bibhu, and your team.
Today, their session is one of the high-end meeting. You know, it was so well attended, so well discussed. You remember? And
yes.
Professor Srikant there asked questions. We had a lot of discussion. Sanofi session was good.
No session was so much of clinically discussed.
Novo was excellent.
Novo was excellent.
You know, the presentation by the people who presented that was very good. On the semaglutide, it was a veritably, absolutely advanced session, and we have a lot of take-homes, and I'm going to carry the message to Vikrant.
And as if semaglutide has entered the minds of physicians and clinicians. Medley is a dear company, and with Rishi at its top and others in the field, Santosh and others, so they have been helping us very intimately. Boehringer Ingelheim, Mukti and others are there. Though their product had a lot of challenge, Glaxambi, still they are supporting us for academic purpose. I am thankful to them. Lupin has also helped us this year. 3 Dots is almost a personal group. Droyesh Jha is like my younger brother, and he has that regard for me. Kavita is here, whole team is there, and they are like a family company to us. And they are opening their new factory in April. And I think I'll be there to see how the one-man army, Droyesh Jha, has become such a big corporate company. Please convey my best wishes to Droyesh. And but he's not there. Kids Hospital, Mr. Prabir Mahanti and his team, headed by Saurav, the architect of this Nucd. I should say everybody give a standing ovation to Saurav for his wonderful work planning these sessions, planning. He came, when he came for the first virtual Nucd, he was straight from the UK, and international quality was infused to Nucd, and we are thankful to you for all details. Please. And all the staff members of Kids Hospital, Dr. Kanungo's Diabetes Center, where Subhasri is one of the senior dietitian, and she is managing this so well. I thank you on behalf of the Nucd conference. And Cuttack Diabetes Research Foundation is our education and research wing, and we have been doing many clinical trials and other research projects. Priyanka He's not, has he left? Priyanka is one of our chief scientific officer now. She is a PhD from Northeastern universities, excellent in her understanding of biology. So that she is helping us a lot in research. And media, press, everybody, Department of Electricity, our security people, everybody I want to thank. And biggest thank goes to my elder brother, Professor Dr. Ashok Das. Minus him, this conference can never become so successful.
I have no words, I'm wordless, speechless. I have enjoyed reasons that it's my passion. I must tell you that many meetings happen. But meeting in the clinical diabetes, which is targeted metros and also for the tier 2, tier 3 cities and the villages, it is addressed to the people who take diabetes. It is only one which addresses it. These 10 sessions have captured, as we told, as Alok said, the latest, evidence-based, fabulous clinical practical tips and very interactive session thanks to Saurabh, who started the idea of interview followed by short talks and then 45 minutes, 30 to 45 minutes for the interaction. Dear friends, we promise you that we will not fail in our endeavor to bring more and more such meetings of Nucd to you. Priyanka has arrived. Priyanka is here.
We are praising you for your continuous support in the science and field of academics and in Nucd. Thank you.
Lot of efforts has gone into it. She used to connect with Alok every day evening, and Saurabh will put all the things in the messages. Good, beautiful messages. You know, the youngsters today message that is so absolutely fabulous. So I assure you that on behalf of the kids, Dr. Kanungo and his center and the team Nucd, that we will strive to make it bigger, better, more useful. I must thank my friends for the projection, for the slides. Not a single slide went wrong. Big round of applause to you, sir. And we have worked together for how many years now?
Samim, we have worked together for 12 years.
12 years. So it is
day
great.
one, he is there.
Thank you very, very much.
And
not
he
a
is
single
there
slide.
and we are assured.
Yeah, not a single slide went wrong. I must see everything went absolutely
And
fabulous.
Friend, he is there also always. Today he has done a lot of work. Thank you very much.
And
to both
we
of
assure you, it was great when it started. Over 12 years, there has been a continuation. We assure you, we'll take it to bigger and bigger and bigger heights. The mountain has two slopes. One way to go to the top, the same can bring you down, but that will never happen for Nucd and Dr. Kanungo. With God's grace and his love, grace and blessings for Nucd and for Dr. Kanungo kids.
Brigadier Behra is my elder brother. In spite of his not keeping well, he has been sitting from the morning. He has a military spirit, decision, and ethical practice. So we are proud to have him with us.
He remembered, he met me in Chennai in one of the meetings, and he was remembering that. I'm so happy, sir. And I must tell you that everything has to come to an temporary end, and the end is the beginning, new beginning. So even though we are doing valedictory function, before I hand over to my very dear Alok to give the last words, I must tell you that is our solemn promise. We'll strive to make it bigger, better, more closer to you. And you know, the industry partnership, we're so close to you. There is nothing. It is a closeness between you which makes us happy. And we put on record this closeness. Thank you very much. Over to Alok.
Thank you, Kishore. You were once a part of us, and now also you are a part of us.
Kishore is one part of us, absolutely.
He was with us, and he started the hospital along with me. And
Really?
Because he joined AIMS, he cannot do private practice. So, but he's doing research, great research. So Maybe in India on sarcopenia, he is in the one of the top list. So thank you for being there. Congratulations. And photography, you have taken more photos than we have desired. So kindly give us all those. And Saurav, you are there. Our social media and all participation, our IT man, gentleman, everybody is there. I don't want to take more time. I'll request Subhasri to close this session.
As we come to the conclusion of NUCD 2026, I would like to thank each one of you for being a part of the enriching scientific journey. Over the past 2 days, we have witnessed meaningful discussions, shared expertise, and collaborative learning across the entire spectrum of diabetes and metabolic care. I extend my sincere gratitude to our respected speakers and chairpersons for their valuable insights and guidance, and to all our delegates for their active participation and engagement. We also acknowledge the invaluable support of our industry partners whose contributions have helped make this session exchange possible. Our heartfelt thanks to the scientific committee for curating such a relevant and high quality academic program. I would also like to specially thank RX Events and the local audiovisual team, the stall organizers, and the entire organizing team.
RX event requires a special mention. They are this nerve center of this conference. They have been transmitting and doing everything. Hardik and we are Stuti, everybody, Jignesh, all, and Hardik's wife, everybody is important. Nilam Chandrana.
As we conclude, we hope that the knowledge gained here will transfer into improved clinical practice and better patient outcomes. With this, we officially bring NUCD 2026 to a close. Thank you once again. Have a safe and pleasant onward journey. Thank you.
Everybody, please come to the dais. We will take a group photo. Yes, sir. All of you, please join. Please, all of you, please come, including Professor P. K. Das.